schermo viola. Non vedi nulla?
Aspetta. Clicco sul link, mi dà questo video non è disponibile.
Io sto streamando adesso.
Vabbè, non è detto che vai istantaneamente.
Sì,
online
no, no,
per
certo,
utente.
certo. Partecipanti, toggle, edit, stream setting, dove sta sta cosa?
Qualcuno? No, vabbè, niente, tanto non mi serve guardare. Qua. Riclicco, sono riuscito, riprovo, niente. Sempre così.
Video non disponibile,
Della Juve, tutto bianco nero.
prova a dare un link ci accedo. Magari tu devi magari mi sono sbagliato io, Io da 1 minuto e 25.
Ah,
Ma lo sai qual è il fatto? Scusami, posso dire una cosa? Guarda la differenza. Guarda, questo è il primo, questo è il secondo. E prima è sempre stato così, pure quando gli hai fatto le cose e tutto. Guarda, mi dai quel video, non va bene. Che video? Quella live che hanno messo. Scusami, come si chiama questo canale?
Stacco un attimo questo computer che sta iniziando, ma non è po'.
Secondo. Che te mando? Quello, scusa, vai all'altro canale, all'altro coso. Dal canale. Eccolo. Ecco, l'hai sbagliato il link, te l'ho detto. Che senti?
This is the wrong link.
Mi parli al microfono?
prova.
L'importante poi è che lo fai presente quando arrivano i
Oddio.
che non mettono più.
Io non ti ho sentito.
Prova test.
Magari riescono a fare.
Possibile, non è possibile.
Lui sta streamando da 4 minuti. Tu, quello che
È vero.
sento da 4 minuti.
Giovani,
Trovatemi
un posto sotto per questo.
Ecco.
Quindi aspettiamo 4 minuti e vediamo se si
Però sto streamando di meno.
Trovami un posto.
sì, per dire la quantità
Sì,
di
sì.
notevole.
Guarda qua. A posto.
Mettilo là vicino a noi. La penna là, sopra. No,
Non sta sopra.
No, vedi, te dovevo sentire perché non ho fatto guarda lì. Vedi, e non ti sento. Non possibile farmi in modo.
Può essere pure che ti stai antipatico, ecco perché invece... Prova, test.
Prova.
Devo fare una...
No, non mi fa niente il monotono.
Che alla fine ci siamo sempre noi dietro. È come guardarsi allo specchio tramite un travestimento, insomma.
Che volete oggi? Io non ti chiamo nessuno.
Dai.
Johnny.
Ma in realtà...
Ecco, le cose normali.
Prova.
No, non è possibile perché lo sto mandando là. Ci dei colleghi dal telefono. Non è possibile.
Però mi rimane lì.
Non vedo da solo, da qua.
Che ora finisce domani stai?
Alle 6:30. Vivo.
Domani 7 e mezzo, dopodomani 6 e mezzo.
Sì.
Più o meno.
No, 6:45.
Ah.
Domani.
Speriamo.
Dicono.
Vabbè, se
siamo
no...
così rigidi, sì.
Quando hanno il timer così rigido, sono così tanti perché sono decine, cioè, 2 giorni sono 50 persone, mi sa, quindi non possono accumulare, insomma, non possono, penso saranno molto rigidi con il timing.
Sì, no, ha detto che come scattano ora bisogna mandare
No,
subito.
no, sì, esatto. Infatti, pure per quelli che mandano i filmati da remoto, se suscita l'interesse,
Prova. Test, test, test.
avanti.
Vaffanculo.
Ho capito, questo non
No, non sei idee, sto un figlio del merda. Ma no, raga.
Versi un attimo il computer di Zoom.
Ah, siamo lì così.
No, vabbè.
Vabbè, dai, sti cazzi. Mi sono sbagliato io, pensavo che c'era...
Anche perché poi a me hanno chiesto domani,
Posso.
domani finisce alle 6:30 il programma.
Alle 7 mi pare.
Allora, aspetta.
Perché a me hanno
Guarda,
Domani alle 6 e mezza.
guarda il coso, Ale.
perché a me hanno chiesto, pensa, di essere operativo all'hotel della Minerva per la cena sociale a partire dalle 7 alle 7 e un quarto, quindi
Allora sì.
no, si fredda tutto.
Che lo vuoi fare?
Là.
Va bene. L'hotel della Minerva qui ci vuole
No, sul telefono, la messo via.
mezz'ora buona ci vuole.
Rivielo.
Noi domani non siamo ospiti loro al pranzo.
Implants and anaplastic large cell lymphoma. As a way of background, the signals coming from 2008
Come si vede più che altro?
on a new entity
Mettilo
which
a
was
sottoscrivere.
linking lymphoma and breast implants become maybe one of the first regulatory reactions by the US FDA Food and Drug Administration publishing on their website about a possible association between the breast implants and the development of anaplastic large cell lymphoma. Then in 2016, the World Health Organization introduced in its classification of lymphoid neoplasm a new provisional entity called breast implants associated anaplastic large cell lymphoma. In EU, in the end of 2012, a task force was established by the member states with the participation of the European Commission in order to try to deal with this new emerging entity. 12 member states plus Switzerland and UK, together with Commission,
Diciamo così, però.
I nomi al...
Potremmo andarsene a casa, secondo me.
Prova.
È o non è mifrate?
Test.
Pensaci.
Però non so chi è fratello.
Prova.
Cioè, non so chi fa il punto di partenza, capito?
Che cos'è che
Quello è lo
parla? Quello là parla, vedi? Quello.
Perché senti da qua? No. Firmene.
Sì, è quello là che parla.
Tutta a posto.
È zoom.
Firmene. Bello come non mi fa entrare su Zoom lo stesso.
Allora, poi.
Eh sì, ragazzi, purtroppo. Se le fatti è la stessa sostanza al pane.
Picchio, poco rosso. Poco fuoco. Posso levare l'audio o lo devo tenere?
Allora, tu adesso devi andare di fuori, accendere il microfono e parlare in sala.
Ciccio, aspetta, io ho l'attenuazione, sta l'attenuazione. Cioè, quello che volevo dire, attenuazione, vuol dire il massimo che possono fare i zoom dal minimo che possono fare ogni sistema. Se invece vado a fare la predizione per l'SPL che mi serve in sala,
Vitto, tu vedi le note là nello schermetto piccolo, vero?
di avere a fondo sala.
Sì.
Ok.
Sì. No, vabbè, mi ha cacciato fuori. Quindi dovrei averlo, no, mo di là c'ho il desktop di Picchione.
Seduto.
Lì su quella console, l'unica cosa che dovremmo fare è switchare tra quei due pulsanti.
Vabbè, mo che esce finisce il loop.
In base a quale PC stiamo utilizzando.
Ok.
Se attaccano quello là, le note non ci stanno, quindi tu là sopra non lo vedi.
Allora, a te come ti arriva? Michele? A te ti arriva qualcosa da lui? Aspetta. Allora, mi devi alzare zoom.
Vai, alza un po'.
Vai.
Prova. Mi senti? Eccolo.
Vai. Parla.
Mi senti? Prova.
Aspetta, che se no qua impazzivo.
Prova.
Vai.
Prova.
Ok, tu mi senti? Mi senti bene o male?
Ti sento l'audio del telefono.
Ma mi senti bene?
Ti sento basso.
Ma questo
Poi
Ragazzi, sta parlando lui.
spostati fuori là.
Dai, infatti devi uscire, Ale, devi uscire proprio. E parla, tanto ti sento.
Raccontaci una storia.
Cappuccetto rosso.
Mi senti?
Sì.
Ti torna zoom sul microfono. Guarda, prova così.
Mi senti?
Tu non lo senti però. Vai.
Mi senti? Io ti sento bene, tu mi senti bene?
No, io mi sento basso.
Ok, aspetta. Mi senti adesso? Meglio?
Sì, basso.
Ok. Aspetta, sì. Aspetta, Ale, aspetta.
Fallo aspettare un attimo.
Sì.
No, ma comunque sono masso, cioè, vai a buon livello, cioè, no, guarda. Vai. Dio, livello.
Mi senti adesso? Mi senti bene? Sempre bene mi senti? Io sto parlando male, lontano. Ok. Allora, adesso... Aspetta.
Sì.
Michele, adesso io devo mandare un video da VMix. Quindi se mi alzi VMix, vabbè.
Good afternoon, everybody. My name is Paul Piston. In order to try to deal with this new emerging entity, 12 member states plus Switzerland and UK, together with Commission,
Ah, no, c'hai ragione. Te credo, non ti arriva nulla.
joined to exchange all the information that was
Perché da lui si sente
available
bene.
at that time,
Adesso
to pull
si
the
sente
data, to cooperate with international regulators. So far, we discussed many times with USA, Canada, Brazil, and Japan to share information on national measures and to discuss and coordinate national regulatory measures. The last two bullet points are separated. The delivery of public health measures strictly the duty and falls under the competency of the member states. Some highlights of this task force include many teleconferences between the member states and with international regulators, the cooperation with the European Commission scientific panels, and I will describe that in greater detail later.
Ne senti una adesso, no, Ale?
And provision of data to one of the scientific committees of the European Commission. Then also we participated at science.
Lo senti una volta sola, giusto?
No, si sentono 2 volte.
Sempre 2 volte.
Riprova.
Scientific discussions and regulatory consultations in Amsterdam, in Paris, and today in Rome. When discussing about the interaction with SCIR, which is one of our scientific committees,
Una volta,
in
giusto?
2017 we received
Una volta sola, lo senti bene?
advice linked to the status of available scientific information on BIA-ALCL at that time, and what the conclusion was that a more in-depth evaluation was recommended. So, within the task force, and also largely with the member states, we came up with a
Esatto. Te me l'hai chiuso là, già era giusto. Ok. Perfetto.
Ale, mi puoi fare un piacere? Cambi il nome tuo in cellulare? Perché io sto diventando matto.
Ah, qua aspetta, ecco che...
Questo può rimanere.
Sì, no, l'unica cosa che dobbiamo fare è... Condivide la telecamera. Così non... porca via. Vabbè, sì, sì. Ti ha cambiato? Ok. Allora, tu adesso mi senti bene da lì, giusto? Ok, parla tu.
Se io ti apro il microfono sotto la cassa, o te ne vai.
Ale, devi uscire, mi dispiace, scusa, mi devi uscire, dai, fammi una cortesia. Se ne andiamo così almeno, dai. Ok, mi senti, no? Io ti sento, mi senti? Ok, perfetto. Io adesso ti rimando il video e mi dici come si sente.
mandate that Mr. Wim de Jong will describe later. And in 2021,
Una volta sola, no?
the committee delivered an opinion, and I will...
Quindi questo è ok. Allora, in sala se devono sentire il microfono, i video e Zoom.
Tutti i microfoni, PowerPoint, Zoom in
Sì, sì.
e VMix.
E avevamo provato tutto, giusto?
E
Ok, te trovi, no?
faccio un volume al timer.
No, a me non deve arrivare in videoconferenza il timer.
Però faccio un volume della sala
Quasi,
per fare
quasi,
pipì.
sì.
Mandaci un po'
Te lo...
Mandaci un
Rientra, Ale. Oh. Ciao. Prova, prova, prova. Test, test, test. Ok, arriva. Là, tu c'hai l'audio aperto là. Non ti preoccupare. Sì, chiudilo quello, certo. L'audio in uscita, Ale. Gli altoparlanti. Sì. Questo è?
Ce l'hai il programma in PDF?
Quello là c'ho in Excel io.
Te lo scarichi dal sito? Così lo facciamo vedere mentre parlano loro?
Sì.
All'opening?
Dove sta che sito?
ibsv.it. Sì, sai, capitavo sempre.
Program, no?
Si autochiude quando... No, là non ce l'abbiamo messa perché diventa un casino attaccare e staccare. Abbiamo 200 presentazioni. Ti devo mandare...
Come... Io sto sul sito, program vado, no?
Program, lo
E
scarichi e lo fai vedere mentre loro fanno l'opening e parlano.
come lo scarico però? Cioè c'è un link, qualcosa?
Se scrivi sul nome.
Free streaming, international shop, non c'è niente io.
Te lo dico, professore.
Program. Eccolo là.
Solo una cosa, Mario. I relatori sono gli stessi del programma, ma cambia l'ordine del pomeriggio. Che tu
No,
sappia.
perché cambia l'ordine? Non c'è nessun
Mi hanno
ordine.
detto una cosa del genere. Mi fida di te.
No, il programma è... Non
Allora vado tranquillo.
Chi ti ha detto che cambia il programma?
No, mancavano alcuni medici, non
Mancano
sostituiti.
proprio?
Sì, non c'hanno più dato.
Che vuol dire cambiano?
Mancano cavalierini, quindi?
Non è possibile.
Ok.
I nomi li devi mettere, no? Li metti tu là.
No,
Li
perché
controllo subito.
ieri ci avevate detto che questi due non c'erano.
Ma sì, in quelli che non ci sono te lo dico, fai cambiare anche uno.
Ah,
Quello delle 17.
Quella tua.
Si chiama James Mark Diarmid.
Quella?
Mo te lo dico io. Tanto arriviamo fino alle 17. Compiliamo la prima sessione.
sì, quello sì.
Ti devo mandare una foto, come te la posso mandare?
Dropbox.
Sicuro?
Sì.
Ok, la devi mettere, il professor Clemens comincerà, gli fai vedere il programma e lui lo facciamo scorrere giù e lui dice oggi si parla di questo, di questo, di questo, di questo, di questo e dopo predichiamo questo.
Ok. Gioa? Qua ci ho messo il programma, è in PDF, non me lo legge come X, quindi me lo devi mandare a te da un computer e io poi lo mando in diretta. Ok?
Programma.
È un programma.
Ma è una cosa che non manda di
No, solo inizio.
manda anche dopo.
Mi senti se ti senti il video? Te già senti roba in realtà?
No, io no, se tu cavolo.
Niente.
Nulla proprio da qua.
Programma IBS, PDF.
Non ci sta proprio l'uscita se non siete sicuri, mica l'avrete.
Non senti
Allora,
niente?
ti ho messo l'immagine su la cartella generale Virtual Talk,
Ok, eccola qua.
ce l'hai il logo del prossimo
No,
congresso?
quel logo giusto.
Non ce l'ha manco qua per il PDF, non ce l'hai non puoi leggere da Google Chrome.
Sì, però da VMix io poi mi dovrei
Lo
prendere
puoi
me
anche
stesso, è
mettere
un'altra
direttamente
cosa.
dal sito, tanto te l'ha aperto sul sito.
È un po' più complicato perché io ho un programma diverso, capite?
Se no lo apri sul Mac con preview, no? E lo prendi dal Mac.
Io sì, lo posso prendere da tutti i computer.
Vedi che così lo vedi?
Sì, perfetto. Senti niente?
E vogliamo aprire YouTube?
YouTube è aperto,
Cioè si sta trasmettendo?
sta trasmettendo.
E allora non mettiamo là cose che si vedono su YouTube. Che se no si crea casino, lascia solamente Google Start Stop.
Questa qua.
Allora, se viene qualcuno,
Chi è?
ragazzi, se viene qualcuno che vuole provare le PPT prima che vadano in onda,
dobbiamo dire che le può vedere soltanto sul monitor di servizio, non su quello grande, perché quello grande è già in onda, quindi lì non
Se no le fate sul computer direttamente, se non si può fare da nessuna parte, quale vede il suo poi? Perfetto, siamo online. Questo non vogliamo che sempre, siamo qua aperto. Quindi, chi ti manca dalla prima sessione? Tutti.
Implant-based breast reconstruction. During the course of this talk, you'll see some implant.
No, ma era su Zoom era.
Perché il podio sta un po' al buio.
Su YouTube so, ma è di su Zoom che non si sentiva, ma perché io devo attivargli una cosa.
Pure sulla telecamera c'è lo scudo.
Ah, ok, scusa.
Chiedo scusa, per le riprese, dice Vittorio, sarebbe meglio accendere anche la luce da...
Perché si vendono...
È un po' più scuro.
Apriamolo così, vediamo se non si dà fastidio sul monitor.
Matti adesso dai la roba.
L'ha presa?
Da Mumix.
Greetings. My name is Dennis Hammond, and I'd like to take this time to share with you some thoughts I've developed regarding fat grafting in immediate implant-based breast reconstruction. During the course of this talk, you'll see some implants from the Mentor Corporation, as well as from Establishment Labs, and ADM from the Musculoskeletal Transplant Foundation. So fat grafting has been introduced for breast reconstruction. Initially, I was very...
Scusami, hai ragione.
Good morning. Welcome. You have a PowerPoint or no?
Mi dà fastidio la luce sul monitor.
Quando hai sentito il... Prova, test.
Se andiamo con le telecamere. No, perché quello si spegne, giustamente si spegne le sezioni.
Prendi quella delle 9?
Se no così abbiamo...
microfono, senti cosa, senti qualcosa?
9:45.
Questo è disattivato proprio, sto parlando.
Ma tu senti qualcosa?
No, ma non penso. No. Sì, sentivo una cosa.
9:45. Te la fa vedere lui qual è.
No, ci voleva sentire per domani.
A me mi mancano i video.
Prendi, dopo ti dico io a che ora sono.
Ti posso chiedere dei video se li vuoi? Se li vuoi vedere un attimo, solo che sono tutti,
Prova, prova, prova. Io mi sento.
Incredibile. Ok, Salgarello 840.
think we can start. Hello? 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 Can I have the light? Posso avere della luce? Posso avere della luce? Vedi te. Buongiorno. Welcome. Good morning. I'm pleased to open this meeting, one of the first in presence, thanks God. And I want to remember a saint that was doing to serve the other is the fee that we should pay to have a place in this world. That was Muhammad Ali. I'm sure that when Muhammad Ali said that, he didn't know him, but he probably meant one of our greatest friends, Brian Todd. Let me take the opportunity to celebrate this moment in his life as a man and as a plastic surgeon, assisting anyone who was passing by him, patient and friends. He is a master, it's not what, he is a master in treatment of craniofacial anomalies and breast surgery. He was the first describing the cosmetic nipple-sparing mastectomy, which we are going to talk a lot today. So I ask you please to stand 1 minute in silence for Brian Todd. Thank you. I would like also to thank all the sponsors. Thanks to their generosity, we are able to arrange the meeting in such a difficult period of time. Supported and endorsed Center, the American Association of Plastic Surgeons, European Society of Plastic Reconstructive and Aesthetic Surgery, European Association of Plastic Surgeons, Croatian Society of Plastic Reconstructive and Aesthetic Surgery, Czech Society of Plastic Surgery, Hellenic Society of Plastic Reconstructive and Aesthetic Surgery, Hungarian Society of Plastic Reconstructive and Aesthetic Surgery, Polish Society of Plastic Reconstructive and Aesthetic Surgery, Società Italiana di Chirurgia Plastica Ricostruttiva ed Estetica e la Società Italiana di Microchirurgia. We got such a large endorsement, we are very happy. So I wish you enjoyed the work and the meeting, and I introduce you, and I leave the microphone. I don't need to introduce Mark Clemens to you. Thank you very much for your work and attention.
Thank you so much, Fabio. And I just want to say welcome back. Which feels absolutely incredible. I know for me, it's been almost 2 years since I've been able to be back in Europe, and it's so nice to see so many faces that we've just seen over Zoom chats for the last 2 years. I like that Fabio opened up with a quote by Muhammad Ali, and as we are now at the 208th birthday of Giuseppe Verdi this weekend, I'm going to open up with a quote of Verdi, which is, you can have the universe if I can have Italy. And I couldn't feel more alive and just so happy that we can be back together with friends to celebrate our research and share what we've learned over the past couple of years. This meeting is incredibly special because it's bringing together over 50 faculty members, 52 faculty members from 13 countries, which means that it truly represents its name as an international breast surgery workshop. It's in its 7th year, and we combine it this year with the 3rd World Consensus Conference on BIA-ALCL all day tomorrow. We are joined not just in person, and I know that we had to be a bit limited because of COVID restrictions in person, but we're joined by over 1,300 registrants online, which is an absolute conference record. And so thank you so much for your interest, for being here today. I want to say the way that the schedule will break down today is all of our speakers will be talking about breast reconstruction in the beginning. We will then go into autologous reconstruction. We'll go into hybrid augmentation and all aspects of prosthetic reconstruction. I'm really excited to see some of the new technologies and surgeries that we're going to present to you in the afternoon. And then tomorrow, we're going to take a deep dive into breast implant ALCL, looking at the latest treatment strategies, as well as latest research on pathogenesis. And then we're going to hear from our government authorities from across Europe on this disease and find out not just what's happened recently, but what's coming in the future. I want to end on just thanking Fabio Santanelli, who has been absolutely an amazing partner in putting on this conference, which is truly extraordinary. I also want to thank Michael Sorotos, who's been incredible in the organization of it. You'll see him running in the background, never taking a breath, as he has just been really the backbone of this meeting. I want to thank Diana Marshak and her company as well, that has been the absolute epitome of professionalism in this very difficult times. And also, I also want to invite you, as we'll do at the end of the conference, but I want to invite you not just to this conference, but to next year, when we return to Houston, Texas, on September 30th for another 2-day conference. This will be the 8th International Breast Surgery Workshop combined with the 4th World Consensus Conference. That's amazing to actually say out loud that we're into our 4th year. It'll be on campus at MD Anderson Cancer Center. We're going to have world-class faculty, not just from MD Anderson, but the United States and around the world. And I hope you'll join us there as well. So without further ado, we'll turn it over to the very first section, which is prosthetic and hybrid breast reconstruction. Our moderators will be Michael Atlin and Dr. Cagliati and Dr. Parodi. If we could have them come up, and we'll have our first lecture by Dr. Salgarello. Thank you.
Thank you so much. I have to thank especially Fabio Santanelli di Pompeo and Mark Clemens for the invitation. I'm very happy to present my experience on long-term outcome after pre-pectoral breast reconstruction with complete Suine ADM. Thank you. So this is my disclosure. And as we know, implant-based breast reconstruction accounts for the vast majority of breast reconstruction following the American Society of Plastic Surgery 19 statistics, over 80%, performed as two-stage, 82, DTI 18. And ADM is both used in pre-pectoral and submuscular placement. Why? Because it facilitates submuscular reconstruction, pre-pectoral reconstruction, also enables the placement of tissue expander with significant field volume, and mitigate, we think so, we will see, capsular contracture. And I want to remind the animal-derived ADM as the only one allowed in Europe, and that pre-pectoral reconstruction started in 2012 with complete porcine ADM covered Braxton device, which was at the time the only one used, and is an Italian device and definitive implant, and was published 2014. That's the beginning of our story. Then many ADMs have been introduced after this one. And so we had Stratis nowadays, Alloderm, and HADM, Surgimen, the Flex HD, Exaship, and many others. So if we search on PubMed, after the first publication by Berna and Simon Catworth in 2014, there are many, many publications describing the advantages of the pre-pectoral reconstruction. Complications, of course, they are our primary concern related to ADM, especially we are concerned about seroma, infection, and to failure. There are, of course, non-ADM related complications. And the avoidance of complication continues to be the major factor in surgical and institutional decision making. This is a very recent multi-center prospective randomized controlled clinical trial comparing two human ADM, and we focusing on seroma and infection, and we see that obesity and pre-pectoral placement are at greater risk of complication. So the benefit, pre-pectoral versus submuscular. Pre-pectoral, of course, we know it results in lower pain intensity, upper limb functional advantages, of course, avoidance of animation deformity. But also contralateral symmetrization need is reduced, 18 versus 84%. And also pre-pectoral breast reconstruction demonstrates an economic superiority. This is the study by Catellani showing that the economic superiority is not only versus submuscular two-step procedure, but also versus submuscular DTI. This is my story. After the first publication, 2014, I embraced the idea of pre-pectoral breast reconstruction. I did my first case of pre-pectoral, pre-shaped ADM, total ADM coverage, and anatomical implant. Then I have personal experience of 6 years. I did and I did almost 500 breasts, and nowadays is my current technique. But in 2020, I participated to the IBAC study, a big multicentric study with 1,450 pre-pectoral ADM. And this is my first case, 2015. She underwent a bilateral nipple sparing, and the mastectomy specimen weight was 295 grams, thickness of the mastectomy flap 1.5 centimeters. I did the total ADM and anatomical implant, and this is the patient after 6 years, Baker 1B. And this is the patient year after year. And I can appreciate the natural result. So basically, we have two possibilities, the old device and the new one, but due to the pre-shaped design, we have a technique very much standardized. It requires some suture to complete the implant cover. It is called ravioli technique. I want to remind it's a nice term. And anyway, it's fixed on the pectoralis major, then with the quilting suture is fixed to the subcutaneous layer in order to reduce the dead space. This is our experience. We did this retrospective study in 65 patients with this technique. 90% were nipple sparing. 5 patients underwent post-mastectomy radiation treatment, and I focus on early complication, but especially on the late complication, over 1 month in terms of seroma, infection, red breast syndrome, stripling, displacement, implant rotation, and especially capsular contraction and implant extrusion. This is the patient sample. And let's go to the need of contralateral symmetrization. 27% in our hands. This is a patient with right nipple sparing mastectomy, pre-pectoral reconstruction with total coverage ADM and definitive implant, no surgery on the contralateral breast, and this is the result after 2 years. Nipple sparing, skin sparing, both were well done with this technique. This is a case of nipple sparing on the right, skin sparing on the left with this technique, and this is the post-op. This is another case. I want to show that is very acceptable technique for skin reducing as well. She was submitted to skin reducing mastectomy, and with vertical pattern, pre-pectoral complete ADM and implant, and this is the result after also the nipple areolar reconstruction after 5 years. Very natural result. And then focus on complications. The early complication, 10% of wound adhesion, 10% of infection, and a lot of early seroma. So we started to monitor this patient very closely with the ultrasound and evacuate the seroma as soon as possible, and our complication rate reduced a lot. Late complication, infection 6%, late seroma is very uncommon, implant loss 10%, rippling 9.5%, few displacement, and 16% of capsular contracture. I want to go on. Let's examine the infections. We, of course, in these cases, did intravenous antibiotic treatment. The outcome, recovery in 5 cases, 1 implant extrusion. This is one of these infections. She got infected after 3 years, and she became Becker 4. Then we did just 1 fat graft session, and she is Becker 3 after 1 fat graft. Then implant loss, 10% of implant loss in breast without any post-mastectomy radiation treatment. The causes, infection, male infection, dehiscence, and 1 case cancer recurrence. Replacement in 4 cases in 6 of 10, and we did tissue expander, pre-pectoral implant again, or flaps. And 4 patients didn't wish any replacement. This is the case that I showed before. She get infected after 3 and 5 years, fistula, explantation, no replacement, the patient doesn't want. But this is another patient, infection, explantation, 1 fat graft, and then the late pre-pectoral with complete ADM again, on definitive implant. And this is a patient after 3 years, and she recovered very well. Rippling and displacement. Rippling is not that common with this technique, just 9% of patients. We did fat grafting. In case of displacement, the patient required Taylor capsulorrhaphy to resolve this patient. This is a focus on rippling now. She is, after previous breast augmentation, needing a unilateral nipples-sparing mastectomy. We use the complete ADM and implant, pre-pectoral. This is the result. On the left, we have some wrinkles. Okay, fat grafting, and she's the patient after 2 years. Another patient, very thin, can be a limit indication, 0.7 centimeter the thickness of the mastectomy flap. Of course, we have a lot of rippling, 2 fat grafting, and this is the result after 2 fat graft and 3 years post-op. This is 1 displacement. After 3 years, the patient doesn't want any treatment. And now we focus on capsular contracture. The follow-up, I remind, is 1 to 6 years. So the mean follow-up is 4 years, 15 cases, 16%. And these are the cases, Becker 3 and 4. Most of them because of previous infection. And this is one of these cases. She is, was submitted to bilateral nipples-sparing mastectomy and pre-pectoral reconstruction with complete ADM and implants. And after 4 years, she is Becker 1 on the right, Becker 3 on the left side. And, but if we focus on our results, I think that the results are very good. Becker 1 and 2 in 84% of cases, and very high patient satisfaction at the breast Q in all of the domains. About the post-mastectomy radiation treatment, we have a very small patient sample, we know, but very good results. This reconstruction is very protective toward post-mastectomy radiation treatment, as we can see from this slide. This is one of our case, bilateral nipple-sparing. This reconstruction, radiation treatment on the left breast, then we did 2 fat grafts. She's Becker 1 on both breasts. This is another case. This reconstruction, post-mastectomy radiation treatment, seroma infection, but she recovered very well. She Becker 2 now. And this is the end. If I compare with the data for the IBAC study, we have a higher rate of capsular contracture, probably because of the length of our follow-up. The obesity is not an issue, doesn't increase complication. Have a look on this result after Becker 1 after 3 years. These are my conclusions. We retrospectively analyze our experience, and I think this is one of the longest follow-up time ever reported. Early complication, we need ultrasound post-op surveillance. Late complications, 6% infection, 10% extrusion, 16% capsular contracture rate, probably because the length of our follow-up. I think that our results are good, and thank thank you very much for your attention. I want to remind that total coverage, it was extremely innovative, and it remains a milestone in my mind. Thank you very much.
So, as the moderators, you have 4 minutes of discussion if you want to discuss the subject. Yes. No?
There are some questions for... Second question.
Thank you. Can you hear me now?
Yes, yes.
Okay. The first question is, did you have any case of red breast syndrome? The second question, wound dehiscence was at 10%, and implant loss was also 10%. Does it mean that you had to remove all the implants with wound after wound dehiscence?
Okay,
thank you.
Very good. Thank you for this question. And about the first one, in this experience, with 95 cases, 95 breasts, we had only one case of red breast syndrome. I think there's a very low percentage. That's the reason I didn't mention. Really, only one case in a diabetic patient. So very, very peculiar patient. About the second question, you have to account the sum of the problem in early and late. All of them get this percentage. So it doesn't mean that I had to remove, but some of them come from infections. So it's the sum of early and late complications. Very few, if I remember well, only 2 or 3 cases.
Other question in the audience? There is one.
I don't want to discuss your lecture because my lecture is with the same topic. The question is regarding the change of the plan that we are using more and more. Which are the indication of changing the plane, radiotherapy, no radiotherapy, thickness of the skin, and of course, as I hope we will publish together, the seroma formation is higher when you use the total coverage of the prosthesis changing the plan.
Yes, thank you. And I start from the last. And as I mentioned, we get used to do the ultrasound examination by ourselves. And that's a very important point, because if you see the seroma, you have to evacuate as soon as possible. Otherwise, it drives to infection or dehiscence. So that's a very important point to me in the use of total coverage ADM. Indication to changing the plane. I think that if we have to remove the implant, I prefer to go for a flap. And so I don't like to change and go under the muscle because I get a scarred situation. From retropectoral to prepectoral, this is a very interesting new opportunity. We are nowadays shifting a lot of our retromuscular to pre-pectoral. This is another topic, a very new application, and we did really many cases because many patients start to complain about animation deformity. And at first, years ago, we thought that it was impossible to solve. We did fat grafting, but of course, it didn't solve the problem. But nowadays, we are shifting. And we prepare this patient with some fat graft in case it's very thin. But then we shift with very high patient satisfaction. So thank you for this question.
1 minute of discussion more, if anyone. Moderators, you have questions?
No.
Great, thank you very much. Oh, one more question, sorry.
Zlatko from Zagreb again. Did you use any implant for breast reconstruction without ADM?
Yes, as I mentioned in my presentation, this is the first part. Then I get addicted to pre-pectoral because I like very much the result, and I try to push the limits. Pre-pectoral, yes. So pre-pectoral, nowadays I'm doing pre-pectoral with polyurethane implants, and I have an experience of almost me and my team, almost 500 breasts. really, we can compare the two casuistic in another setting, but really very, very good experience.
Thank you very much. We have to go on the next lecture.
Thank you.
Thank you very much. Algorithm to optimize immediate prosthetic breast reconstruction by Dr. Rubino. Thank you. 11 minutes and 4 minutes of discussion.
Mr. Chairman, thank you. Ladies and gentlemen, I would like first to thank Professor Santanelli di Pompeo and Professor Clemens to having invited me to this meeting. I will speak about our experience driven actually by the COVID-19 pandemic for an algorithm to optimize immediate prosthetic breast reconstruction. Doesn't work.
It doesn't work.
Next slide, please. Okay. Sorry about that. Okay, so it's a common experience, unfortunately, that we have had that all the hospitals were turned in a local hub, and our university hospital in Sassari was the same. We had the problem that nurses and anesthesiologists were transferred in COVID departments, and actually most of our elective surgery in the first part of the COVID pandemic were just cut. And we had a consistent reduction of the operating room available. Now, then at the very beginning, we had to totally discontinue breast reconstruction for first 2 or 3 weeks to preserve operative time for breast oncologic surgery. Then we resumed immediate breast reconstruction late April 2020 and never more discontinued it, but the shortage in theater time remained. So far, we are still in shortage. When as a result, we had almost no place to perform breast expander replacement and the light breast reconstruction. This meant actually that we had an unbearable increase in the waiting list for the second stage of reconstruction. And at the end, for example, we counted more than 120 people waiting in the waiting list for changing the expander. When faced with that, we decided to perform a sort of paradigm shift. Actually, we have seen from the previous lecture, in the 20 years ago, we considered a two-stage breast reconstruction with implant as the standard method which gave us better results. But now we have many new techniques that can made us perform a good reconstruction in one stage. The paradigm was that we decided to implement an algorithm to do a one-stage breast reconstruction, immediate and implant breast reconstruction for all patients at all, and discontinue definitely the two-stage, because we could not afford to tell the patient that we should make a second stage, but we cannot assure in any case. This is the concept. Actually, because we have innovative surgery techniques that allow us a one-step reconstruction, and the COVID-19 gave us not the possibility to make the second stage, we had a tremendous increase in waiting list, and then we go for one-stage reconstruction in all cases. The algorithm actually is a simple algorithm. It starts with the preoperative evaluation. We first decide if the patient meets the criteria for immediate reconstruction. If yes, we have to decide whether to go for alloplastic material or autologous tissue reconstruction, of course, based on the anatomic features, autologous tissues availability, and patient desires. When we have decided for alloplastic material reconstruction, we go for an intraoperative evaluation. We have our first choice is the pre-pectoral reconstruction. If the skin thickness and the skin viability after the mastectomy is good for pre-pectoral, and if the breast weight is less than 100 grams, we go for a pre-pectoral prosthesis and ADM. If the criteria is not met, we go for a DTI, direct implant reconstruction, if the weight is less than 200, 250, and if the weight is bigger than 250, and we cannot go for submuscular plus IDM, we still use, we have returned to use the Becker's prosthesis. So at the end of the day, if a patient is candidate for immediate alloplastic reconstruction, she will have anyway an immediate reconstruction with simultaneous, if necessary, with simultaneous contralateral adjustment. It's very important to standardize the method to consider the weight of the breast specimen. If, for example, we have got the breast specimen which is higher than 500, 550, we go for contralateral reduction, and therefore it is simple is a simple calculation. We just consider the weight of the specimen minus the weight of the specimen of the contralateral reduction, and we have the weight of the implant on the reconstruction sides. This is our experience, because we started this algorithm. The algorithm is for all patients immediate reconstruction in one stage. It's a little more than 10 months. This is a result, but we have seen a lot of very nice results from the previous, and we will see in the next. Now, what was our our question? Because we were offering the patient only one choice to be reconstructed in one stage, we want to compare the perceived outcome of the patient who had completed the reconstruction using one stage with our patients before we had operated years before. We have completed the reconstruction in two stages. We want to see whether the approach was gives at least the same results of the two-stage reconstruction. We made a comparative evaluation through a patient-reported outcome study of the outcome perceived from two groups of patients. In the group A, we put immediate breast reconstruction in one stage with the algorithm all patients, and group B, immediate implant reconstruction in two stages from our previous series. Previous patients. The exclusion criteria basically was an unsuccessful reconstruction procedure, which led to removal our procedure, because we wanted to see which was the perceived results at the end of the reconstruction. We administered the breast Q reconstruction model pre and post-operative scales the post-operative was administered to the patient of the two groups with a minimum follow-ups of 6 months. We used 6 months because we started the algorithm in September 2020, so we couldn't have for the group A a longer follow-up. As usual, the responses of each scale were summed and transformed using equivalent Larcher transformer score. The statistical analysis of the results were descriptive, were average standard deviation and a t-test for the comparison. The group A and group B, you see the different variables were all non-significant, which means that the two groups were comparable. And these are the result of the analysis. There were 4 domains in which there was a statistically significant difference. It was in two domains there were no statistical difference between the two groups. This is the same in a more simple visualization. For psychosocial well-being, satisfaction with breast and satisfaction with implants, the score was significantly better for the group of one stage. And for physical well-being, chest, it was the score was statistically less. The score was smaller in the group A, but this means more favorable results because the physical well-being for the chest means that the lower score has got less pain, less discomfort. For the sexual well-being, there was no statistical difference, even though there was a difference, but it's not statistically significant. And for satisfaction with breast pre-operatively, the perception of the woman of her breast before surgery was the same in both groups, which is another indirect analysis that the groups were a statistically better outcome for most domains in the patient for the one stage group. The causes less time. The limitations was the limited group of patients, the fact that the green group it's not homogeneous. We are finished for the reconstructive technique used, and the conclusion is that it's better outcome for most in the patient with our strategy of immediate breast reconstruction. The possibility of offering this immediate alloplastic breast reconstruction to all suitable patients comes from the availability of new innovative techniques like Pre-Pectoral, for example. Last, I will to say that the pandemic emergency in this case has got an acceleration in what was can be considered a paradigm shift in alloplastic breast reconstruction. Thank you.
Thank you very much. Committee discussion, moderators. Any question for Professor Rubino? Question from the audience, from the moderators? No? Yes?
Let me thank you, Corrado, to have introduced the factor of thickness of the skin in the algorithm of choosing the right.
Pardon?
I want to thank you for having introduced the thickness of the skin as an important factor in choosing the right reconstructive surgery.
We started using direct measurement in the operative theater, and now we are using also the preoperative thickness measured with the digital mammography. But most of the patients have been just measured with the ruler at the end of the mastectomy.
Just a question for the thickness on mastectomy.
Yeah.
It has been proven it doesn't work. There is an article on that.
Okay.
And really, I don't know what you think, but what is your opinion?
Well, actually, I think that it's a multifactorial variable. It means that the single we can for example, with radiology or also with the ruler, we can measure in single points. But for example, we have to look at the depth of the skin mastectomy flap, because there are some parts for when, for example, there can be the dermis exposed, and this is a bad sign. So it is actually a clinical evaluation.
I agree. If there is no more question, we're going to go through the third. So comparative long-term outcome. Yes. No other question? Sorry, I didn't see you.
Just a question, Corrado, about the ICG angiography. Do you do ICG angiography evaluation in TRALP?
I haven't the technique available. I have done only 1 or 2 tries, but I haven't got. I still I haven't got the possibility to do it routinely.
There is the last question, because we have less than 1 minute.
Do you think of use of thermal camera to evaluate the vitality of the skin flaps?
Pardon?
Thermal camera.
No.
Thank you very much. We're going to go on the third lecture by Dr. Parodi, Comparative Long-Term Outcome of Pre-Pectoral Breast Reconstruction with ADM.
Good morning. Thanks to Fabio and Mark for the invitation. This is my personal disclosure. Which is there? Okay, my financial disclosure. 6 years ago, we chose the pre-pectoral approach because it is a part of complex philosophy where all this aspect has a significant contribution to the high quality results. The concept of bioengineered reconstruction, where the surface of the prosthesis and the ADM are only a part of the process. We were convinced by the improving number of published papers on this topic, the superior quality of the aesthetic results, the absence of animation, the percentage of complication comparable in our experience with the traditional techniques, the higher satisfaction of patients also confirmed by independent observer. But this is very important because when you perform the double plane reconstruction, putting an ADM in the inferior part of the breast, there is a superior movement of the muscle, leaving the gray part of the retropectoral prosthesis completely subcutaneously. And again, you can see the difference of the result in pre-pec and retro-pec 1 year after the procedure. Same surgeon, same mastectomy, same prosthesis, different plane and different results after 4 or 5 years. These are aesthetic outcomes that we can reach with the pre-pectoral technique described in the IBEG group. This is our contribute to the literature, especially with the reduction of seroma and functional results. I'm in favor of biological ADM. In these years, we used the 700 biological meshes and a very small number of synthetic mesh and polyurethane implants. And this is a weak point of our experience. In our philosophy, we need to satisfy both mechanical to restore the function of the Cooper's ligaments and biological requirements. For us, in order to prevent capsular contracture, it is essential to use biomaterial able to guide the inflammatory response toward remodeling and regeneration. The biological ADM are scaffold, that it means that they are able to guide the cell adhesion and the inflammatory response, especially if you are using smooth implants. Biomaterial were considered inert with no interaction with us in order to not cause damage, but the scaffold has a bioactivity, and this is the center of the trouble. In this study from my group, we introduce also another advantage of biological ADM. In lab, of course, in lab, ADM promotes the differentiation of subcutaneous stem cells into adipose cells, improving the formation of new fat. And it could be important in lipostructural procedures. There is some kind of a biological war if there is an inert material between the body and the material. This is not the situation of biological ADM where there is an integration. Giorgio Bernard groups show that polyurethane could reduce the rate of capsule contracture, but there is also an inflammation, and we don't know if there is an importance from the clinical point of view. But we know very well that polyurethane has pros and cons, And for me, the concept very important is the degradation of the polyurethane after years. So there is an increasing number in the literature of capsular contracture after 4 or 5 years. But we want to have the breast not touched for many, many years. And also the publication on this topic are very interesting, but they have a very small number of cases, very small follow-up. The paper of Marcia Salgarello is very interesting, but the follow-up is 1 year. So we need more time to compare the result and to see if, to get some conclusion. You know, we can share immediate, major complication, late complication. They are different troubles. In my opinion, the Rancatis classification is very useful. With type 3, you can use any kind of material, polyurethane, texture, probably also smooth. But if you want to improve the number of patients and to improve the indication in type 2, and also in very selected type 1, in my opinion, you need an ADM. The meta-analysis show that the learning curve is very important. In this topic, with a lot of implant loss, they show that Pre-Pectoral has not in this study, has a very good clinical effects, but also better results compared with the subpectoral. In terms also of capsular infection, hematoma, and delayed wound. In this paper of Marcia, there is another meta-analysis related to the human ADM. This is a very interesting topic because we consider many articles that are written with human ADM, but in Europe we can't use, or the experience with human derm is very limited. But also in this study, the rate of capsular contracture was 1.2. The bug study was described, but in our experience, we try to see our complication, limiting the number and the experience on only one hospital in order to limit the bias of treating for breast unit as we do every day. Our experience show a rate of major complication on 9.5, and including 6 hematomas requiring reoperation, 2 implant revisions, and only 3 implant loss. That the rate of infection was more or less 2%. The overall minor complication was 20.7, and the overall seroma race was more or less 14. But the gray part was minor, minor seroma, that it means less than 40 cc requiring 2 evacuations. No difference were observed using different ADM. And the percentage is more or less the percentage of the literature. It is very important, as described before, to perform immediate evacuation under ultrasound guide of the seroma, and also to reduce complication, to treat immediately any kind of suffering tissue. There are no long-term studies concerning the results of Pre-Pect and Retro-Pect. In this study, they are using a lot of material, a lot of surfaces. Very interesting, the very high number of failure, prosthetic failure, that it means more or less 15–18%. A major number of change of plan and prosthetic failure in subpectoral group. A number of capsular contracture less in the prepectoral than in retropectoral. But also in this case, it is not statistically significant. Of course, there was no animation deformity and more rippling in the group of prepec. Our experience, sorry to the mask. We tried for this Congress to share, to control 3 groups, Pre-Pect plus ADM, Retro-Pect plus ADM, traditional retropectoral approach. And we choose the patient, the first patient of each group with a follow-up of 4 years at minimum. This is the primary outcomes. We consider 50 patients in each group and their comorbidities. Seroma was, again, the most frequent complication as a minor complication in Pre-Pect and Retro-Pect, probably due to the presence of IDM compared with traditional one, no red breast syndrome, and the number of infection very, very low in this group. More wrinkling were observed in Pre-Pectoral, but this technique was associated with less rotation, malposition, and reoperation. Only 2% of these patients show the capsular contracture grade after 4 years, compared with the 10% in other groups. This data is not statistically significant due to the limited number of patients, but the trend is clear. The pre-pectoral group presented an inferior number of reoperation and less procedure of fat transplant. I don't know if it is the advantage of the technique or it was related to the pandemic that decreased the number of lipofilling, but it is the result that we have. In conclusion, pre-pectoral plus IDM reconstructive surgery show, in my experience, encouraging results in long-term follow-up, but larger samples are required as are necessary comparative long-term studies, including ADM versus polyurethane. These studies are necessary because our experience is limited only in one arm of the problem. Thank you for your attention.
Thank you. Question from the moderators? Any question?
I believe that all these studies about direct to implant or coverage of the implant with membrane or nets have an important bias because they don't consider the homogeneity of the mastectomy. I mean, if the skin is preserved, the fold is preserved, anything can be done, and the result will be wonderful anyway, with or without meshes or membranes. But if the skin is tight, the inframammary fold has been violated, that's completely another story. So I think it's really difficult to have an objective evaluation of the result if we do not consider that mastectomy is not homogeneously performed.
Yeah, I don't agree with you totally, because we know perfectly that if the prosthesis is below the muscle, the results are significantly inferior. This is our experience in that time. The Pre-Pect has enormous advantages in order to augment the quality of our results. For the skin coverage, this is true. I mean, if you have the type 3 of Rancati, in my opinion, you can put everything. But the mastectomy has not the same thickness in any situation, because sometimes you have a very thin skin in the inferior quadrants, especially if you are approaching from the lateral part or in the medial part. And this is the reason why in that situation, you can have necrosis of the skin, also if you have a thickness on the superior bole more than 1 centimeter. So my choice at the moment of the reconstruction is I check clinically the skin. If I have dermis, I don't put a prosthesis immediately. I check with fluorangography, but I don't believe completely to the fluorangography. I mixed this result with the clinical observation. In that situation, I moved to stage reconstruction, in many cases using ADM, and the results in my hand are superior.
Thank you. Just to emphasize that there is a paradigm shift in the way the breast surgeon is performing the mastectomy nowadays. I think that it was forced by the plastic surgery experience. We try to push our breast surgeon because most of us don't do the mastectomy, but we collaborate with the breast surgeon. So we try to make them understand that the mastectomy should be anatomical nowadays. anatomical mastectomy means following the plane of breast capsule, means respecting the IMF, respecting the perfusion, respect the internal mammary perforator. So I think that the paradigm shift is due to our experience and our efforts to push them to do a better mastectomy for a better reconstruction. And this needs to be emphasized because this is a strong work that we should do in our breast unit with our breast surgeon. And I think those of us who will succeed will have a perfect way of solving most of the problems in implant base. Of course, free flap is another choice.
I totally agree, but there is a great bias for some of us. They are working in academic hospital. We are covering 5 hospitals. So the type of the mastectomy is not the same. Also, the results are not the same. In this way, we must be very very aggressive on complication. That it means that you have only a small suffering of the tissue. You have to operate immediately.
Sorry, we are short on time.
Be a very useful tool for this work with the breast surgeon.
Thank you very much. I call him Professor Persichetti, direct to implant breast reconstruction when he's indicated and to do it. Sorry.
Good morning. First of all, thanks to Professor Santanelli di Pompeo and Clemens for the invitation. And I'm going to speak with the problem of breast reconstruction direct to implant. As you can see here, in 20 years, breast reconstruction in the United States increased 75%, and 14.5% are direct to implant. So the radical mastectomy was mentioned before, is mandatory to understand what we have to do. Let me speak just a second and make a tribute to Brian Todd, who was the first plastic surgeon who described the skin sparing mastectomy. So parameters influencing the result are anatomical, as you can see, and the thickness of the skin flap is mandatory to understand it, and also other disease-related and also additional factors. Many times I heard about this very good article published by Rancati and others, where it's possible to assess before surgery the thickness of the skin remain on the breast, and we can divide in 3 types: type 1, type 2, type 3. In type 1, we maintain our attitude to do normally 2-stage reconstruction or ADM and with implant below the muscle. In type 2, we can do the direct implant with ADM and most of the time below the muscle. And in type 3, we go pre-pectoral over the muscle, and most of the time without any ADM. Some example, very thin patient. Flap is mandatory, even in young people, where we go direct to implant. And if the patient has to support radiotherapy after the breast reconstruction, we can have some good results doing afterwards some lipofilling. And when we have type 3, we can go directly, and we use and see very well like a normal breast. even in thin patients like this. And you have a possibility to manage the post-operative period in the right way, and the patient are very good and satisfied with this. We did a study just to understand what the evolution of this, and to know also the opinion when we do direct to implant reconstruction of bilateral. And if you see here, we had two groups, monolateral and bilateral, more or less comparable. And we see that all the parameters we explore, the sexual well-being, the satisfaction with breast, and the satisfaction with heart implants are higher when we do bilateral reconstruction. So we try to have strict parameters to use direct implant breast reconstruction, and we would like to do in one shot what we need, but DTI is a real one stage. Most of the time we have to do some refinement or two. The direct implant breast reconstruction bilateral, but afterwards, some days, we experience this problem. If we had checked before the viability of the skin flap, probably we will prevent this problem. And we use an implant or an expander, and we try to solve the problem, but it was impossible. Then we shift to an expander, and we did all the job in 2 stages on the right breast and maintain the one single shot on the left breast. At the end, we achieve a stable result. So we have to prevent complication when we do direct to implant, but it is not every time possible. So when we got complication, we moved to autologous reconstruction. And we do this basically. In type 1, most of the time, 2-stage breast reconstruction. In type 2, we do hybrid reconstruction with ADM. And in type 3, we do direct to implant pre-pectoral with polyurethane. So we have to say that the variability of the patients are so wide. We have to have a very good radiologist to choose the right operation for that patient. And we have to also to think that we have to satisfy our patients. And we have to take into account this is not the best operation which satisfies the patient as we would like to do. And if we think about this very strong anecdote of Tagliacozzi, we have to think that we have to do our best to do this. And this is a movie that I would like to show you. I don't know how I can go on with the movie here, but I think for a plastic surgeon it's much more important to know what kind of person has a disease than to know what kind of disease a person has. Thank you very much.
So we have a bunch of time for questions. Moderators, do you have direct question to the speaker?
Zlatko Zagreb. What kind of 2-stage procedure do you use? Expander and then implants, or implant and implant?
No, normally we put an expander during the mastectomy, and then afterwards 6 months, 1 year or when the patient is okay, no more problem with the disease, they finish their adjuvant therapy, then we move to, yes, then we move to definitive implant.
More questions in the audience?
It's a question or for the other speaker. But when do you perform the evaluation of the perfusion of the flap? Before inserting the prosthesis or after mastectomy? Because it's quite different condition after stress or before stress of the prosthesis. Even for the other speaker that talked before.
We would like to check after the mastectomy. At that point, we see what the perfusion of the mastectomy flap. But this is not every time possible. It's difficult to, if we don't preview to do this at the beginning of the surgery, most of the time we don't have the machine, we don't have the right solution to do during the surgery. So we have our clinical experience, which is sometimes fail, as usual. And regarding what was said before about the thickness and the regularity of the thickness of the skin flap, this is very difficult to assess, even if you measure it or in everywhere, because you have so many variables. And also the gland, that this is not completely in that plane, and the oncologic surgeon has to remove the gland, otherwise we got many recurrence there. So it's impossible to have a very regular thickness of the mastectomy flap.
One thing, for the ICG, there is no real study that prove that, yes, it helps, it's a guide, but there is no real criteria to say, oh, it's more blue, it's more dark, it's lighter. It's impossible. It's not have been proven. It helps. The other thing is for the Roncati study, it's fantastic. It's a very good tool. But in my practice, we tried on 1990 patients, and we didn't have any. We just tried just for the skin necrosis. Absolutely no link. Stage 1 could be good. With no fat necrosis and very good results, and stage 4 will be. It's only question the quality of the mastectomy and the homogeneity. It's a plastic surgeon thing to do it. It's to me. I don't want to harm anyone, but I think this is the major point of the discussion. We all thought that the implant and what coverage and mastectomy before. I think it's a message.
Also,
go ahead.
I would like to say also the technique the oncologic surgeon uses to do the mastectomy could have an influence. Because if they use very low temperature blade, this will help a lot, and what they can do to preserve vascularity will be encouraged. So I think we have to care about this.
Thank you very much, Professor Persichetti, and we're going to welcome Peter Cordeiro for the impact of radiotherapy on implant reconstruction. Thank you, Peter Cordeiro.
Thank you. It's a real pleasure to be here with my friends back here in Rome. Thank you to Fabio and Mark for the invitation. I was asked to speak about the impact of radiotherapy on implant breast reconstruction, and there is a lot in the literature to cover, and would probably take at least an hour to cover all the different types. So I'm going to speak mostly about two-stage implant breast reconstruction and post-mastectomy radiation. And I think much of the data I show you will probably apply to the other forms. These are my disclosures. So post-mastectomy radiation therapy has been shown to provide superior local regional control, increased disease-free survival, and increased overall survival in node-positive breast cancer patients. And the definite indications are large tumors, multiple nodes, but in my institution, I think worldwide now, more and more young women are getting radiated even with a single node that might be micropositive. So PMRT is becoming increasingly common for patients with advanced breast cancers. And I think for most of us, if you're doing autologous reconstruction, we would prefer to delay the radiation, delay the reconstruction, and then do the radiation first. But how does PMRT impact outcomes in patients with implant breast reconstructions? So my approach to implant-based reconstruction has certainly evolved over the last 2 decades. And this shows you my overall experience through about 2019, about 6,000 patients reconstructed with implants. And you can see about 4,500, 4,700 without radiation, but down in yellow are all the different groups of types of radiation. And bottom left, you can see radiation to the implant, about 20% of the overall group, and radiation to the tissue expander, about 7%. So it's already pushing 30% over this entire group. And in my recent groups of patients, the number of patients getting post-mastectomy radiation is even higher. So chest wall radiation is increasingly common. The need for post-op radiation may or may not be known prior to immediate reconstruction. And the dilemma we were faced with 20 years ago was, what do we do if there's a tissue expander in place and they need radiation? Do we remove the expander? Do we convert to a delayed reconstruction? And even more complicated, and if we knew for sure whether the patient is to get radiation, do you delay the implant reconstruction? Do you reconstruct with autologous tissue and radiate the flap? And then what if the patient is not a flap candidate? So many questions. And back then, when we first started seeing a lot of patients with PMRT, we decided to just proceed with immediate reconstruction with a tissue expander. And then we coordinated with the oncologist and the radiation oncologist the timing, so that most importantly, the patient gets the appropriate oncologic therapy. So this was the original algorithm. The patient received mastectomy with tissue expander placement. Expansion started within 10 to 14 days post-op. We expanded during chemotherapy because at the time, most patients got adjuvant chemo, not neoadjuvant chemo. And then we exchanged the implant about 3 to 4 weeks after chemo, and then radiation about 3 to 4 weeks after exchange. And this was the routine for many, many years. And our preference was therefore this algorithm to radiate the permanent implant. However, we've increasingly seen more patients with neoadjuvant chemotherapy, and I'd say now this is much more common than adjuvant. So in this scenario, the patient has already received chemo. They then have their mastectomy with placement of the expander, and there's not enough time to expand, wait, do the exchange, wait again, and then radiate, because in that scenario, the patient ends up getting their radiation about 5 to 6 months after their mastectomy. And instead, what we do is we expand rapidly within about 6 weeks and start the radiation within 6 to 8 weeks after placement of the expander. And then I usually wait 6 months after completion of radiation before doing the final stage. So this algorithm involves radiating the expander. And I think in general, if you're doing 2-stage reconstruction, it's either one algorithm or the other, depending on the timing of the chemotherapy. So this is the algorithm radiating the expander, and next to it, the algorithm radiating the final implant. The question becomes, if you have a choice, when should you be radiating, and what is the best algorithm? And in looking at the literature, it's very hard to come up with good answers because reports demonstrate variable outcomes. They're usually focused only on surgical outcomes and principally loss of the reconstruction. There's no information on aesthetic results or patient-reported outcomes. And the timing is variable from paper to paper, and this systematic review, very small numbers of studies with adequate patients. And they concluded that these were retrospective, they were small numbers of cases, lack of control group, different timing of radiation, and then often there are combined forms of reconstruction. And it really does make it very difficult to compare apples to apples to really come up with the right answer. So I'm going to show you a paper that we published in 2015, which looked to answer this, this problem. And the objective was to compare both clinician and patient-reported outcomes using these two algorithms, radiation to the expander and radiation to the permanent implant. So here again, the two algorithms, radiation to the expander, radiation to the implant. These were my personal reconstructions between 03 and 12, which is when we were doing both types. And I think it's important, and this was mentioned in some of the previous presentations, you can't compare groups of patients that were operated on now and 10 years ago. They have to be done at the same time. All tissue expanders and implants had total musculofacial coverage, so the results I'm showing you pertain to that particular approach. The radiation technique was very standard in our institution, and for surgeon-reported outcomes, I'll show you, we looked at capsular contractures, aesthetic results, and then we also used the breast Q to look at patient-reported outcomes. Capsular contracture, the standard modified Baker classification system. The breast Q reconstructive module, I think most of you are familiar with the satisfaction of the breast and outcome. So within this group of patients, about 1,700 implant reconstructions, 1,400 non-radiated, about 100 radiation to the expander, and about 200 radiation to the final implant. You can see that the overall reconstructive failure in non-radiated patients, it's about 5%. Radiation to the expander, 18%, and radiation to the implant, 12%. So very clear difference in outcome when you when you're looking at loss of the reconstruction, which favors radiating the final implant. A better way to look at this, because it takes into account the much longer term outcomes and patients that may be lost to follow-up, is to do a Kaplan-Meier evaluation. You can see that about 5% in the top green line, non-radiated patient loss, versus about 16% radiation to the implant and 32% radiation to the expander. So no question, you're more likely to lose the implant if you radiate the expander. And multivariable analysis shows some difference, again, between the two types. Big difference between radiation versus non-radiation. This shows you capsular contracture rates, and the far right group and the middle group. Far right is implant, radiation to the implant. You can see in dark blue and the darker blues, you're more likely to have a capsular contracture if you radiate the final implant. When you look at surgeon-evaluated aesthetic results, you're more likely to get a good result if you radiate the expander. So it's the opposite. No real differences between outcomes when you're using the breast Q in either group. They're about the same. To quickly show you some of the types of results I'm talking about, you can see acute radiation on the left, and then about 2 years later, sometimes you often get very good results. This is radiating the final implant. Here's the patient after her reconstruction. During the radiation, looks horrendous. And here she is about 2 years later with a grade 3 capsular contracture, but overall still a reasonable result. Complications, you can lose expanders and implants to infections either way. You can certainly get exposures after radiation, as you see here. Grade 4 capsular contractures, this is what I consider a grade 4. Some of these can be pretty severe, and it's interesting because most of these patients do not want anything done. They have advanced disease, and they're still happy to have something. It's a different perspective. Grade 3 contractures, you can see moderate asymmetries and firmness. And grade 2s, less asymmetry and just slightly firm implants. And then about a third of the patients have grade 1s. There's really no capsular contracture. It's hard to tell. So I think it's still very worthwhile to reconstruct patients even if they're getting radiation. So to conclude, the odds of reconstructive failure is higher with radiation to either the tissue expander or the implant compared to non-radiated patients. Radiation to the expander has increased failure rates compared to radiation to the permanent implant, 32% versus 16% at 6 years. Aesthetic results and capsular contracture rates are slightly better for patients with radiation to the expander as compared with radiation to the final implant. And patient-reported health-related quality of life outcomes, the BRESCU, show no difference between the two groups. So what's the take-home message? I think the management of PMRT and breast reconstruction is multidisciplinary, and it needs to take into account, first of all, the oncologic treatment, and then also surgical and aesthetic outcomes and the patient's wishes. And oncologic approaches continuously evolve, which is why we as plastic surgeons need to change how we approach these or the timing of our reconstructions. What should we recommend for patients, radiate the expander or the implant? I generally will provide the patient with all this information, and at the end of the day, they will make that decision with me. Thank you very much.
Thank you very much. Question in the audience?
Pauline from Rome, thank you for your presentation. I wanted to ask you if fat grafting changes your perspectives and eventually how.
Fat grafting is very useful. I usually don't do fat grafting at the time of the exchange. Radiation, no radiation. Some of my colleagues do at Memorial. I will usually complete the reconstruction and the radiation, and then evaluate the patient about 6 months after that, and then depending on what they need, I will fat graft, and it will certainly help indentations, asymmetries, and I think in some cases it does improve the quality of the tissues, but I don't have a large number that I can show you long-term follow-ups, etc.
Thank you. Mike, here? Yeah? No.
Stefania Tenna, Roma. Thank you, Dr. Cordeiro. Great presentation and, of course, great experience. May I ask you, you switch from the tissue expander to the implant in a very short time. Do you think there is enough to have a really skin expansion? Because if you switch so quickly, don't you think that is more a distension and then you can just put the implant?
So you're talking about the algorithm. If I'm going to have radiation, I'll switch within 3 to 4 weeks. If I'm not doing radiation, I'll wait at least 2 months or more. But I think you have to make sure the patient gets the right oncologic treatment at the right time. And I was worried about switching after 3 or 4 weeks, and these patients actually do really quite well. When switching from a radiated expander to the final implant, I wait 6 months.
That's our experience.
Yeah.
Thank you.
Just a question for so considering that if you irradiate the implant, you have less complications. Okay. Considering that tissue expander, irradiating the tissue expander, you have a better aesthetic result. So what do you choose?
I still think, so you don't have a choice if you're irradiating the expander.
Yes, you're right.
And that group of patients now has become the more common pathway. Makes it easy. In a patient who's going to get adjuvant chemo, and I often leave it up to them, and I say, here's the difference, right? Most of them will select radiating the implant and settling for a result that may not be as good.
Thank you.
And I think personally that's what I would do too. And patients, they know what you think. They kind of get the message.
Okay. There was a question in the last. No?
Thank you. Great talk. Just wanted to. I'm here. Just wanted to ask you if you take the expander and the radiate the expander or the implant, your radiotherapist use the same protocol. Because there is a difference if you have an implant to also with the radiation coming there where she should, or you have an expander with a valve or something?
Generally the same, but with an expander you have a metal port, and they do take that into account. So it's slightly different, but the overall dosage to the skin and the chest wall is about the same. You know, and again, it's interesting. We're seeing many more patients with proton radiation, which is a totally different approach. And I haven't seen enough patients, and I don't have enough data to compare that to the more traditional methods. But my general impression is that radiation is radiation, and some patients do very well, some patients do very poorly, and in between there's a gradient, and it's not random, but it's patient specific, and the outcome still remains about the same. And this is my feeling also about, you know, so you do a one stage and you radiate the implant, or you do a pre-pec. I'm not sure that the technique makes a huge difference, and I don't have enough data. Again, I'm very data driven to tell you for sure. But it's less the technique, and it's more how the patient reacts to the radiation. That's really if there's going to be a problem, it's how it's in those patients that don't do well.
Thank you very much. We have to move on. Thank you, Peter. So we're going to welcome Dennis Hammond for fat grafting in implant-based breast reconstruction.
I think it's pre-recorded.
Greetings. My name is Dennis Hammond, and I'd like to take this time to share with you some thoughts I've developed regarding fat grafting in immediate implant-based breast reconstruction. During the course of this talk, you'll see some implants from the Mentor Corporation, as well as from Establishment Labs, and ADM from our concerns with regards to the medical legal aspects of fat grafting in the breast due to the possible triggering of a breast cancer.
Well, over the years, a lot of these concerns have really been dispelled, and this is one of the cases that certainly changed my mind.
We did some early fat grafting on many years ago, and here you can see the fat being placed largely here in the medial aspect of the breast. We were able to inject a fair bit of fat in each breast, and I had a chance to operate on that patient again about a year later, and when I looked inside, I could see here was the fat that we had actually grafted at that time a year before. And in fact, when I cut the fat here, you can see that it actually bled. And this was really, for me, just a solid indicator that fat grafting truly was adding viable tissue to the breast soft tissue envelope, and that it was a viable procedure. So as the years have gone on now, two separate theories with regards to fat grafting have been developed. One focuses more on the stem cell effect as it applies to the soft tissues. And this is what you use mostly in the facelift realm. So adding stem cells to rejuvenate the skin. In the breast, however, we're looking for volume. And that's where the effect of the composite graft comes into play. Because when the fat is injected, it's taking as a composite graft. So whatever approach you decide to use when you're injecting fat into the breast, these are the elements that you really need in order for it to be effective. First, it's got to be simple and instrument friendly. You just can't spend a lot of time worrying about technology to provide fancy instruments in order to accomplish this. It's also got to be time efficient, and it has to be effective. Now, I've tried several different methods. Of course, everybody's gone on probably and tried the centrifugation method. When I centrifuged the fat, I noticed in our syringes, we really didn't get very much liquid at the bottom of the syringe. And so it was a lot of time spent for not a lot of benefit. Other types of systems have been developed. This is an example here for a buttock fat grafting system where these large syringes are attached to a rotating column. And as you basically centrifuge the fat, you can process a large amount of fat in a short amount of time. And you can see where you get rid of the tumescent fluid there. What many people utilize today is just simple decantation. So you simply let the fat sit on the back table, and it will actually auto-separate without too much trouble at all. And this is the system that I now use, is the decantation system. So this is a self-contained system that we use. It's got a plunger here that applies a constant pressure to the cannula here so we can remove the fat, and the fat is then collected in these plastic bags. Now, I do believe in trying to purify the fat if at all possible. So what we'll do is we'll decant that fluid over several minutes, and then we'll let the gravity just work so that that fluid can be removed. And I like to wash the fat 2 or 3 times in order to get all the blood out. So we want to try to get the purest graft that we can. So here you can see we add just a little saline, and what we'll do is we'll agitate this bag like this, back and forth to distribute the fluid within the bag. And ultimately that'll separate again. And here, this is after the 3rd wash. You can see that we've been able to really clean up that fat, get a lot of the blood out, and we'll just decant this last little bit of fluid here. And this will be that pure fat that will then use now to graft into the breast. So this is just a video clip showing the various stages of that fat washing technique. Here's what the fat looks like when it first comes out into the bag. This is after 1 wash. Here you can see the fluid separating at the bottom. This is after 2 washes. And then finally, after the 3rd wash, we get that nice yellow gold fat with that last little bit of fluid that will let fall out from the side. Now, the advantage of using the decantation technique as opposed to some sort of filtering apparatus or a colander or a sieve, if you will, is that you can preserve all of the elements of the fat. So this is the fluid that's really not going to be of much help to us. And here you can see we've got fat cells at the top, and then singlet and doublet cells, and then we actually even have the pre-adipocytes and the stem cells here in this white buffy coat area. So what that means is that few cells are lost even when it's washed. And what we end up with is a wetter fat. And that wetter fat will allow us to inject it through smaller cannulas without injuring the fat. This particular system is self-contained, and it's really quite efficient because the fat's not exposed to the outside. And what this does is it facilitates the transport of oxygen and carbohydrates into the cells so that you can get better cell dispersion and possibly enhanced fat survival. Now, one of the concepts we use when we're injecting the fat and processing it is this. This is going to be 5 cc's of fat that I'm going to inject now through this cannula. And so you'll see here as we put this out onto the towel, this 5 cc's now is completely removed. So we went from 10 to 5. Now, if we're not careful, if we take this fat and we're very rough with it, what we can actually do is destroy the cells. We can basically obliterate the cells and just turn it into a wet spot, as you can see here. And so if you're not careful with your fat, you can really destroy it in the process of processing it. And this is why I've got some concerns about the nanofat technique. For instance, this is a technique used in facelifting, where you use this connector here to run the fat back and forth. And basically all you're doing is liquefying and really damaging the fat. So as far as survivability is concerned, there's crushed fat, which really doesn't survive well at all. This is just going to be stem cells. Then there's nanofat, which will have some singlet cells, full fat slurry, what we call the structured fat. So now what we can do is we can take this fat and now we can easily inject it then just under the dermis in our breast reconstructions now to add that fat to the overall breast soft tissue envelope. So the concepts that we use are we harvest and inject with no delay, we inject with minimal pressure, and that wetter fat that we get by decantation allows it to be more lubricated, and it allows us to inject it and limit the damage to the fat and allow us to treat it then as a composite graft. Now, as far as reconstruction is concerned, here's an example of a patient that underwent an implant-based breast reconstruction. Here's a video of her several years later. You can see that she's got some contour irregularities in the breast. And in particular, she's got some wrinkling here in the medial aspect of the breast that we'd like to soften here if we can. So as she leans forward, you'll see there's some hollowing here in the breast. And you can see these wrinkles. So the idea is now we want to go and add fat. Now, if we're above the muscle here, it's fairly easy to add the fat. It's harder to add the fat just into the mastectomy flap itself, because if you're not careful, the idea is you want to get that cannula right in that mastectomy flap and deposit your fat cells in the mastectomy flap. You don't want that cannula to get down through the capsule and into your implant, because you can inadvertently inject the fat in places where you didn't mean to. And so this is where the fat grafting becomes a technical operation. We want to take that fat and we want to try to add it into that mastectomy flap right between the skin and the capsule. And it's very helpful at this point to have an acellular dermal matrix as the inner lining of your breast, because it allows that fat to be injected quite easily right there. So here's an example of where we're going to add this fat here into the mastectomy flap. We're getting into that space between the skin and the acellular matrix. So essentially what we'll have now is we'll have the skin protecting us on the outside, as you can see there, and then the acellular matrix protecting us on the inside. So what that allows us to do is to now completely inject all the way around circumferentially 360 degrees around the soft tissue envelope to add the fat, to thicken that mastectomy flap. And that way you'll be able to hide wrinkles and mask the fact that you've got a round implant in place. It essentially turns these patients into a breast augmentation type patient because you're able to thicken up that soft tissue envelope, as you can see here. So this is with the implant in place now. And then not yet on this side. And here she is now, a bilateral mastectomy patient with her implant-based breast reconstruction. So this particular patient, we brought her back, we got some fat, we added 165 cc's to each side, and we're able to completely soften that soft tissue envelope and create a nice shape with very few wrinkles. So in just a couple of cases, here's a patient. We're going to do our first stage reconstruction with the mastectomy. We wrap the tissue expander with an acellular matrix. Here's what the implant looks, the expander looks like on top of the muscle. We let that go ahead and heal, add fluid until we're happy with the volume. Now we can do our second stage planning, taking a look at the base diameter of the tissue expander and the volume that we have in, and then picking an implant that will match that. Then we harvest some fat, and we add here, you can see we've added 220 cc's of fat to both sides, and we're able to create really a very nice result, softening those contours with the fat so that it merges well with that implant to create the overall look that we're looking to create with our reconstruction. And so just a little video clip here to show that she is in fact demonstrating a very nice result, like so. So just a couple of examples of very, very reproducible technique to add to our overall implant-based reconstruction strategy. There's another example before and after. You can almost create a scenario where the patients look like they've had a breast augmentation. In other words, they can look better after the bilateral mastectomy than they did when they started. You can also fat graft multiple times. So here's a patient as she presents for her mastectomy with the placement of the expander. We ultimately take the expander out, add the implant, and here she was. She had a little bit of still upper fold deformity there. We brought her back, fat grafted her a second time, and were able to create really an augmented look to her breast with 2 separate sessions of fat grafting. And she's totally soft. And then one last case is a previous implant-based breast reconstruction. Here's what she looked like with her implant alone reconstruction, direct to implant with a circumvertical lift. We were able to demonstrate a reasonable result, but she still had wrinkling present in the medial aspect of the breast here. So we brought her back, we fat grafted these areas. Here you can see with about 200 cc's to each side. And here's what she looked like at a year. She liked that so much that she actually came back. She wanted another revision, so we fat grafted her again here, and we touched up the scars. We changed her implants out, taking out the anatomic and replacing it with a smooth round gel. As you can see here, bumping up the volume just a bit, and ultimately got her result to here. So after 3 separate sessions of fat grafting, again, we were able to create a scenario where the patient had a better appearance afterwards than she did when she started. And then one last case here is a pre-mastectomy mastopexy concept. Here's a patient that's going to have a pre-mastectomy mastopexy to lift the position of the nipple areola and get a biopsy under the nipple. We let that set for 6 weeks. We bring her back then, and through the vertical incision, we do her formal mastectomy with the placement of the tissue expander and the acellular matrix. Here she was after 6 months with the expanders in place. We ultimately brought her back, took out the expander, put in the permanent implant, and fat grafted her and got her to this situation here, where she's demonstrating again, almost a breast augmentation look with a lift. And so on a video clip here, it demonstrates really the quality that you can create in your breast reconstruction using this strategy. So we've reported on this in an article several years ago with a very low complication rate, basically 1 area fat necrosis and 1 oil cyst in 36 consecutive breasts. So at the end of the day, breast fat grafting is really an excellent adjunct. As long as you don't damage the fat, treat it as a composite graft, it's really an excellent option for correcting contours and shaping the breast. So that's how we perform fat grafting in our immediate breast reconstructions. Thank you for your attention.
Oh, sorry. Any question in the audience? Sorry, Dennis. Moderators, do you have questions? No. There is one question in the audience. Lawrence Larcher.
Thank you very much. Thank you very much for the lecture. I just had one question about the nanofat. I had some huge troubles with if you do too big parts of fat in injection, you get oil cysts, especially in skinny patient, in aesthetic patient. And so I am really a little scared of putting the pure fat without elaborating it. So that's, at least in my experience. So I try to filter it a little bit.
Yeah, I think that with the nanofat, what you do, you are destroying the fat a bit, especially, and that's bad, especially if you accept the fact that it's a composite graft that's allowing the fat to take. But with nanofat, you are going to get singlet and doublet cells, and you're going to have more of a fluid environment. So you are going to get some take of the fat, and I think that's why that's particularly helpful in facelift surgery. That's where a lot of the stem cell theory of fat grafting really applies, I think, because it's liquid and you don't need a lot of volume in the face in order to achieve a nice result. But in the breast, you really need the volume. That's going to be a volume-based procedure. You're not looking just to rejuvenate the skin a little bit, but you're looking to add the volume. And so nanofat might be perhaps not the most efficient way to go about it. But what I showed you in that video clip is exactly how I fat graft even today. And it surprises me that I don't really see more instances of oil cysts or masses, but you really don't. It incorporates into the tissues really well, and it's really a very safe and problem-free procedure.
Other question? Yes, Fabio?
Hello. Dennis, may I only thank you to connecting with us at 3 o'clock in the morning, in the night. Thank you very much. What time is in Grand Rapids?
4:15.
Okay, now the big change. Thank you very much for your professionalism. Thank you.
No more? Okay.
Hello, everyone. My name is Alexandre Mendonça Munhoz from São Paulo, Brazil, and I'd like to thank you, Professors Fabio Santanelli and Mark Clemens, for the kind invitation. In this talk, I'll talk about some aspects related to breast augmentation with smooth silk implants and how to stabilize these implants and avoid complications. This is my disclosure with Establishment Labs Motiva. We started our experience with smooth implants in breast augmentation in June of 2017 in Brazil, where we did the first cases here. And working in a scenario with no tissue adhesion and with very thin capsules leads to the development of new strategies in order to have an adequate implant stability. And what is our approach for implant stabilization in breast aug? We think that we have to individualize your action according to the patient's risk. And in private practice, you can identify different patient profiles with different risk for implant instability. We have least at risk, young patient, good skins, primary breast aug. And most at risk, patients with middle and old age, ptosis grade 3 and 4, sagging skin, hair operation, and post-bariatric. And so we use a score system with clinical measures that have an influence on implant stability and the result of breast augmentation surgery. Here we give scores ranging from 1 to 3 for each item, like age, body mass index, and reoperation. The higher the score, the greater the risk and the need to apply more effective techniques to stabilize the implant. And for low-risk patients, we usually indicate preoperative planning and pocket control. However, for extreme-risk patients, we have to do something more. And it's a good indication for crimes, meshes, reinforcing sutures, and thermocapsular hyphae. The intermediate risk represented by medium and higher risk, you can adapt your technique according to the patient. And usually we indicate reinforcement sutures and thermocapsular hyphae. And a precise pocket sizing based on pre-op measurement is crucial to have a predictable result. It's like a hand-in-the-glove fit. Tight pockets, you have to be conservative initially, and you have to create a more snug space, more than we usually do with a texture implant. If it's possible, you can use sizer, but with caution. And remember, control your pocket is mandatory. A tight and stable pocket dissection can avoid malposition, displacement, and rotation. This is a fact. And how tight should the pocket be? From a practical standpoint, the pocket should be very tight. Here you can see from the endoscopic access that there are no medial and lateral free space to the implant. In addition, when we pull the gland upwards, there are several folds in the implant, indicate that the pocket is tight. Having control of the pocket is one of the most important steps. In fact, surgeons who already used shaped implants already took special care in the pocket side to maintain stabilization and avoid rotation. In our experience, we have already emphasized the importance of tight pockets, premuscular or submuscular, but maintaining the post-op immobilization and avoiding any kind of manipulation. And for this objective, pocket control is crucial. And pre-op measurement should be always respected. We have risky limits, especially in the lateral anterior axillary line and medial parasternal line. You have to be conservative in this area. Based on the final base, define the superior, lateral, medial, and inferior limits, and you have to create a very tight pocket, less than 0.5 to 1 centimeter of the base of the implant. In the intraoperative, you have to be conservative again and start with small sizers or implant. With sizer is much easy. And if necessary, expand the pocket in specific regions, avoiding extensive and random dissection. From my point of view, it is easier and more predictable to increase a pocket that is very tight in the beginning than having to reduce one that is loose. And in risky patients, maybe it is necessary to create a stabilization structures with no observed stitches or even barbed sutures where you suture it in the EMF. But for larger implants, if you need to lower the EMF, maybe an upper of lower base flap will be necessary, associated with stabilization sutures sutured into the deep planes. Here you can see the pictures that with these sutures and with a lower base flap, we can suture it into the deep planes, and you can lock the EMF and avoid the inferior displacement of the implant. And for medium risk patients, besides an adequate pre-op planning and control your pocket measurements, we can also indicate reinforcement sutures and thermocapsular hyphae, as in this case of secondary breast hug. And here's an example of implant stabilization in a secondary breast augmentation in a patient with implant rupture, cap cone, and asymmetry. This is intermediate risk. Here you can see that both implants were ruptured. So in this case, we utilized an implant bigger, 1 centimeter than the old implant, and you applied restriction sutures with barbed sutures in the EMF and lateral aspect of the breast in order to stabilize the new implant. Here is an example to reduce the pocket size using a barbed suture. First, we identify the whole pocket and the area to be reduced, almost here 2.0 centimeters. Then we perform the thermal reduction like the popcorn technique described by Handkist, with the electrocautery and creation of a raw area. With this area, we can have a greater adhesion. And third, we closure this area, this burned area, with the barbed suture to have more stability. Here you can see the final closure with an adequate reduction of the pocket size. So you have a more tight pocket and according to the dimensions of the new implant. And here the patient in the pre-op view, 3 months of post-op and 2 years of late post-op showing good results with volume and symmetry, an adequate expansion of the lower pole and a smooth transition in the upper pole with adequate coverage. And for higher risk patients, we use reinforcement sutures and thermocapsular hyphae and sometimes associated with the Clemens technique. And here is an example, secondary breast segmentation, bilateral lower pole expansion and lateral displacement in a patient with skin laxity and ptosis. And this is our planning, secondary advocacy with Clemens technique associated with implant change and thermocapsular hyphae. And for a better assessment of the lower pole, it's important to operate the patient with the arms along the chest. Here you can see the previous implant, macrotexture, grade 4, in the subglandular pocket with instability and inferior lateral displacement. And this case is a good indication for crimes, composite reverse inferior muscular sling, and in our experience, we indicate in primary and secondary cases in order to control the lower pole. And the principle is simple, resection of the lower pole and breast fat. With a sizer, we evaluate the lower pole arc from base to the dome. We perform the dissection of the inferior muscular pocket and then introduce the implant into a stable pocket. Support points, and then we perform the Mastopexy with closure of the lateral and medial pillars and repositioning of the nipple complex. In this way, you have to protect the risky areas, the inferior and the inferior lateral aspect of the breast. For this object, we have to place the implant in the inferior submuscular pocket as a reverse dual plane technique, using the inferior sling of the pars externalis of pectoralis major muscle, the S4, S5, and S6. This is the Clemens composite reverse inferior muscular sling published last year in ASJ. And with the inferior basal pectoralis muscle flap, we can stabilize and support the implant into the EMF anterior axillary line. You can create a fixed and stable suture area in the central breast region. And also you can protect the implant from the most superficial plane, gland and skin. This is the reversed dual plane pocket. And after the implant insertion into the muscular pocket, we perform the support points to keep the nipple areola complex and the glandular tissue in a stable position and avoid glandular implant dissociation. Sometimes we perform fine adjustment of the skin over the breast cone and resection of the excess of the skin and perform the support dermal bridge. And then shaping the new breast, narrowing the base, bring the lateral and medial pillars to the central region, as you can see here in this video. And here you can note the pre-op with a wide intermammary distance and the immediate post-op. The pre-op with instability and longer lower pole, and immediate post-op with stability and shorter lower pole. And here you can note the outcome, the pre-op, the post-op in 2 months, and the long-term post-op in 2 years with an adequate distance between the nipple and EMF. And with the arms up in the pre-op with a wide intermammary distance, the post-op in 2 months, and a long-term evaluation in 2 years with a nice result in terms of volume and symmetry. And the outcome of the lower pole, the pre-op and the long-term evaluation in 2 years with an adequate distance between the nipple and the EMF. And similar results from the top, with a nice result and shape on the upper pole. And the dynamic evaluation through this video, late result 2 years, softness, adequate position, and lower pole stability. And to have this satisfactory and long-term result is very important to recognize the big five, the plane, to be more careful and to have an implant stability. And what is plane? P, patients with poor quality and sagging skin. L, large implants and with higher projection. E, early impact physical activity. I, EMF approach. And N, when you need to lower the EMF. When we have more than 3 associated factors, preventive reinforcement measures must be performed as there will be no implant adhesion. This is the plain risk factors. In conclusion, although a smooth silk surface is not totally smooth or not textured, its roughness are stated to be much less than other textured surface device, resulting in less inflammation and tissue ingrowth. In our experience and coming from the macro-texture school, care must be taken with the support and stability of the smooth silk implant, especially in operations and higher risk patients. You have to do a customized approach. With any implant, success can be achieved through a well-defined process of patient selection, precise technique, and post-op protocol. Thank you again for the invitation, and I appreciate your attention.
Any question in the audience? Any question from the moderators? May I ask you a question for the support you need for the cream, the technique you develop? Do you have any capsular contracture? Not capsular contracture. Do you have any breast animation using the pectoral muscle?
Good morning, everyone. It's a great pleasure to be here, and thank you, Fabio and Mark, for the invitation. This is a very interesting issue. We have been studying this aspect related to breast animation deformities. We have a follow-up with this technique in almost 6 years and a half. And now the patient at 3 months and 1 year after surgery, we have been doing animation tests in order to diagnose the bad and also to quantify the animation deformities. 96% of the patients have a very good results with minimal animation deformities. And in almost 4%, 4 to 5%, who have some animations. And the main risk factors for to have these problems is secondary surgeries, where you have a previous capsule and you suture the previous capsule into the superior border of the muscle. And I think with this maneuver, the contraction of the muscle, it's more strong and sometimes can have attraction into the glandular tissue and also into the skin. Anyway, in the other cases, and especially in primary breast augmentation, it's not a big issue. But in secondary and tertiary cases where you have the capsule and you suture the capsule into the muscle, it happens in almost 4% of the cases. The good news that I have a reoperative rate for breast animation deformities less than 2%. It represented 10 cases in 5 years. And once you indicate a reoperation, it's very simple to fix this situation. It's totally different for animation that we have in a skin sparing mastectomy. But here you just release some sutures and you can fix the problem of animation deformity.
Can I? Alex, this is Fabio. I just want to thank you very much to connect 5:30 in the morning. You were luckier than Dennis, 1 hour luckier. Thank you very much.
Thank you very much.
Yes.
Question? Yes, one question from the audience.
Yeah, thank you, Zlatko Zagreb. I didn't catch you. How do you fix, or do you fix at all that PEC sling, posterolateral PEC sling, when you take that sling to prevent descent of the implant? Do you fix it? Anyway.
Yeah, you have to create the inferior sling, inferior muscular sling. And on the inferior aspect and the inferior lateral aspect, it's just your dissection. You create the pocket in the dimensions of your implant, and especially the implant base. You don't have to fix anything in the inferior and inferior lateral. You have a stop here in the EMF and the inferior lateral. It's a very strong adhesion when you dissect into this area. The only points of fixation and in order to stabilize is the suture, is the supporting sutures. And I create a bridge of sutures between the upper part of the inferior sling into the glandular tissue. So you create a bridge from the inferior medial quadrant until the superior lateral quadrant, because it's the direction of the fibers of the pectoralis muscle when you create the sling. So you have a pocket that is totally closed, and the implant is stayed on the upper part in the subfacial pocket, but with sutures, the pectoralis muscle into the gland, and the inferior lateral part of the implant, the pocket, it's totally submuscular. So this is the principle of Crimes technique. The only sutures that we create is between the upper part of the muscle and the glandular tissue.
we heard from the previous speaker, we have the ADMs nowadays, which are a great helping tool for us, which were introduced in 1994. But you can do a reconstruction with ADM, but also adding fat. So that's another step more we can do with this kind of reconstruction tool. And of course, there are other very good tools. In our practice, we use TiLoop also. We used different brands. We have no conflict of interest with these companies. And also with this kind of meshes, you really can have a stable long-term result. And these are the cases in which we perform together with our general surgeon or gynecologist, which most of the time do the tumor resection. And of course, there are other tools like Braxton or Seri is not on the market anymore. And there are different kind of methods to fix these ADMs in the implant. One of the tools we all know is, of course, the lipofilling. The lipofilling is even a greater tool. Even there are some really, really important things you should always keep in mind. And there is not, and I will come to it soon, of course, you need to be careful not to perform it the wrong way. This was a liposuction done outside, and also this could happen with a wrong performed lipofilling or liposuction technique. And of course, with lipofilling, you have great tools to fill up the breast without additional volume given by an implant. And you should always tell the patient that there is probably more procedures necessary, so she needs to go under surgery more times. You can't predict, at least in my hand, the volume, because there is always a big resorption rate with some things you can't predict. Skinny patients are really a problem. It's a good tool to add in the irradiated patient, and we even can get smaller with the implants and give more fat, and this is one of the new steps we all think is the future, is the reversed expansion. So you always should learn from aesthetics and translate it to reconstructive. Of course, here there's a hybrid augmentation subglandular, 1 month post-op, where we filled up the missing space with fat, so you can add subglandular with really smooth implants. You can add fat to get even a better and more natural results. There is some other studies. This is from Professor Brandl from Regensburg. He mixed up fat with PRP. It's not allowed in Italy by law, but he is for sure, if you mix it 1 to 4, you get even a better rate of keeping the fat. And of course, we tried it in Austria in the clinic where I worked in Salzburg, and you can perform also this mixing PRP with fat to get even a more stable fat result. And there are some other components. Of course, we all know we worked in senological centers that the Angelina effect affected all of us and our work. And also in our region, there was a lot of request of doing, let's say, aesthetic reconstruction, especially in patients affected by BRCA. And also here, you should always keep in mind there's a high psychological impact on the patient, and there are very often young patients who didn't, who still have the whole life before, and they never asked for breast surgery, so they're not coming like an aesthetic patient to ask you, I want a breast augmentation done, but they just get hit really hard by this diagnosis, and you should always keep that in mind too, because they're not asking for surgery. So they are, in my eyes, you need to have them handle them like cancer patients. And I think always there should be a translation between science and surgery. So a surgeon should always try to move on and to keep himself updated to also try to do the best. And we in our clinic, the mastectomy are done by the general surgeons. And we try to do our best to have a good aesthetic results. We sometimes we can choose where they do the incision rates, and of course you can predict. You can even try to predict the outcome of the mastectomy, but I think you will any implant, any technique you choose, if the mastectomy is done wrong, you will fail with your reconstruction, because in that case you're done, and probably you need to move on to do a free flap. There is we also try to use different brands of implants to do mastectomy, and this is one of the first cases we did with a new kind of expander where we can have a really thin capsule in our eyes and do the reversed expansion. Let's say you fill up the expander, and then slowly you get him out. You get the water out, and you fill up the volume you get out with fat. So this is also one of the futures where you, at the end, probably you can remain without an implant or with a really small implant. Radiotherapy, of course, in my eyes, is a big issue in breast reconstruction. If you have an implant and you are planning a radiotherapy, probably you will get into trouble in most of the times, at least in my hands. And so in these cases, probably you won't accomplish your mission. And in that case, probably you will move on to do some free tissue transfer. Where, of course, not every patient is eligible for free tissue transfer. And there is another fact. There was a good paper in PRS also about the costs. Of course, the costs are almost the same in implant-based or autologous-based reconstruction, but you need to take sometimes in mind that if you perform a free tissue transfer or free tissue reconstruction, most of the time is done by one stage procedure. All of us who did some reconstruction with implants know that it's also a really high psychological impact for the patient to re-go to the OR all the times. So there is also responsibility for the implant producing companies, because we all had these disasters in our hand, removing old implants, and none of us or none of our wives or girlfriends want to have something like this inside. And of course, in conclusion, for us, hybrid breast reconstruction is a really good tool and an alternative to microsurgical free tissue transfer. We need long-lasting, stable implants, of course. We need to learn our aesthetic breast surgery knowledge, and we need to learn from that. We should combine techniques from different fields, and breast reconstruction, of course, should meet aesthetic breast surgery. And of course, not every woman is eligible for free tissue transfer. So thank you very much for your attention, and would like to take the chance to invite you to Bolzano, both in my hometown, for the 10th symposium next year. We always go skiing and drink some wine, so thank you very much.
Thank you very much. So we won't have time to take questions. It's a coffee break, but in the meantime there will be a lecture from Dr. Munhoz on endoscopic harvesting latissimus dorsi for immediate breast reconstruction. It's a very interesting lecture. So you have the choice, coffee break or a bit of science. Thank you.
Welcome, and thank you for joining this GC Aesthetics Symposium. We have the honor to have with us Dr. Joaquin Munhoz. He's based in Barcelona, and he's a medical doctor specialized in breast reconstruction and plastic surgery. He is a member of several committees, he has several publications, and one of course for this topic, the topic of today. And it's an honor to have him today. And the topic of today is endoscopic latissimus dorsi harvesting in immediate breast reconstruction. And as you know, in GC Aesthetics we have the GC Academy, so we are key in education. So without further ado, I would like to say thank you again to Dr. Joaquin Munhoz, and whenever you want, the floor is yours. Thank you.
Okay, thank you. Thanks to UCSD for the invitation. As you said, we want to talk about endoscopic smooth her best for immediate breast reconstruction, for partial breast defects, and also for mastectomy defects. If we take a look, these are not uncommon situations in breast conservative therapy when there is not an oncoplastic technique associated, no replacing and no displacing technique associated. So if we take a look to general considerations in breast conservative surgery, we need an accurate approach, in which case we need an accurate presurgical multidisciplinary operation. We have to work close with oncologists, close with pathology, close with radiologists, in order to have a good approach for each case. We always use a wide guide decisions, a guide.
Welcome and thank you for joining this GC Aesthetics Symposium. We have the honor to have with us Dr. Joaquin Munhoz. He's based in Barcelona and he's a medical doctor specialized in breast reconstruction and plastic surgery. He is a member of several committees, he has several publications, and one of course for this topic, the topic of today. And he's an honor to have him today. Welcome and thank you for joining this GC Aesthetics Symposium. We have the honor to have with us Dr. Joaquin Munhoz. He's based in Barcelona and he's a medical doctor specialized in breast reconstruction and plastic surgery. He is a member of several committees, he has several publications, one, of course, for this topic, the topic of today. And it's an honor to have him today. And the topic of today is endoscopic latissimus dorsi harvesting in immediate breast reconstruction. And as you know, in GC Aesthetics, we have the GC Academy, so we are keen on education. So without further ado, I would like to say thank you again to Dr. Joaquim Munhoz, and whenever you want, the floor is yours. Thank you.
Okay, thanks to GC for the invitation. As I said, we're going to talk about endoscopic latissimus dorsi harvesting for immediate breast reconstruction, for partial breast defects, and also for mastectomy defects. If we take a look, these are not uncommon situation in breast conservative therapy when there is not non-complastic technique associated, no replacing and no displacing technique associated. So if we take a look to general considerations in breast conservative surgery, we need an accurate approach, in which case we need an accurate presurgical multidisciplinary evaluation. You have to work close with oncologists, close with pathology, close with radiologists, in order to have a good approach to each case. We always use a wide guided decisions guided by the radiologist. You need an accurate intraoperative margin status, and you have to be concerned about radiotherapy and chemotherapy effects on breast reconstruction. If we take a look, just endoscopic harvesting for latissimus dorsi for immediate breast reconstruction is a well-documented and well-published technique with available data about oncologic security, with predictable results related to post-radiotherapy effects on the reconstruction, and with several benefits from the classical approach, but really it's not widespread in use. We started to do it just 10 years ago with a publication on the European Journal of Plastic Surgery for breast conservative therapy. And the main indications, in our opinion, and in opinion of other authors, are defects located in union of upper quadrants, union of external quadrants, of course, upper external quadrants, or retroareolar location in small breast. It provides autologous tissues for reconstruction with minimal anatomic variations and allows the reconstruction of a wide range of defects, from lumpectomy to hemimastectomy, depending on tumor-breast ratio. It achieves excellent results of reconstruction in breasts of cube size A or B, and in larger breasts is most effective in defects located on upper outer quadrant or at the union of the outer quadrant. And of course, this endoscopic approach offers you a scarless technique in comparison of the classical one. If we take a look, this clinical case is a 29 years old female with a infiltrative ductal carcinoma on the left breast. In red, we can see just the effects of the chemotherapy, the residual lesion assessed by the RMBI, but we used to take the initial disease on the breast, so we'll get a large defect. You can see the defect. It's almost a full quadrantectomy, and we always use a pectoral approach. Then for the reconstruction of the defect, just for harvesting the latissimus dorsi by endoscopy, we use a double approach, an axillary approach through a lymphadenectomy approach, and another one, a dorsal back approach at the level of the summa manifold. It's only just 3 or 4 centimeters in length. Some authors doesn't describe this approach, but in my opinion, it makes more easy, more fast, and more accessible to get a correct hemostasis, especially on the lower back perforators. Here in the video, we will see just few images of the endoscopic dissection. You can see the dissection of the superficial layer. We use an endoscope of a stores 30 centimeters in length with 30-degree angulation. Now we are dissecting the superficial layer. You can achieve a good hemostasis and separating the latissimus dorsi from the teres major. Here you can see the dissection of the lateral border. Underneath there is a serratus, the serratus major, the anterior serratus. Sorry again. Now we are dissecting the deep layer of latissimus dorsi with some keratin with the hemostasis of the dorsal back perforators. And finally, we're dissecting here the deep layer. Just we're finishing our dissection and we can identify the descending branch of the anterior serratus. Here you can see how much muscle can you recruit and how much can you fill the breast. In the second peak, you have the muscle, the flap inset on the defect and filling the full defect. Of course, we'll face off radiotherapy effects. So in our experience, we always recruit 30% approximately more than the muscle that we need to fill the defect in order to anticipate the unwanted effects of radiotherapy like more fibrosis and volume loss of the breast. We can see results just 1 month post-op and finally just 1 year post-radiotherapy with a good breast shape preserved. Another case, 36-year-old woman with a ductal infiltrative carcinoma on the union of the upper quadrants. You can see the resection, the flap inset on the defect and filling the defect. The results 1 month and 1 year post-radiotherapy. Here you can see the results 1 year post-radiotherapy on the tumorectomy side with fill of all the defects in time. And a third case of breast conservative therapy with a diagnosis of infiltrative carcinoma initially of 11/8 centimeters and with a final fibrosis area post-chemotherapy of 7/5 centimeters in length. Of course, with no involvement. And we see the results of 3 weeks post-surgery with a small scar on the back and the result 17 months post-surgery and radiotherapy. So just, I know the use of muscle is controversial, but we don't find just a difference in shoulder abduction and shoulder flexion between those patients that have gone or had undergone just mastectomy or mastectomy plus latissimus dorsi reconstruction. It provides an autologous tissues for oncologic resections. It allows the filling of wide spectrum of defect from simple tumorectomy to defects equivalent to hemimastectomy. It's a scarless technique comparing with the classical one, and in my opinion is an excellent tool for oncoplastic surgery, especially in those patients that will undergo radiotherapy, to keep in mind. If we talk about mastectomy defects, these are some examples of implant-based reconstruction or expansion device reconstruction. They are not good, and this situation are not uncommon for those patients that has undergone radiotherapy or not. Just of course, the flap is still gold standard in immediate breast reconstruction, but sometimes things go wrong, especially in those DIEPs that you don't have a good venous drainage or the DIEPs that are radiated. And that's a thing that we have to concern about, because indication of radiotherapy after mastectomy and reconstruction are increasing strongly in the last years, just since maybe just 10 years ago that we only radiated those patients with tumors larger than 5 centimeters or 3 or more lymph node affected. Now we are radiating just those patients with one lymph node affected or tumors no larger than 3 centimeters. So this is the trend, and we have to manage to handle this. So for that, just post-mastectomy radiation therapy appears to be associated with increased risk of reconstruction-related complication, implant removals, fat necrosis in case of autologous reconstruction. And that's not clear that this radiation of post-mastectomy radiation reduce or not the patient satisfaction, but it seems to be clear. For that, the immediate single stage endoscopic latissimus dorsi breast and nipple reconstruction, just which patients or how we do just the patient selection. For patients who were indicated for patients with lower body mass index, only 25, lack of abdominal tissue, A or B breast cup, or those patients concerned about future pregnancy or refusing scanning an abdominal donor site. And of course, the needs for radiography is still a focus of controversial. Here show you just a video of a skin sparing mastectomy through a perioral approach. The dissection of the breast. The full mastectomy, the skin sparing mastectomy, and the stitching sutures for the pathology intraoperative report. You can see the defect, the flap of mastectomy. And so we start our dissection. We always identify the thoracodorsal pedicle, we transect the thoracodorsal nerve, and we transect also the humeral insertion. Just the flap is just pedicled by the vascular pedicle. Here you can see an image of the lower back approach with this skin Irland paddle. You can see the dissection of the medial border between latissimus dorsi and trapezius, the section of the lateral border from the dorsal back approach, the section of the deep layer. You can see the descending branch of serratus anterior. Finally, as I told you, the transection of the humeral insertion, a review for hemostasis at the insert of the flap through anterior axillary line on the defect, and finally, the implant. The implant will be full covered. Cranially by the pectoralis major, caudally by the latissimus dorsi muscle. And finally, in this case, the nipple reconstruction with a classical trilobular flap. This is the muscle that you can recruit just in order to cover the full implant under the flap of mastectomy. And this is our result. This technique is especially useful when you need a wise pattern in the skin sparing mastectomy. Just you have a scar, but you have the implant with a full coverage. You can see the scar of the donor side. Another result of skin sparing mastectomy, in this case, was not radiated because the lymph node biopsy was reported negatively, and it was a 2-1A on tumor size. You have the results, you're 6 months post-surgery. You can see the scar on the back, a little one with 44 centimeters, and the results 1 year post-op. Just some advantages of this technique in comparison with the mesh-based reconstruction is that you have less inflammatory response, you have autologous coverage of an implant, you have more thickness of the flap. It will be a very good result, and in my opinion, better long-term results in terms of capsule contracture. Of course, we will phase off all the wanted effects of radiotherapy on the breast reconstructed, but it seems to keep far away from the dramatic case of capsule contracture. But on the other hand, we can reconstruct the tail of the breast with this insetting of the flap through anterior axillary lane, and avoiding the gap that are apparent in some just implant-based reconstruction. You can see the results after radiotherapy and the lack of the scar on the back. In this case, and another case radiated was a young female. This is a pic of the surgery. She undergo skin sparing mastectomy, latissimus dorsi endoscopic approach plus implant reconstruction and lymphadenectomy. This is an image of 4 weeks after surgery. The lack of skin, lack of the scar on the back. And of course, if you take these pictures 1 year post radiotherapy, you can find some capsule contraction and migration, cranial migration of the submammary pole. But this was just resolved with a minimum surgery, just with a submammary approach, release of the capsule contracture, replace of the implant, and release of the submammary fold. this is an example of revision surgery. You can work with a lot of confidence. You can detach the flap of mastectomy from the underneath muscle and work on the submammary fold, work on the breast shape, and take an implant replacement. In other cases, you can undergo a secondary surgery and do a wise pattern just to obtain some symmetry with the contralateral breast. And this is another example of nipple sparing mastectomy, a bilateral nipple sparing mastectomy, and immediate bilateral breast reconstruction with this technique and implant. This is a result just 2 months post-surgery and a result 1 year post-surgery. Just keeping a good breast shape and keeping a good covering of the implant with a sense of rippling. For summary, I think it's really a workhorse for oncoplastic surgeon to keep in mind, especially in those patients that you know before surgery that will undergo radiotherapy, do a pathology report or do a MBI assessment. Of course, you have to have an accurate assessment about spot practice of the patient, especially in climbing and hiking, and in front of classical approaches, Scarlett's technique with minimal dressing needs, less postoperative recovery, less pain. The Oswald Hospital releases in 3 days. It's an assisted endoscopic surgery. You need a learning curve, but it's not so hard like robotic surgery. And it's just assisted surgery, not a pure endoscopic surgery. Seroma rates, really in comparison with the classical technique, are very similar. There's not difference between them. And this Scarlett's technique is well accepted by patients in terms of aesthetics, an aesthetic of the breast, but also an aesthetic of the donor side. The reliability of lower skin pedal is well documented, and you have predictable results. The adding thickness and adding quality coverage provides a confidence in case of a recent surgery, as I showed you before. And the inferior dorsal scar allows the surgeon to reconstruct the nipple area and to save another surgical time if it's needed, in case that you cannot do a nipple sparing mastectomy. And that's all. Thank you so much.
Good morning. We are now in time for the second section. The title is Role of Autologous Tissue in Breast Reconstruction. The first speaker is Professor Clemens, which will speak about the practice shift, prophylactic LV bypass with immediate breast reconstruction. Please.
Good morning. ADM assistance, pre-pectoral breast reconstruction, a shift away from textured implants. All of these represent what I would define as practice shifts, major practice shifts just in the last 10 years. I would define that as, of my 26 partners at MD Anderson, when greater than half of them have a very fast adoption within a 12-month time period. And so as I was thinking of possible topics for presenting to you today, I really wanted to address prophylactic lymphovenous bypass, which I think is the next big practice shift that I'm seeing in our own practices at our hospital. For disclosures, I receive no financial reimbursement from any company. I want to acknowledge MD Anderson does participate in approximately 1,200 clinical trials, of which Mentor and Establishment Labs are 2 of them. What we're going to be covering today is the concept of lympha, as well as a focus on the technique, outcomes, and how you can build a program at your own hospital. And what I really want to impress upon you today is this, which is actually my conclusion slide as well. And I want to reiterate it multiple times, that lympha procedures should be considered in all patients undergoing axillary lymph node dissection. Both lymphedema treatment and prevention are highly dependent, though, on surgical technique, and I'm going to describe that, and that tracking of outcomes is critical for improvement and setting patient expectations. So what is lympha? Lympha truly is the prevention of a disease. We know that there is no curative treatment for lymphedema. It is a lifelong subjectation to compression garments, decongestive therapy, as well as activity modification. We can ameliorate it, but we can't get rid of it completely. So why don't we just prevent it before it's ever occurred? Therefore, enter lympho, which is lymphatic microsurgical preventative healing approach. I'm going to refer to it throughout the presentation. Also, you may have heard it referred to as prophylactic repair of vessels in the axilla with immediate lymphovenous bypass. And this is the idea that at time of axillary dissection, before the patient has developed lymphedema, you prophylactically hook up the lymphatics in the arm. You have your breast surgeon do reverse mapping, axillary reverse mapping, to be able to identify the key drainage system of lymphatics in the arm, and then you hook them up into a localized vein. The technique usually involves injection of lymphozurin. It usually is into the anterior antebrachial fossa, about halfway down the forearm. And you can use ICG if the patient has a sulfa allergy, or if the lymphozurin is being used for a sentinel lymph node biopsy, then you want to use ICG to determine the drainage ports for the arm. Axillary dissection is important to have a communication with your breast surgeon to identify the main lymphatics. And you can see in the picture that I've put up on the wall is that you can see the lymphatics where they're occurring coming up from the arm. These are the main drainage patterns. If I was to tell you what I find most commonly, it's one large single pipe of lymphatic down deep, close to the axillary vessels, and 2 paired superficial at the surface. Now, you must communicate with the breast surgeon. They must mark this ahead of time and identify it intraoperatively. However, if you get used to this, if after you've done several dozen, you'll start to notice that you can actually see the lymphatics without even staining. And so blue staining is not a critical criteria for lymphatic selection, but is critical early in your learning curve. Now the target is subcutaneous venules. That's about 80% of veins can be utilized right next to the lymphatics. Serratus anterior vein, 15%, and a thoracodorsal I use at about 5%, but I would argue only take one of the thoracodorsal veins. You want to leave the other one, as well as the thoracodorsal artery, as a bailout for latissimus muscle should you need it. My average number of anastomosis ranges from 0 to 5, but the vast majority, very, very vast, is 2. Configuration is end to side and side to end, side to side, multiluminal, and you can see it demonstrated, and I would say probably in about 30% or 1 in 3 cases, a 1 millimeter lymphatic I can actually couple. This entire thing takes like 20 minutes to perform. The technique usually involves a Mitaka microscope. This goes up to a 50x magnification, which is very helpful since many of these lymphatics are usually about 0.15 to 0.2 millimeters. Optimize your positioning, particularly if you're not used to super microsurgery. All of them utilize 11-0 suture, and suture direction can either be from lymphatic to venule or vice versa, depending on whatever easiest for your setup. And I also like to be able to use a Prolene suture, a 6-0 or a 5-0, to actually go into the lumen and facilitate suturing, and I'll show that in a video. Now the goal is long-term patency and efficacy. I feel, this is my opinion, that approximation, just putting the vessels together with the lymphatics, is inferior to a true anastomosis. But this is an argument that I have with my breast surgeons on nearly a weekly basis, because in the breast surgery literature contradicts the plastic surgery literature right now. The breast surgery literature says that just with a big suture, you can suture a vein to a lymphatic, and my surgeons will sometimes use a 2-0 vicryl, big, huge whip stitch. And I want to show this picture of what happens when you do that. You get obliteration of the lumen in the long term. These are in animal models, whereas our goal is patency of the lumen. We actually want to have lymphatic flow from the second that we establish it. Usually on average, suturing these together has about 3 to 4 sutures per anastomosis. So how do these patients do? Well, Baccardo in 2014 demonstrated a 4% lymphedema rate with 4-year follow-up. Feldman in 2015 demonstrated a 12.5% lymphedema rate in comparison to patients that didn't receive this, having a 50%. Jorgensen in 2015 demonstrated a relative risk of 0.33. What do all these say? Is that prophylactic lymphovenous bypass is successful and significantly decreases the rate of lymphedema in nearly every study that it's been looked at. However, I will throw in Ahmed 2016 in the breast surgery literature demonstrating that reverse mapping alone also could decrease lymphedema, but they still were reporting about 24% lymphedema rates. So they're still not getting as low as what prophylactic super microsurgery anastomosis can do. So what are we doing at MD Anderson? We have a prospective evaluation, and the principal investigator is Mark Shavarian, which is our lymphedema specialist. I'm going to show you my personal experience. These are all my cases. So I've done it in 28 patients over the last 4 years. I've been able to actually successfully perform it in 26. That's a 92% success rate. And my average follow-up on those patients is 9 months with a range of 4 to 31. All of them had axillary dissection. All of them would go on to radiation therapy. My average BMI is 32, making these all high risk for the development of lymphedema. And 4 were inflammatory breast cancer. To put that in perspective, our invasive ductal carcinoma has a 25 to 30% lymphedema rate. Our inflammatory breast cancer has a 50% lymphedema rate. Those are real numbers. And yet my lymphedema after that is 3.8%. For patients not treating with this, 32%. We're truly preventing lymphedema. This just demonstrates how we approach the patients ahead of time, preoperative volumetric analysis with parameter testing. You can do simple circumferential testing with tape, but there's a lot of unreliable inter-rater reliability. This just demonstrates an example in that inflammatory breast case where my breast surgeon, Dr. Kelly Hunt, you'll meet her tomorrow, leaves very nice lymphatics. These are very easy to anastomose. Again, 1 and 3 you can couple. And it's very easy to see. She likes to mark them with either a clip or will actually put a suture tagging at time of axillary dissection. This just demonstrates the anastomosis in this patient, and I can tell you with 1-year follow-up, no evidence in a very high-risk patient. I'm going to jump forward to the next video. This patient has a completion axillary dissection. We're going to do a robotic-assisted deep flap reconstruction with simultaneous lympha at time of surgery. And so in these procedures, we'll do a robotic dissection of the pedicle of the deep flap. This takes on average 45 minutes to do robotic assisted. The additional cost to the patient is about $800 US. You can see we can limit fascial dissections to 1.5 to 2 centimeters, still dissecting out a 14 centimeter pedicle of the deep flap. Here I am doing proline stenting of the lymphatic to the vein, and you can see it very much facilitates manipulation of these very friable and small vessels. This is about a 1 millimeter anastomosis. And you can see how she looks postoperatively after her deep flap reconstruction, mastopexy, and immediate lympha. In a morbidly obese patient, you would expect some evidence, and she has none of lymphedema. So where does this go in our toolkit? Well, we can see that lymphovenous bypass to treat lymphedema statistically significant lowers lymphedema rates when performed, and now we can add to it lympha, which actually is able to maintain patients not developing lymphedema even in the long term. And how to do this in your own center, it is important to have an infrastructure in place, resources, outcome metrics to follow these, as well as a referral base, and it's important to educate your community that this exists. Since it's a new technique, most don't even know that they can get this. So in conclusion, you can refer to these manuscripts from MD Anderson for further information that I've talked about. Lympha procedures should be considered for all patients that are getting axillary dissections. It's highly dependent upon surgical technique, as well as tracking of your own outcomes are important when quoting these rates to patients. Thank you so much, and we hope to see you at MD Anderson next year.
Thank you, Mark. Are there any questions?
Marcia.
Mark, congratulations for this beautiful presentation. And I have 2 questions. The first one is, how do you select the patient for lymph or prevent? Because we are trying to select by BMI, aggressivity of the tumor, biological factors. I don't think all of them need probably, but this is something that has to be examined in the future. And then second question, what is your personal opinion about the risk of metastasis with this procedure?
So great questions. All of those that you mentioned are risk factors for the development of lymphedema, and you could highly isolate a very select cohort that would greatly benefit from this procedure. For instance, everything that you mentioned, and I would throw in inflammatory breast cancer. But in my practice, my cutoff is everybody getting an axillary dissection. So at that point, everybody getting an axillary dissection, I think, benefits from this very quick, easy procedure. Some breast surgeons would go a step further and say, for instance, Suzanne Klimberg recommends doing this for all sentinel lymph node biopsies. In my 11 years at MD Anderson, I have never seen lymphedema a single time from a lymph node biopsy. Therefore, that doesn't come into my practice. And I don't think that that needs to be performed at that rate. But I think that all axillary dissection patients benefit from this. The question of metastasis is real, but I think theoretic at this point. I think that that's one of the reasons why we need to follow these prospectively. I would encourage you to follow your own patients, and we follow them prospectively at ours. But I can tell you, after doing this for 4 years, I don't believe that it increases that rate. It's not reflected in our data, but it's very important for us to follow the data so that we can be reassuring to our patients.
I would like to ask you about the Sentinel procedure. You know, how these guys, they do it, how they decide when they should do it or not, because this is, I think it is this is the critical point. You know, what's your opinion about that?
I see. Yeah, so if you look at the early studies of Lympha, they would say that they were only able to accomplish this in about 70% of patients, or about 2 in 3. 1/3, they just couldn't find the vessels. My rate was 92%, but I have to admit that those are with breast surgeons that are highly invested in this, are looking for the recipient lymphatics as they're dissecting and tagging them for me as they come across them. So our breast surgeons are a critical aspect to success of identifying them. That said, if you can't find them, that's a good sign. That means they were so small that you couldn't see them, and that's probably not a patient that you're going to have a problem with lymphedema. If there's an enormous pipe that you just leave and don't hook up, in my mind, that's a higher risk for lymphedema than if they had such small ones you couldn't even see. Then they probably have superficial collaterals and they're not going to get lymphedema. That's just my opinion, though.
And what do you think about mapping the arm?
Axillary reverse mapping, that's for another talk. But I'll be happy to send you the papers on that.
Okay, let's go on next speaker, Professor Santanelli di Pompeo, Freestyle DIEP flap breast reconstruction.
Thank you to myself and to Mark Clemens for the invitation at the meeting. And I'm going to invite you to join in next September, 1st October 2022 in Houston. Save this date. Okay, so deep flap freestyle versus CT angio selection of the dominant perforator. So I was interested by the literature by looking at time. But then this paper from Figus stated that the quality of the evidence is poor and has a very limited external validity. And there is need for well-designed and conducted randomized studies. And the question is it possible for an experienced surgeon to safely and repeatedly raise the deep flap without the help of CT angio? We tried to answer this by making a study. So we took advantage of our experience and we developed a freestyle selection algorithm after 500 consecutive deep flap breast reconstruction based on the concept that the vein outflow is the key issue to harvest a well-perfused large flap. The dominant perforator is considered the one with the largest vein, selected under direct visualization. What if this perforator is the cranial border of the flap? So we don't know if it's inside or outside the flap going. It's easy. Shouldn't be used if there is a major bleeding under the scarpa fascia once you dissect your flap, because it means that the perforator, the border of the flap, goes out and not into the flap. Most of the perfusion goes out. Contrary, if you cut your flap and you have a minor bleeding above the scarpa fascia, then it means that most of the perforator goes into the flap and perfuse the flap. Then the third point of the algorithm is in case of vein perforator of equal size, what to do. If the flap is a unilateral flap and we have a large perforasome number 3, choose the medial largest vein perforator because you give bad perfusion to the last part, to the most medial part of it, or possibly add a second perforator. If it's a small perforasome number 3, then choose the lateral or the medial, which may be easier or tedious largest vein perforator. Bilateral flap just behave like a small unilateral flap with 2 perforasome only, so you can choose either the lateral or the medial. The fourth point is when to choose a second perforator, when to add a second perforator. It should be harvested according to our experience, always when there is no or limited muscle damage. Like in this case, 0.5 millimeter of fibers makes no sense at all not to carry 2 perforators altogether and to improve the vascularity. In flaps with large perforasome 3, as we saw before, we need to implement the perfusion and add the second perforator. Well, pay attention that sometimes it's better to take two perforators in parallel than in series, because in parallel you cut a little bit of mass, but you don't damage the nerve if the nerve is in between two serial perforators on the same row. So we developed a double-blind prospective study with primary endpoints, length of operative time, postoperative complete perfusion-related complication rate, and some secondary endpoints, like the agreement rate of intraoperative findings versus the CT angio-based selection, and variables that may affect operative time and complication rate. The inclusion criteria for the material were under consecutive deep flap breast reconstruction, were enrolled during 5 years, and immediate or delayed, both, unilateral only. The exclusion criteria were bilateral flaps, algae to iodinated contrast media, renal impairment, claustrophobia, flaps not performed by the senior experienced author. So the matter, we select the material into groups, 50 deep flap breast reconstruction with the freestyle approach. All patients gave their informed consents to undergo the freestyle approach with preoperative CTA blinded to the surgeon. The senior author intraoperatively selected the largest vein perforator following the freestyle selection criteria. The senior author postoperatively blinded select the dominant perforator following the CT angio guided approach on same patient. Group B, 50 deep flap breast reconstruction with the standard CT angio based approach. So we decided to use as a scanning method, scanning material, the same machine that has been used with 64 slides, because it's the same on literature, and the results are more comparable. O2 is not the most advanced. The two groups, Group A and B, are demonstrated to be homogeneous with all of these variables. And these are the results of the primary endpoint, the operative time. The use of the freestyle statistically lowered the operative time in Group A. The complication rate with the univariate analysis, complication in Group B was increased, which is the CT angio guided, but not statistically. So the method went on by dividing the material into groups. The group of flaps and patients with agreement of the dominant perforator between the CT angio and the freestyle, and the group of patients where there was non-agreement between the two selections. The two groups were not homogeneous only for smoking history and contralateral symmetrization. All the other variables were comparable. That's the result of the secondary endpoint. The operative time, according to the multiple regression analysis, varied and was increased by the CT angio guided approach, the increased BMI, and the harvest of more than one perforator, and that was statistically significant. Among the complication rate, the multiple regression analysis failed to confirm that any of the variables that are listed can be statistically increase the complication rate. So in conclusion, the freestyle approach proved to be a useful tool for guiding deep flap harvest with good sensibility in detecting the dominant perforator suggested by CT angio without statistically increased complication rate or operative time. In absence of CT angio facility, our freestyle algorithm can serve other breast microsurgeons, even if less experienced, in performing deep flap transfer. Could it work for experienced surgeons to safely and repeatedly raise deep flap without the help of CT angio? That was the question in the beginning, and that's probably the answer. You didn't put the video, the audio. Sorry. Thank you. It was yes. It can.
Thank you, Fabio. Questions for the audience?
Fabio, I have one. How does the freestyle approach affect elevation of the superficial systems, such as the SIEA?
Yes. Okay, that was probably missing from the approach, but it's not a freestyle approach, but it's my approach. We always go for the superficial vein. Whenever possible, we add the superficial vein as a double draining system. And we have a very low, I would say that the overall failure rate of deep flap, it's 0.7%. And the partial necrosis, which is considered to be up to 1 centimeter, 1 cubic centimeter, detected with follow-up in ultrasound, it's about, I think, 10%. That's it, which is a minor revision under local anesthesia, it means. But we always try to give superficial and deep drainage, both ways.
One single question. So at the end of the day, would you suggest to having CTA or not?
Well, I wouldn't suggest one or the other. I would suggest to do what you really feel comfortable doing, but you have to consider that by using the freestyle approach, if you feel self-confident, you don't lengthen the time, statistically you can reduce it, and you don't increase the complication rate. That's what I can say. So if you are in a setting that you cannot take advantage of the CT angio, which may happen also if you have the CT angio facilities, because sometimes it's operator dependent. It does not depend from you anymore, the decision which one is the really best perforated dominant. But it depends from the technician that has done the exam, which is not always at the top of the standard. So I think it's an extra more bias that it's between you and the dominant perforator, which I personally don't like, according to me. But I wouldn't suggest to do one or the other. The one you will feel more comfortable. Yes.
Stefania Tenna, Roma.
I met you
yeah, we have seen a few times before.
Yep.
Following Dr. Clemens' question, I didn't understand. Have you ever switched to a superficial inferior epigastric artery flap during your freestyle approach?
You mean the whole flap?
Yeah, on the superficial system.
Oh, yes, and I regret. Yes, but there is a point which is different. I mean, the SIA is more risky if you are not very experienced to do. First of all, I selected only for unilateral flaps, the SIA, never for bilateral. Oh, sorry, the other way around. Only for bilateral flaps, so very small, never for unilateral, because I think that the angiosome, the superficial, it's quite small for a deep flap. So I use it for bilateral, trying to reduce even more the damage and the time of the operation length. The problem is that with SIA, your pedicle is short and coming out from the border of the flap. Very easy to kink. As long as you orientate the flap a little bit, it kinks immediately. Deep flap is much more flexible because you have your pivot point here, and you can rotate the flap as much as you like, and there is much more compliance in kinking the pedicle. So from my point of view, if you are not extremely experienced, it's 100 times safer to do deep flap than a SIA flap. And I learned, unfortunately, on my experience, because I have 99.7 success in deep flap, it's poorer in SIA. And then I learned why.
Mm. Thank you. Any other? Yes, please. Just a moment, just a moment.
Just a
microphone.
Just a minute.
Plastic surgery, Patrizia Del Re from Salerno. How long does the surgery last?
Depends of the...
more or less medium.
Oh, our mean average time it's 4 hours, and for unilateral deep flap, including symmetrization, I don't remember, it's 4 hours 20 or 4 hours 40, something. 4 hours 20 minutes, I think. It's among 700 cases. Mm-hmm. It's 6 hours and a half for bilateral, done in 2 teams. I never do bilateral all on my own. Also to train surgeon and to go.
Okay.
Okay.
Thank you, Fabio. So we going on with Eagle. Combining conjoined DIEP flap with lymph node transfer.
Let's see. I think I advanced it. Thank you. Good morning. Well, again, I would like to thank Doctors Fabio Santanelli and Mark Clemens for the invitation to this conference. This is actually my first international live conference since the pandemic, so I'm very excited and grateful to be here. I'm Dr. Aldona Spiegel, and I come to you from Houston, Texas. So I would like to talk to you this morning a little bit about conjoint deep flaps and vascularized lymph node transfer. You heard already about preventing lymphedema, but what do you do in patients that already have lymphedema? These are very difficult cases, and as we know, the deep flap is a gold standard for autologous breast reconstruction. But this is the type of situation where you need a lot of skin, and frequently patients don't have a lot of abdominal tissue that is excessive. So you really have to maximize it. Also, these patients often have obviously a large skin defect, so you want to make a sensate breast reconstruction that actually has also a lymphatic outflow. So in order to address this problem, really there's a lot of factors that we want to consider. We're completely re-establishing the footprint of the breast, the volume, and the skin envelope. And this is why I believe the conjoint deep flap and vascularized lymph node transfer is a very nice solution to these problems. So just briefly in this presentation, I'd like to go through the flap design, how this affects the abdominal donor site. I'm going to discuss the difference between stacked and conjoint flaps, as well talk a little bit about the options for intraflap anastomosis, and then describe the lymph node transfer technique. So when we talk about recruiting this large amount of skin from the abdominal area, oftentimes we really don't think as much as we should about the abdominal donor site. So planning your flap and deciding where those incisions are really depends on the patient's trunk, where their kind of waist is, how much excess abdominal tissue they have, but also if you do decide to do preoperative imaging, you can look at your perforators and decide how low you can make your flap to optimize that low scar and make this as maximally aesthetically beneficial for the patient. So this patient is an example that you can see her lower abdomen is really very tight. She's actually a nulliparous patient, so she's never really had expansion due to pregnancy. And you can see that the entire lower abdominal tissue was used to recreate her breast to make it symmetrical with the contralateral side. Now, what's the difference between conjoint versus stacked flaps? It's a little bit of a huge difference, and sometimes it gets confused in nomenclature. So these are both dual pedicle flaps, meaning that you're recruiting the entire lower abdominal volume, but stacked flaps traditionally are divided into two hemi-abdominal flaps, and they have two separate anastomoses to the IMA. The conjoint flaps, on the other hand, have a single anastomosis to the IMA, and there's actually an intraflap anastomosis. So the tissue is transferred en bloc and not split. So the advantages of conjoint flaps, in my mind, are several. Number one, this is exactly for those patients that really do need a lot of lateral breast volume because you're not tethered by the anastomosis of the second flap. You really have a lot of freedom in inset. There's also obviously better perfusion because you're doing a dual pedicle flap. There is no zone 3, so your fat necrosis is minimized. And I perform these procedures in a rib-sparing fashion because I don't need a lot of IMA length because I'm only doing a single anastomosis versus a stacked flap. Traditionally, the rib has to be removed. I believe this is a better option for the patient. Now, the way that the intraflap anastomosis is performed is actually with a coupler. Traditionally, these arteries are quite small. They're between 1.2 to maybe at most 1.5 millimeters, and they're extremely elastic, so they're very amenable to coupling. So it's a very fast procedure. Of course, the vein is very easy. It's usually a 1.5 to a 2 millimeter vein. So you can quickly do your intraflap anastomosis, and the way I do that is with the flap turned upside down. That's the first anastomosis I do, and then I turn the flap down so the skin is up under the microscope to perform the IMA anastomosis. So it's helpful to understand what options you have. It's a little bit freestyle options as you're dissecting your flap to determine how you're going to connect these two sides of the flaps together. So you have first in blue the actual perforators that are ligated to provide inflow to the flap. So essentially you can either use the distal lateral row or the distal medial row. And essentially you want to use the largest caliber, so you're actually anastomosing the rows themselves, not the perforators themselves, because those are really, really small. So you're really trying to figure out how you can match those sides together. So if you think about it, you have basically 6 permutations if you are using the SIEA also as an option for perfusing the contralateral side. And so the first type A is the most common one, and this is actually where you're using the medial perforator. It's going to right here, and you're connecting it to the distal end of the lateral row. And this is in my hands probably 80% of the time. This is a nice way to do this when the anatomy is adequate. And this is kind of the picture of what you would see under the flap with the two vessels connected as you're trying to do your intraflap anastomosis. The next one is using the lateral row perforator to, again, that distal lateral row. Again, this is basically this to that, so your flow comes through this and then to the other side. Type C is when you're actually using the superficial vessels for your contralateral side, again, coming into that same lateral distal row. And then the same thing, but you're using this, the medial distal lateral row, and then using the same, either the medial perforator, and here is the depiction intraoperatively, or the lateral perforator right here. And then finally, the last option is using the SIEA to this medial one. Now, when you're doing the lateral distal row to the SIEA, you notice that the distance is quite large. So using that distal medial row is actually better because that length is not such a large one to overcome. So sometimes you have to dissect this a little bit longer so you're not worried about your length of the two vessels. Obviously, you want a tensionless repair. So how do we combine this with lymph node transfers? These patients, again, traditionally come in with more advanced breast cancer. They traditionally have an axillary lymph node dissection. As previously mentioned, up to 30% have significant lymphedema. And so as you're doing this reconstruction, it's not only important to reconstruct the skin, but also offer them lymphatic outflow. And here is the dissection of just a very simple, superficial, vascularized lymph node. Kerwin Becker is here, who I was privileged to operate with as I was learning this technique a few years ago. So this is a very nice way to add lymphatic outflow with your flap. And traditionally, there's an anastomosis in the axilla where you're having to work in this radiated lateral axilla to connect the vessels, but this is difficult. And so you're usually having your ipsilateral flap having urine flow from the internal mammary vessels and the contralateral flap from the axilla. And that, again, can be sometimes difficult. So the nice way to do this is actually rely on your intraflap anastomosis to perfuse your entire contralateral side and the lymph node. So you're really relying just on the one anastomosis that's perfusing your entire flap, including the lymph node. And so this is an intraoperative perfusion, just to show you that it does indeed work, that this is allowing the perfusion of the entire flap without any issue. This is again an intraoperative video. You can see the SPY lymphozurin is lighting up. Everything is nicely perfused, again, through that one anastomosis to the IMA and then an intraflap anastomosis perfusing the lymph node. So here are some photos of some results. This is again a sensate conjoined deep flap. I do believe in making these flaps sensate. This is a large amount of skin island. You really do need to add sensation. This is a patient who had a lumpectomy, had multiple problems with infections. She wanted to have a completion mastectomy, and here is her result. Another patient, similar issue, she actually had to have radiation, so here is her interim result with a tissue expander. Through her radiation process, here are her markings and the perforator markings that were marked preoperatively. And here is her postoperative result. And then this last patient is very challenging. As you can see, she is very thin. Her mandate to me that she did not want to touch the other breast. She wanted me to make a breast exactly like her natural right one, which, she didn't have a lot of autologous options. You can see she has a small abdomen. Again, perfect candidate for a stacked or a conjoined flap. And here we have her fat grafting process. She had a few fat grafting procedures, and she was able to get the volume required, with the flap itself almost being like a matrix for fat grafting to get the volume that she desired. So I jokingly tell my patients when I do this surgery that they have the Ferrari flap, because I think this is the most luxurious flap you can do. It's sensate, it maximizes all of the available abdominal tissue, eliminating any fat necrosis, a single IMA anastomosis with a rib-sparing approach, and then, of course, a vascularized lymph node transfer. Of course, being in Italy, I thought this would be very nice. And this flap really checks off all the boxes. So I hope that you consider it as a part of your armamentarium for breast reconstruction. Thanks so much.
Thank you so much, Dr. Spiegel. Do we have any questions? Yes.
All of you. Do you hear me? Yes. I have some little tricks. For the axillary dissection, you really need to open everything in the axillary region before to put the flap. It's very important, otherwise it will not work. So the fibrosis, so you have an extra surgery to do before to put the flap. The second thing, I do more often a second anastomosis. Mostly even if you feel that the flap is well perfused, because I have postoperative better result in regarding the lymphedema if you do an extra anastomosis. The third thing, I have only one patient. She had a very, very large breast, and she had no very good result on the arm. So I went back, and I saw the flap was completely retracted with the weight of the flap and was just going again in the breast, and there was nothing left in the axillary region. So for very, very heavy breast, I suggest to do 2 flaps, to cut completely, because with the weight, when she's not in the bed, but when she will live again, you will see after 3 months, the results are less good. So I think we should consider this point.
Any thoughts on that?
Yes, I think that from the results that I've had with these patients, I have 35 patients so far. I didn't have a chance to add my results. All of them had some decrease in lymphedema. It's variable. About 40% of the patients stopped wearing their sleeve post-operatively, and all of them had the perception of a less sort of swollen arm. They were able to wear jewelry and so forth. So this is a paper that we'll be writing just to show this as an option as well.
Thank you so much, Dr. Spiegel. In the interest of time,
5 seconds only. Thank you very much for your presentation. I enjoyed very much. Since I have quite a serious problem of spine, and when I go to surgery, I need to be as quick as possible. My question is, how long it takes to do the stack flap for you? How it lengthened the procedure?
It actually is pretty fast. I would say I'm a single surgeon. I don't have another team, and most of the time it's about 5.5 hours for the dual pedicle flap.
Thank you very much. After 4.5 hours, I need cortisone.
Next,
yes,
we'll be continuing on with 3D technology supporting autologous breast reconstruction.
First of all, thank you very much for the invitation, Fabio and Mark. It's a great pleasure to be here. I'm Uroš Šahčan from University Medical Center Ljubljana, and I will talk about 3D technology that's supporting autologous breast reconstruction. So I have no conflict of interest. So we all know that breast cancer affects over 500,000 women every year in Europe, and that the loss of breasts have a profound impact on women's quality of life. So the most important question is how to restore body and life and transform a desperate woman to a happy mother and wife. So we have plenty of reconstructive options: oncoplastic surgery, autologous reconstruction, implants-based or combination. We can do it immediate or delayed. And DIEP flap is still a working horse in autologous breast reconstruction because we replace like with like, and microsurgery became a routine standard procedure with almost 100 successful rate in Ljubljana, 99.6. And with two-team approach, we can shorten the surgery time below 4 hours in average. So in immediate breast reconstruction, breast surgeon performed skin-sparing mastectomy, lymph node surgery, and leave the skin envelope and important landmarks intact. So in the meantime, we raise the flap and just use the well-vascularized adipose tissue as an outer prosthesis. So the same amount, 550 grams as the breast, and we use 550 grams of the DIEP flap for reconstruction. And we just then shape the flap to an autologous implant of the similar size and shape and restore the appropriate shape and size of the breast, volume. You can see the projection is quite similar to the opposite side, and the inframammary fold as well is very important. So some of our cases before and after, we can reconstruct with immediate DIEP reconstruction and get a final result in different patients. Also with small breast or big breast or ptotic breast. And we also know that patients have a high degree of expectation nowadays, so we performed usually also simultaneous contralateral breast adjustment, as you can see here, bilateral breast cancer, and we performed DIEP flap on the left side and just mastopexy on the right side to get a good result at the end. And now the most important question of this talk is how to optimize the breast reconstruction in patient desiring delayed breast reconstruction. I entirely agree with statement of Blondel that recreating an aesthetically pleasing breast is a combination of good measurements, artistic insights and the experience of the surgeon that are very abstract and ill-defined elements, and questions still remain how to restore breast volume and shape and how to achieve maximum symmetry when we have plenty of question mark about weight, volume, contour, projection, inframammary fold position, and location of upper and lateral breast pole. How to avoid additional procedure on the learning curve. So in order to achieve better breast symmetry in secondary breast reconstruction, where the footprint, conus, and skin envelope have been damaged dramatically, 3D technology is used. We use nowadays Artect 3D EVA, and 3D image of the remaining breast is taken with 3D scanner to design the replica of the contralateral breast, and then we print a 3D print of healthy breast replica, and then the mold is then used for markings and tissue shaping during surgery. So, as I mentioned, plastic mold is first placed before the surgery on the patient in the upright position, and the key suture points are marked on both the plastic mold and chest wall for positioning of the flap during the surgery. Then we just raise the DIEP flap and put it into the mold, which is sterilized. In the meantime, the second team closes the abdominal wall and shortens the operation time. So we put flap in such a way that all the perforators are centrally located and exposed all the time during shaping. We just mark the excessive tissue of the new breast according to the mold and remove all the excessive tissue, and here you can see the final breast into the mold, which is just a replica of contralateral healthy breast. Then we transfer the flap in the mold to the thoracic wall, perform the microsurgical procedure to internal mammary artery and vein. It takes us about 17 minutes. And then the most important part, the breast positioning is just done according to the key suture points. And then we just staple it and suture and check finally, and this is final result in about 3 hours surgery, and this is after 24 hours. Now we can see the video of this technique. So two-team approach shortens the operating time. We find the perforators. In delayed reconstruction, I'll always take more than one single perforator. Then we put to the mold, which is sterilized, as I mentioned. Mark the excessive tissue. It's fast and easy, and you can see the perforators all the time. Then holding suture are used to preserve the shape. Then we mark key suture points to the flap, central position of the final shape of the new breast. You can see it's quite a replica of the contralateral side, microsurgery. Positioning of the new breast according to the key suture points, intradermal suture, and this is final check, as you can see here. Bello. One day after, and when we assess the breast parameters with Victra 3D imaging system, you can see a quite similar lines, and the volume, the difference in volume is 28 cc. So again, this is 10 days after surgery. You can see the result. And the aesthetic outcomes of autologous breast reconstruction with 3D technology remain stable over time. And now, the last 2 minutes, I would like to show my modern approach in delayed breast reconstruction. The main goal is not the best breast symmetry, but the best result. So this is a questionable result nowadays for me. And if healthy breast is nice shape and volume, and patient desire just one single surgery, as case here, I perform a 3D scan, and then we produce a mold and perform reconstruction. And this is the final results of some of the patients. In the case of health, if healthy breast is small, and empty, let's say, then we can suggest to our patient first breast augmentation, then 3D scan, production of mold, and finally reconstruction, and this is the case. Or if healthy breast is too big or ptotic, then we can suggest breast lift or breast reduction, then 3D scan, mold production, and reconstruction, and this is the final result. And even if there's no opposite breast, we can use the mold from our base or patient, and this is the final result. So in conclusion, advantages of 3D technology: objectively determining breast volume, shape, and contour. We can predict key breast landmarks with the help of contralateral breast. It's easier, faster, and safer shaping of the flap with direct visualization of perforators. There's decreased the need for secondary procedure, and method is extremely helpful for a young, less experienced surgeon. So every woman deserves the right to choose the reconstruction options, to regain her natural breast shape and fullness, and to restore life. And it's our duty to bring back the smile on the faces of our patient, and we know that smile is the best fashion accessory. Thank you very much.
Thank you, Dr. Artson. Question from the audience?
Yes. Congratulations it's not for less experienced surgeon, it will be useful for everyone. How long does it take to make the mold?
It takes about 12 hours.
Oh,
we product by ourselves in the hospital before we have a cooperation with Faculty of Mechanical Engineering, and it's quite expensive and takes us a days. Now the price is €4 and it's 12 hours production time.
Okay. Did you say 4?
Pardon? €4.
That's
it's a material.
Yeah.
I have a video. If you want, I can show you also how our nurse make this. Can you put back the presentation, please? It's just 1 minute video. Just to the final slide. Okay, back this one. Sorry. No. So it's done by the nurse with special education, Artekiva. This is how it works, the software. So this is now the copy of the contralateral breast. Put on the chest wall, then define the key suture points. We check everything. And this is now printing with Ultimaker, 12 to 14 hours. It depends how big is the breast, and the cost, as I mentioned, €4.
What kind of material?
It's a plastic material, I don't know really, but it can be sterilized. This is then the final, and then we just put it and for the markings and all the rest, as I mentioned before in my presentation. It's quite fast, easy.
Thank you so much. Really wonderful results. Why don't we go ahead? So next we'll be doing SIEA versus deep flap when one is indicated among the other.
Good morning. Thank you for the invitation. It's a real honor to be here.
Can we have, perfect.
Okay, thank you. So when it comes to free flap breast reconstruction, we know we have many options available. And with this presentation, I would like to focus on the SIA flaps, which was firstly described for the head and neck reconstruction, and later on for the breast reconstruction. The first case was described by Grafting in 1991. But before that, we have a really nice and harmful study, which was performed by Taylor and Daniel on a cadaveric dissection on 100 specimen that showed that beside the anatomical variation, the artery was absent in up to 35% of the specimens. So just having a look at the anatomy, we all know about the CF vein, which is always preserved and used almost always in the DIEP flap. And the artery is based on a superficial system, and it goes straight to the femoral artery, and the pedicle could be quite long, but not long as for the DIEP flap. And regarding the angiosomes, there are a few very nice studies that study the lateral and medial row perforated of the DIEP flap. And when it comes to the CIA flap, it is comparable to the lateral-based perforator in the DIEP flap. So only half of the abdomen is harvestable, and so just the ipsilateral side. So it's not. It is really not wise to harvest more than a half of the abdomen. So is it really something that we decide intraoperatively? Is it something that it's just at the moment of the surgery? Well, I think that it was this kind of decision maybe in the past, where the tools available were not that much as we have today. So during the DIEP flap lower abdominal incision, we just look for the CIA artery. If it was present and it was bigger than 1.5 millimeter, it was a choice that could be taken into consideration if the breast to be reconstructed was medium size. But nowadays, we do have the CT angio, and I know that Professor Santanelli is not really a fan and is not really using it, but I'm way less experienced than he is, and I need to do that to sleep at night before the surgery. I need to have the plan in my mind so I can go. And this study, there are many studies available, but this one I found it very useful because they have all the settings that you can hand it to your radiologist to have really a perfect made CT angio, and you're really able to see all the perforators and the CIA artery, which is sometimes quite questionable. And there's this very helpful algorithm described by Dr. Spiegel. Thank you very much, because this is something that helped me through the decision-making process, because this algorithm is not only focusing on the diameter of the artery, which is the set point is 1.5 millimeter, but also to have a look if a direct pulsation is present, because if the artery is there but it's not really pulsating in a sufficient manner, it is advisable not to go for it. And also in 2008, the year later, Charlotte Holm described almost a similar algorithm. And even you might think that this could be time-saving, it is really not, because after dissecting the superficial system, you just not raise the flap as an abdominoplastic. You need to preserve the perforators as per a DIEP flap. Then you need to clamp them with vascular clamps and let them drink for at least 15 minutes. And after that, you need to have a look at the clinical, and if you have the indocyanine green available, you use it. And this is what happens. So you just basically look how the flap is. If it's well vascularized on the CIA flap, you can go for it. Otherwise, it is advisable to go for a DIEP flap. So we all know the advantages of the DIEP flap, so I don't want to go through this, but the main difference is on the donor side, because the CIA flap do not have any incision of the rectus sheath, no hernia, no abdominal bulge, and also the wall of the abdomen is not weakened by damaging motor nerves as it can happen with a DIEP flap. And the BMI is not really related to complication on the flap. On the donor side, it is, of course, because we know that fat patients are not the best patient for us as for seroma and complication on the donor side. But when it comes to the superficial system, these patients have a really bigger vessels compared to the deep ones. On the other hand, the anatomy is really inconsistent because this artery is not always there. The caliber of the vessel is not reliable. The vascular pedicle is at the periphery of the nerve, and as Professor Santanelli was said before, it comes just in a straight way, so it's easy to be kinked. And it is not suitable when a previous C-section or abdominal surgery was performed, and it is burdened by a really high incidence of arterial thrombosis. This is just a standard CF flap, which the artery is located more laterally than the vein, among 5 to 7 centimeters from the midline, and obviously the recovery is less painful, and the patient is able to go back to work and everyday activities quicker than with a DIEP flap. And of course, we do not have any robotic assistance because we are poor. And so we just perform the standard incision of the rectus sheath, so which is up to 8 to 10 centimeters. So it is still there for us. And this is a case when a patient had to undergo bilateral breast mastectomy, and abdominal-based bilateral breast reconstruction was planned. And in this case, since a bilateral reconstruction was planned and a CIA artery was really present and nice on the right-hand side of the patient, we perform a one-side DIEP flap reconstruction and a CIA flap reconstruction on the other side, and this is the results. And then I was thrilled about this nice and almost easier flap to be done. And this is one of my first cases as a junior consultant. I did it 2.5 years ago. So I chose the patient. She was fat enough. I was happy to do that to her. And she needed to go back to work soon. So I decided to go for a CF flap. And so far, so good. I mean, during the surgery, everything was fine. But afterwards, I found that partial necrosis occurs, and I did not actually know what went wrong, but the thing is that on the bench, when I raised the flap, and after letting the flap drinks, the clinic signs was not that brilliant, and the Indocyanine green was fine, but not that fine. And I was like, I went for this flap, and I regret it because in that case, it's better to be sure, 100% sure. So if the flap is not drinking properly, it's better to go for a DIEP flap. And then this is the result, which is not the finest, but still, and the patient will go for the other contralateral breast reduction. And I was not happy with that. So is it really something that is related to the learning curve? Is it something that is intraoperative decision making? What was wrong? So I found this really nice study that compares the experience of this group of surgeons from Philadelphia, their experience on a case series performed 20 years ago and nowadays. And the surgeon is the same surgeon, so he compared his complication rate. And even these complications were different with other flaps. When it came to the CIA flap, it was just the same. And 1 out of 6 patients, which is a lot, can experience this type of partial necrosis and intraoperative ischemia related to vasospasm and the characteristics of the flap itself. So in conclusion, the lesson I've learned and what I can tell about my experience is that I think it could be suitable when bilateral reconstruction can be planned and performed, and when the CIA flap is a good caliber, is pulsating, and it's present on the CT angio. With patient with elevated BMI, but you need to really proper select the patient and perform an intraoperative careful check just to be sure that everything could go well. Thank you.
Thank you so much. Do we have any questions from the group? Dr. Spiegel.
congratulate you on attempting this flap. I was enamored with the SIA flap myself, as you saw that article. And the things that I learned very much agree with Fabio about the plane of the superficial vessels, that you have to have a plane change. They're not in the same plane as the internal mammary vessels. So there's always that issue with a kink. So that's number one. Number two, there's a lot of variability about perfusion across the midline. And if you look at patient to patient, I think that's why you may have observed this, is that you may have a successful anastomosis, but it just doesn't go as much as you want onto the contralateral side. So I agree with really minimizing the amount of tissue you're trying to preserve and perfuse with the superficial flap. And then just finally, the way that you do the vein, there's actually two options. You can use the superficial large vein, but sometimes that causes a problem because the artery is a little bit away from the vein, and when those two venae comitantes are not used, they can sometimes enlarge and actually cause sandwiching and compression of the artery. So with a superficial, I actually try to use the venae comitants as they come together for my venous outflow. So those are just my remarks on that. Thank you, very nice presentation.
Thank you very much.
Any further questions? I do have to reiterate, congratulations on doing this flap. It still gives me heartburn every time I do one, so I really appreciate making it safer for all of us.
Thank you.
All right, why don't we go ahead and continue to the next presentation.
Guido Paolini will speak about long-term experience with 130 flap breast reconstruction.
I wish to thank Professor Santanelli di Pompeo and Dr. Clemens for the invitation. I report our experience with the FALD flap. Autologous flap is surely today the gold standard for breast reconstruction. Nevertheless, it's a demanding technique, needs microsurgical expertise or multiple stages. Latissimus dorsi is an old option but has gained renewed interest recently. In our armamentarium is indicated in bilateral cases in patients with no abdominal donor area, in aged patients with high ASA index. Small breasts can be reconstructed with autologous tissue only, while large flaps with latissimus dorsi and implant. The advantages of extended flap is that it is one-stage autologous reconstruction, but it has several drawbacks, especially high complication rate and poor aesthetic outcome of the donor area with high incidence of seroma and dorsal skin breakdown and asymmetry. Therefore, our aim was to develop a technique that was totally autologous, one stage, either immediate or delayed, that wouldn't need microsurgery or an implant that could allow a good result with a low morbidity. So we studied the matter, published a few papers on latissimus dorsi, and finally in 2014, Professor Santanelli came out with the fat augmented latissimus dorsi flap, the FALD flap. It's mainly indicated in patients with small breasts, small to medium, in patients that do not hold the abdominal donor area or unsuitable donor area or a poor candidate for free tissue transfer. Mainly in patients that hold abundant dorsal skin laxity or fat deposits, and patients that refuse implant reconstruction. The contraindications are mainly due to professional athletes, paraplegic women, and patients with thoracotomies. Two-stage FALD flap is useful in patients with higher BMI that need further lipofilling stage. In the last 15 years, we have performed almost 2,000 breast reconstruction, among which about 600 latissimo dorsi flap, and among these, now we are at like 150 FALD flap. We here present our experience on these patients, where 100 patients, mainly unilateral, but a high number of bilateral cases, mainly immediate. Mean age was 15 years. BMI was low, was 24, and there was an equal incidence of radical mastectomy, skin sparing, and nipple sparing mastectomy. Mean harvest time was almost 3 hours in unilateral cases and 5 hours in bilateral. Mean injected fat volume was among 100 milliliters per patient, and the skin paddle usually measured 19 per 11 centimeters. Average mastectomy weight was 400. Mean hospitalization 2.34 days in unilateral, 3.31 in bilateral, and more than 50% of the patient received only intraoperative fat grafting. Mean follow-up was 60 months. So we didn't experience any major complication like total or partial latissimus dorsi flap necrosis. We experienced 7.65% of minor complication, among which 2 skin island partial flap necrosis, 1 fat necrosis, 1 donor site seroma, 1 wound dehiscence, 2 patients complained about chronic pain, probably due to mastectomy, we hope, and no functional limitation of the shoulder. No local recurrence or distant metastases were experienced. So our results were satisfactory, especially for the nipple sparing and skin sparing mastectomy, regarding to skin texture, scar location, and total score. So here we present our way of doing it, our tips and tricks. In unilateral cases, we do adopt a lateral decubitus of the patient. We perform simultaneous ablation and reconstruction, and no decubitus change till the end of the operation. We harvest a wide island, skin island, at least 11, if we can, also 12 centimeters skin island. The orientation of the skin island is horizontal or slightly oblique, because the totally oblique harvest has a higher donor side morbidity, is more difficult to be concealed under the bra, while an horizontal or slightly oblique is much better. We perform a total muscle harvest. We do perform immediate fat grafting, about 80 to 100 cc of fat. We use Clemens technique. Sorry, can you put the video on, please? And we perform fat grafting to the skin island, both into above and below fascias, Scarpa's fascia. We try to perform an anatomical fat filling, so to fill the lower pole at the most, like mimicking an anatomical implant. This outcome is furthermore increased by a lower muscle folding in the lower pole. We preserve the tendinous insertion of the muscle. We preserve thoracodorsal nerve to retain as much as thickness of the flap in the long term. We spare the pectoralis major, and we try to reduce donor side morbidity by using Colorado tip dissection, sparing of the thoracolumbar fascia, and tight fascial closure. In bilateral, we do perform simultaneous bilateral prone harvest and one only decubitus change. We present a few cases. This was our first case, a patient that had an outcome of radical mastectomy with bad skin in the abdominal area, with multiple comorbidity, nephrectomy. So we choose to perform a FALD flap. She underwent immediate reconstruction with fat grafting of 130 ml. These are our first case of immediate reconstruction. The patient had to undergo a right skin-sparing mastectomy type 1, so we perform an immediate reconstruction with the valve flap with 63 ml of fat. This patient has a moderate-sized breast with initial ptosis. She needed to underwent a nipple-sparing left mastectomy. We performed the valve flap with 130 ml of fat. Another patient with moderate breast, no ptosis. She needed to undergo a bilateral nipple-sparing mastectomy. So we performed a bilateral valve flap with 85 ml of fat. More difficult case, a patient with pendulous breast, large pigmented areola. She needed to undergo skin-reducing mastectomy type 4, and we performed a bilateral valve flap with 90 ml of fat. Last patient, a patient with breast asymmetry, with scar in the abdominal area, left large breast. So we performed left valve flap with 210 ml of fat and contralateral immediate fat grafting for symmetrization. So valve flap has several advantages. It's one-stage autologous reconstruction, doesn't need an implant, has a low complication rate in our hands, and allows an improvement of the donor area. So the take-home message that this solution may expand indication for autologous reconstruction for those patients that do not hold abdominal area or slim patient not candidate to free tissue transfer, and that easily enhance the final volume and allows also an improvement of the fat donor areas. Thank you.
Thank you so much. What I'm struck by is how much more natural it looks than a latissimus with an implant. It's great to see those results.
Thank you.
Is there any questions from the audience? Yes. Can we have the microphone on, please?
Yes.
Bülent Saçak from Turkey. Congratulations. I would like to ask, in the setting of PMRT, do you perform these procedures? Because my concern is about fat necrosis and oil cysts. Thank you.
In our experience, we usually like to defer reconstruction when we have a high chance of postoperative radiotherapy. So when you see the patient with this enologist, that's one of the first questions we ask him, and not only for valve flap, but also for DIEP flap. Then it may happen in our series of patients. We had 30 patients that had radiotherapy, and they surely have a higher incidence of problems. Mainly they have more reabsorption of the fat, that's for sure. Regarding oil cysts, I think they're more connected to the technique of fat grafting more than on the radiotherapy.
Okay, I have a question, please. Thank you very much. You know, the flap consists of skin, subcutaneous tissue, fascia, and muscle. So what is your favorite site for the injection of the fat, and how do you avoid injury to the trunk?
Thank you very much for your question. I had another movie, but it was not working, so I had to remove it. We started injecting fat only below fascial scar, but then also above, and now we do also infiltration of fat in between pectoralis muscles and into the fascia of serratus. But on the other hand, we don't like to inject fat directly into the muscle.
Thank you. I congratulate for the wonderful results. I want to ask, in your experience, what's the maximum weight of the breast you managed to reconstruct with the autologous latissimus tarsi?
one of the largest breasts was the last patient that I showed was about 600, 700 grams. But in that case, you must put more fat also in the other compartments, in between the pectoralis major and the serratus fascia.
Can I just unpack a comment that you just said, where you said you tried to avoid injection into the muscle? We see a lot of manuscripts coming out in the journal right now saying that into the subcutaneous fat is better. Some people would argue better fat retention into the muscle is better. Why do you avoid the muscle? Is that a worry about fat embolism, or you don't think it takes? Why do you?
Thank you for the questions. No, we try to be safe. We are afraid of fat embolism, so we don't like to inject into the muscle. We believe that it takes, but we don't like that. Furthermore, we are afraid of a possible fat differentiation into osteoclasts. That's why.
And I find that if I don't do that, then I have animation of the muscle. So I usually always cut it. And I think that I get a better position of the latissimus in the breast, and I can have I have less animation and no problems with it.
Thank you for your question. This is a debated question that we recently talked also with Stefania Tenna. And we have experienced animation with latissimus dorsi with implant, especially if the implant is large, then the muscle has tension on the muscle, so it's easier that the patient would complain for animation. And that's why in our series of latissimus with implant, we would cut the nerve, so to reduce the animation. We find that when you do the valve flap, you don't have an implant, so there is much less tension. We can reach easily the deposition, also the medial area of the breast without problem. Maybe we have accomplished it over time. And the patient do not complain about animation. So we don't need to transfer the tendon. Would be a further step that in few cases, if you are not very keen on it, it may lead also to strangling of the vein if you are not experienced surgeon, and then you may transfer tension to the vein while keeping the thoracodorsal nerve intact. It may happen.
Thank you very much. I think we'll never have consensus on whether to cut the muscle or not. But why don't we continue on to Dr. Michele Sorotos, who will be talking about autologous fat transfer for total reconstruction after nipple-sparing mastectomy, 117 patient follow-up.
Okay, hello, good morning, everybody. My presentation is here. I would like to say I feel really honored to be a part of this extraordinary faculty, and also I would like to thank Professor Santanelli and Professor Clemens for following this paradigm shift and offering this high-level conference free online. We have more than 700 people that have been following since this morning, which is great. So I would like to invite you to the next year's conference, 8th International Breast Surgery Workshop and the 4th World Consensus Conference on BIA-ALCL in Houston. I'm going to speak today about autologous fat transfer for total reconstruction after nipple-sparing mastectomy. So forget about flaps. We're going to speak about fat grafting and how we can reconstruct some of our patients. So these are my disclosures. So we published in 2014 our preliminary experience with total breast reconstruction with autologous fat transfer in nipple-sparing mastectomy patients in both irradiated and non-irradiated patients. We had few patients at the moment, 21 patients, 34 breasts, 10 radiotherapy patients, and 11 controls. We concluded at the time that it is a reproducible technique with good aesthetic results, effective in both irradiated and controlled patients. It can offer total autologous breast reconstruction, aesthetic improvement on the donor areas, and breast tissue quality improvement, especially in radiotherapy patients. The limitations, of course, were a small population, an inadequate donor site volume for some of these patients, so you can't offer them the technique, and you can only reconstruct small to medium-sized breasts. And of course, you have to do more than one surgery. So the aim of our current study was to define a systematic approach for total breast reconstruction using the same technique, autologous fat transfer after nipple-sparing mastectomy, validate our protocol in irradiated patients, and extend it to smokers. So we collected data from our database, and the inclusion criteria were indication to nipple-sparing mastectomies and small to medium-sized breasts. Excluded were patients with comorbidities, local or distant metastasis at the time of surgery, or ischemic complications of the mastectomy flaps. The data collected were age, BMI, weight of mastectomy, number of sessions after AFT volume in each session, and total AFT volume and complications. So in total, we had 79 patients, 117 breasts, 41 were unilateral and 38 were bilateral. Group A were 25 breasts with radiotherapy, Group B, 21 patients were smokers, and Group C, 71 control patients. Our breast surgeons use always the same incision, inframammary fold incision from 3 to 6 o'clock. This is our autologous fat transfer protocol, nothing special. We usually do the surgery under local anesthesia and sedation. We do liposuction with 10 cc lower lock syringes and 2.3 millimeter cannulas. We centrifuge at 3000 RPM for 3 minutes, like Coleman standard technique, and we use to do the fat transferring with 1 cc lower lock syringes and 1.2 mm cannulas. We published this simplified lipostructure technique, which makes things easier and faster to do. So our autologous fat transfer protocol has some principles regarding volume and timing. So volume, in the first session of autologous fat transfer, we transfer 1/3 of the mastectomy volume. And then from the second session and on, we transfer 30% more compared to the previous session. Regarding timing, we usually start transferring 6 months after surgery. So the patients do nipple-sparing mastectomy, and then we transfer 6 months afterwards. And in patients with radiotherapy, we wait 6 months after the end of radiotherapy. This is to give some time to the skin. We did a aesthetic analysis with a global aesthetic score and a subscale analysis. And these are our results. So in all groups, patients were homogeneous regarding age, BMI, and mastectomy weight. We didn't see any differences there. And regarding the number of sessions, okay, I'm back here. So number of sessions, what we can see is that there is a statistically significant difference, and this is between the radiotherapy group and the other two groups. And we confirmed that with pairwise analysis. This is because radiotherapy patients demand more sessions, okay? So that was something we observed. And of course, more sessions mean more volume in order to reconstruct them, and more volume and less volume in the first 2 sessions. So it's the opposite. You need more total volume, but in the first 2 sessions, in order to expand the skin after radiotherapy, you need to give a less volume. Our follow-up was not statistically significant. Regarding aesthetic results, we see that most patients were happy. We were happy with most of the aesthetic results, but what we saw as a difference is the skin texture. Of course, radiotherapy changes the quality of the skin, and this is why those patients scored poorly regarding this category. And the same, of course, the impact of the skin texture was also seen on the total score. I'm going to show you briefly some results of some of our patients. This is our patients with radiotherapy. We can see the way her breast came back to her preoperative status slowly after the sessions of fat grafting. We can get good results, and our patients are happy because they don't have to have extensive surgery. They usually stay at the hospital for a day. And this is the same patient. This is a more difficult patient with a thinner patient, so it's not easy to reconstruct those patients with fat transfer, but you need patience, and you can get good results also with these patients. This is a patient that wasn't part of this cohort, but I'm going to show it to you only to see that you can combine that with rigotomies in patients that have scars on the superior external quadrant, and how you can move. You can see the nipple, how it's retracted. You can move the nipple to a more natural place by doing that. This is another patient with a smoker patient. We actually consider those patients now like healthy patients because we saw that there is no difference in the volume we injected and the number of sessions. And we can also get excellent results with these patients. And some control patients, as we like to call them, and no smoking, no radiotherapy. You can see how we can get a good volume. Sometimes the patients ask for more fat in order to get a bigger breast compared to the preoperative volume. Another control patient. We see how also the scar modifies during the follow-up, and it gets better with time. Another control patient. So as a conclusion, we can say that this is an effective, reliable, and reproducible technique. It's easy to perform. It can offer total breast autologous reconstruction in those kind of patients. We can confirm that our indication in irradiated breast and also extended the indication for smokers. We can offer aesthetic improvement on the donor areas and breast tissue quality improvements. We recently published this work on PRS, so you can read it in the following months. Thank you very much for your attention.
Thank you so much. Really amazing results. Are there any questions from the audience?
Everybody's hungry.
No. But it's quite evident that the beneficial of fat grafting we knows very well.
Thank you.
Yeah.
Thank you very much.
I have a safety communication. There is a... Oh, good. May I?
Hello.
Congratulations, Dr. Serratos. Very nice presentation. How many months do you wait between one session and another?
3 months. We wait at least 3 months, and usually we have to fight with the direction of the hospital in order to have spaces to schedule patients. We usually schedule patients for the next fat transfer after they are discharged, the same day, so we have the time to prepare them and do the surgery.
C'è un conflitto di interesse. Il marito.
Alessio Gaggiati from Rome. You told us that you start fat grafting 6 months after radiotherapy.
Yes.
There is indication from oncologists or your preference? There is no need to wait from, in my opinion.
So this is an excellent question. We have seen other works, and people say that you should start earlier in order to help also the skin to heal better after radiotherapy. For this cohort of patients, and in order to be standardized with our protocol, we waited for 6 months. But it's something that we consider to start even earlier. It's not an oncological concern.
As an oncology concern, do you find that these patients end up getting more biopsies for suspicious calcifications, or is that a concern?
No, and actually we published also this month our personal experience with 1,000 breasts, where we did case matching regarding oncological safety and fat transfer, and we saw that there is no difference. So we are safe with that.
Wonderful. Any last questions? All right, that will end our morning session.
I have an information that I'd like to give you. During lunchtime, there will be a symposium. So if you can either stay inside or probably you prefer to eat outside and immediately get back here to the room. Fortunately, I couldn't control the wind. It's quite windy in the buffet. God allowed me for raining, but not for wind. And if you can leave your bag under, because we need to sanitize the tables. So you leave your bag under the table, there is some room to put it, they can sanitize, and you can come back as soon as you like. Thank you very much.
Yeah, just as a reminder, we will be back in about 5 minutes. That will be the Women's Health Industry Symposium by Establishment Labs. Thank you very much.
Thank you. Grazie.
Di aprire anche l'altra porta.
Ah, pure di questa? Ah, ok. Ah, perfetto.
Grazie, gentilissimo.
Not necessarily for them, yeah, please. No, yeah, but... And Paolo should push the Italians as well. Yeah. Are we putting up, you know, we're putting up our this? I don't know if they have it. No.
How long do they have for lunch?
1 hour.
1 hour. So can you help us and bring them here?
Okay, are you starting now or?
5 minutes. Give them 5 minutes. Yeah. Because Ross does the intro, and then I do my intro, and then we can do the lectures or the.
Yeah, maybe something in 10 minutes and then.
Yes.
You give me the bell. we go outside with the bell.
Okay. I will.
Thank you.
No, actually, I'm looking for an open seat.
Can steal.
There, I had to lower it a bit. I'm one of those short.
Safety first.
Short people. Short people problems.
One is there. The one who needs to do the online presentation.
She's here.
So I can tell her to. What is she doing?
Who?
You didn't make a picture like me sitting like this. Let's do it this way.
You can't do your mask. Mask. Unmask.
Yeah, unmask player.
Oh, do we want, is that in the background? Yeah. Insta. Please move to the front. Oh, in front of that one? Okay.
Munhoz is online now. Yes. Okay. That's what I'm going to say.
It's just comical.
There's a lot of women's health organizations online. I mean, who checks? Oh, sorry.
I think it's not on.
Well, we have Eric Swanson in the room, so who else do
Thanks, Eric. Thanks for being here.
who else do we need?
That's great. We said we'd give people 2 more minutes. Eric, you must have been first in line for the food.
I was watching people's manual dexterity with the salad, you know. The lasagna's good.
You can sit here, and I'll go behind your back, and then sitting again.
Yep.
And then we watch what's happening.
Okay. Thank you. Water, please.
Eric, we can start.
Good, thank you.
You have a microphone there in front of you.
Yes. Ross starts.
We had a couple of our colleagues that are coming back in like 1 minute. Can we wait?
We can't wait for them because then we will lose
Time.
They're beat for us. You start, please.
Nobody can say anything against Giannis, but then.
I'll go and get them.
Okay.
Okay, start.
Good afternoon, everyone. I am Rosalind Incelli, the Global Head of Clinical and Medical Affairs at Establishment Labs. We are honored to support this important educational congress. Establishment Labs is a women's health company in breast aesthetics and reconstruction. So what that means for us is that we will be here to support women on their journey from beginning to end. And it means we have an important responsibility to produce products that are the most safe and effective to support that journey. To that end, we are proud to launch 2 new exciting technologies this year. One is our Flora tissue expander with an advanced smooth silk surface, and it allows for a more comfortable expansion, is MR conditional, and has the potential to facilitate improved radiation treatment as there is no metal or magnet at all in the product or port. Second is our Ergonomics 2 breast implant. This is an advancement of the ergonomy concept for aesthetic and reconstruction outcomes and allows for easier insertion. We continue to prioritize our commitment to research, development, and innovation, with several clinical trials ongoing globally. Our US IDE study of which Dr. Clemens is an investigator, is progressing very well with all augmentation patients past the 2-year time point. We are proud to support many academic institutions in research with a focus on innovation and education in women's health. And this Congress and the panel today is one of those important topics that Eric will introduce. Eric.
Thanks, Ross, and good afternoon. October is Breast Cancer Awareness Month, and breast cancer prevention during COVID has been very challenging. Screening and early detection programs have been set back, and the US CDC, the Center of Diseases and Controls, reports a decline of more than 80% of women for specific breast cancer screenings. That, of course, is a setback. That is not supporting women's health. Of course, we support the Breast Cancer Awareness Month, which we started exactly a week ago on October 1st with a Breast Health Day, with a women's platform in Barcelona. And we had a women's panel of breast cancer survivors. So that's the leadership we as Establishment Labs are currently performing. Breast implant patient advocacy is, however, not a monthly initiative. It's a 12-month a year, 365 days involvement in creating awareness for and around breast health. The purpose of our journey and our commitment is women's health. So today I'm very proud that we have 3 remarkable women on the topic, discussing the topic of women's health. And I thank the organization for giving us the platform to discuss. We currently have about 500 people online. The presentations of these 3 women are unrestricted. That means we haven't asked them, we haven't consulted them on the content of the text or added what we have seen, what they have delivered. So I'm very happy to introduce the first woman who is going to talk. It's Georgia Jones. She's a professor in health psychology at the University of Leeds in the UK. But she's also a chief editor of the QNL session, the Quality of Life session of Frontiers in Global Women's Health. So I hope we can have Georgina's presentation online. Thank you.
Hi everyone. My name's Georgina Jones and I'm a Professor of Health Psychology and Director of the Interdisciplinary Centre for Implant-Based Research at Leeds Beckett University in the UK. Thank you for inviting me to come and talk and be part of your Women's Health Lunch session today. I'm sorry I can't be there in person, but I'm hoping to be able to join you live for some questions after you've heard this talk. So today I'm going to share with you some research that I've been involved in for a number of years on a project called Cancer, Fertility and Me. And the focus of the work has been to look at the impact of cancer treatment on fertility for women diagnosed with cancer, particularly from a psychological perspective. And today I'm going to talk about the relevance of this in the context of women diagnosed with BIA-ALCL. So I'm sure you're all aware that cancer treatments such as surgery, chemotherapy, radiotherapy can all affect a woman's fertility. And whilst fertility can resume naturally post-cancer treatment, it can also be permanently lost. And the problem is predicting who and to what extent fertility will be affected is full of uncertainty. It's dependent upon many other factors such as the woman's age, the dose, the nature and the type of treatment she's receiving, and her previous medical history. So this is why it's really important that should a woman want to preserve her fertility, that preservation process happens before she starts on any cancer treatment. So, which women are most at risk of losing their fertility? Well, obviously it's women who are having gonadotoxic treatment such as chemotherapy, radiotherapy, women of reproductive age, but also prepubertal females too. And within the cancer groups, the women of reproductive age who are most likely to be affected are women with a breast cancer diagnosis. And then we found that the second largest group are typically those women with a blood cancer diagnosis, particularly lymphoma and leukemia. So why are the women with BIA-ALCL an important group to consider in terms of potential fertility loss as a result of cancer treatment? Well, many women who have breast implants are doing so for reconstructive purposes as a result of a breast cancer diagnosis themselves. So very early on in the pathway, women with breast cancer should hopefully be having fertility preservation discussions with their oncology care team if they're of reproductive age. For women with breast implants who go on to develop BIA-ALCL, their treatment could impact on their future fertility. I mean, typically treatment for BIA-ALCL is focused on the surgical removal of the implant, but actually for those that are late presenting with symptoms or late being diagnosed, more radical surgery and adjuvant treatment such as the chemotherapies may be needed, and therefore these women may be at risk of losing their fertility. The good news is that for women with a cancer diagnosis who are at risk of losing their fertility as a consequence of cancer treatment, there are fertility preservation options available, and the science has really advanced in recent years. There's freezing, so the woman can freeze their eggs, embryo, ovarian tissue. There's ovarian suppression, and there's also cancer-specific methods, for example, trachelectomies for girls maybe with cervical cancer, ovarian transposition, and also ovarian shielding, presenting a number of options available for these women. But despite the options available, there will be lots of questions that these women face. They may be thinking, well, will I be able to have a baby after cancer treatment? Will my cancer treatment affect my fertility, given that there's a lot of uncertainty around who and the extent to the degree that fertility may be temporary or permanently lost? What are the fertility preservation options, and will they delay the start of my cancer treatment? Are there any side effects of having fertility preservation treatment? And am I eligible for fertility treatment, particularly in terms of maybe costs to support this, these extra procedures? So these pose lots of questions for women at a time that they're dealing with a very stressful cancer diagnosis as well. In the UK and in many other parts of the world, we have clear guidance as part of our NICE clinical guidelines and the Department of Health, and the mantra really is there should be no decision about me without me, embedded through all sort of routine clinical care. It's a real emphasis on shared decision making, where the patients should have be active and have a voice in any decisions made about their care or treatment. And the NICE guideline actually says that at cancer diagnosis, the impact of cancer and its treatment on future fertility should be discussed between the person diagnosed with cancer and their cancer care team. So despite the recommendations that I've previously described, we did a review of the international literature and actually found that the reality for a lot of women can be very different. For example, many women described not being referred to fertility services and not being able to have that fertility preservation discussion or consultation before starting their cancer treatment. Women typically described that their information provision to support them to make fertility decisions was poor. Many women described being fearful as well of the perceived risks of fertility preservation treatment, particularly around whether it might aggravate a hormone-positive cancer, for example, or make them more likely of having a cancer recurrence. They described a dilemma of whether they should prioritise their cancer treatment or it was acceptable and safe to delay slightly to have fertility preservation treatments. There was concerns over their personal situation. For example, you know, how being single or not in a stable relationship might impact upon the options available to them. And also financial worries was also an issue because in some parts of the world there's restrictions on eligibility criteria over who can receive funding for this kind of treatment. So after reviewing this literature, we identified that there was a real clear gap for women in the UK of resources to better support them to make fertility preservation decisions. And so what we felt was an appropriate intervention to create was a patient decision aid. And patient decision aids are a type of, they come from psychology, they're a type of decision support intervention. And just briefly, what they're supposed to do is to present evidence-based information in a neutral way. So they present the risks and the benefits of the treatment and present those in a neutral way. They can be these resources can be in booklet form, web form. They can be given before or during or after a clinical consultation. But what they're supposed to do is to facilitate the patient group to make the right choice for them, treatment choice for them at the right time. So in the UK, we've been undertaking a programme of research called Cancer, Fertility and Me. And the aim of that programme of work has been to develop a number of patient decision aids that can better support women with any cancer diagnosis at risk of losing their fertility as a consequence of their cancer treatment to make fertility preservation treatment decisions. The resource in green is specifically designed for women aged 16 to 45 years old. The resource in the middle is an adapted version that's been developed for teenage girls and young women aged 16 to 25 years old. And they've both been developed in collaboration with the charities Lymphoma Action and Breast Cancer Now in the UK. And they've been endorsed by National Institute for Health and Care Excellence, NICE, and they've also been endorsed by the International Patient Decision Aid Standard Committee as well. We've also developed the tool and adapted it online, and this is just the web link to the online resource, and you can download a PDF version of the booklet from the website, and we can also send complete booklets out completely free of charge to anybody that is interested in looking or using the resource. So I thought it'd just be really helpful just to give you a brief snapshot of some of the content in the resources that we've included that have been designed to better support women with the fertility preservation treatment decision. So for example, we include decision guidance statements, talk about who the book's for, who it's relevant to and who it's not relevant to. And we include things like decision pictures, tables, questions, some value question exercises to work through, writing spaces for them to jot down notes on so they can take to the consultation with them, and a glossary which has been found to be really, really helpful to the women who've used the resource. So this is an example of how we represent the fertility preservation treatment visually. As you can see, it's really neutral. We don't favour one over the other. We also include the option of not to do anything, that they don't have to preserve their fertility, but they could just wait and see if it comes back naturally after cancer treatment. So we don't wait pursuing treatment more favourably than doing nothing. We just present all the options, and then it is for the woman to come to the decision that's best for them. This is just an example of how we present the options, and we talk through question and answer. It's in a question and answer format. So, and they're all identical for every option. So it's, will this option affect the health of the baby? No. Are there any effects of having fertility preservation? Any side effects? No. And we do that for every single one, so that again, everything is really balanced for each option. This is an example of the values clarification exercises, where we get women to think about what matters most to them. Is it important to them to start cancer treatment straight away, or do they want to delay the start of cancer treatment to have fertility preservation? So these are just some exercises to work through that are meant to help them think about the things that are priorities and matter most to them. And these are just some examples of the questions that we provide, and we do that for each section. Because sometimes if you don't know what to ask, you don't at the right time, you don't get all the information that's going to help you make that decision. So these are the kind of prompts, and then again we provide prompts to help them make sure that they can repeatedly go back to their clinical care team and to check things. For example, have you been referred, if it's important to you to be referred for a fertility preservation consultation. And then finally, the book mainly focuses on thinking about the fertility decision before starting cancer treatment. But we also take them through what might happen during cancer treatment, what their fertility options are, and then post-cancer treatment as well, what their fertility and family planning options might be to them. So we try and take them through that whole fertility pathway before, during and after their cancer treatment. So in summary, cancer treatment, surgery, chemotherapy, radiotherapy can all affect a woman's fertility, and women with BIA-ALCL could potentially have to make these fertility preservation treatment decisions, and they may have faced them with a BIA-ALCL diagnosis, but they may also have faced them as part of receiving a breast cancer diagnosis previously. So it's really important to think about the impact of cancer treatment on fertility for women with this type of diagnosis, and with breast cancer diagnosis generally too. Psychological decision support interventions such as our cancer fertility immune resources may be of great value to women. We've done lots of research with women, and we've had really positive feedback where they find it highly acceptable and really better supports them at this stressful time. And you may be interested to know that from January 2022 we've just received funding to translate and roll these out over 5 European countries. So we're going to be translating them into Spanish, German, French, Italian and Dutch, and we're going to be then undertaking some studies to get women living in Europe their feedback on the resources from their perspective, and hopefully we're going to be able to find that our interventions are also going to better support women living in Europe to make the right fertility preservation decision for them at the right time. So thank you for listening, and if you've got any questions, please don't hesitate to contact me. Here's my email address, or to hopefully I'll be able to join you live in a moment, and please feel free to ask me any questions then. Thank you.
Happy to support you in the possible distribution of that awareness, and thanks for providing the information and for sharing the toolkits. For the next speaker, we have Natasha Bolanos. She is the Global Alliance Manager of the Lymphoma Coalition, which is a global operating patient advocacy group for people with lymphoma in general. Interestingly, 6 months ago, we got in touch and there was no awareness of BIA-ALCL with the Lymphoma Coalition. So that is a very interesting collaboration we have found, and I'm very pleased, Natasha, that you're online. You also were a previous consultant on a breast cancer unit in Madrid, Spain. So please let us know your experience, please. Thank you.
Thank you very much. Indeed, my name is Natasha Bolaños. I have a background as cancer rehabilitation specialist through exercise referral. My first approach to this field was specifically with women who have been diagnosed with breast cancer. And I have been working with women for a number of years on a daily basis, going with them through the patient journey in general. I mean, I have been working with them just after diagnosis, before going under treatment and surgeries, during also the course of the reconstruction surgeries, and afterwards. And for transparency, I do not have personal disclosures, but I want you to note that the Lymphoma Coalition received funding from pharmaceutical companies. None of these companies funded more than 30%, and all the procedures and policies about how we work with industry are publicly available in the Lymphoma Coalition website. For those who don't know us, the Lymphoma Coalition is a global network. We currently are 83 patient organizations from 52 countries. We work at global level, and we produce a number of resources and work in several areas, but our main focus is on advocacy and research for gathering information, meaning that everything we do is evidence-based. We try to base our campaigns, our awareness plans, and the way we try to inform clinicians, policymakers, scientific societies, and regulatory bodies in general, and other partners, is based on data. And we also run a global patient survey. This is an event that we run annually. The 18th Annual Lymphoma Coalition Global Summit was held this week from Monday to Thursday. This virtual setting allows more participants per organization than in-person meetings, although we miss the in-person meetings, of course. And these sessions are offered at multiple times to account for the many time zones members live in. Although, well, we must acknowledge also that the virtual setting allows many more participants per organization, but also non-member organizations were invited to join. And this virtual global summit is packed full of learning and information for attendees to take back to their local organizations for use in their daily practice. And it's not limited to the sessions, because we can allocate in this virtual venue scientific literature, white papers, case studies, ways to use data locally about, among others. And these resources are now available on this platform and will remain available for at least 1 year. We have in place a number of alliances and partnerships with different types of organizations. Some are alliances that we have with other patient groups, and I want to raise the case of the Global Cancer Coalitions Network, where breast cancer coalitions groups from around the world are included. And we also partner with the International Lymphoma Epidemiology Consortium, where we have an active role with the European Lymphoma Institute, with a number of groups and regulatory bodies that we think could offer good support for the work we are planning to do on this lymphoma subtype. I told that everything we do is based on our on data. So I want you to know that every 2 years we conduct a biennial online global survey, and this has been conducted every 2 years since 2008. We work with the Picker Institute Europe to ensure that there is a methodology, that it's reliable, and that can be considered for evidence. And for the 2020 Global Patient Survey, we received almost 12,000 responses from 91 countries around the world. And the responses came from two streams, 9,179 from patients and 2,699 from caregivers. And each member organization within these countries are provided with this data to help them in their own planning and advocacy works. And the results from the Global Patient Survey allow Lymphoma Coalition to conduct and publish its own research on the patient experience, but in many other issues that we can evaluate. And this is an imperative issue because we can raise globally what are the unmet needs and try to partner also with other bodies to try to promote the change. And all this information is really relevant when we come to analyze the shared decision-making that is regularly accepted today for the patients to have an active role when they decide any treatment, when they decide to go under surgery. This is not only applied when you are a patient from the point of view that you have received a diagnosis of a disease, but every time you decide to go through any surgery procedure, or as it could be the case of prosthetic surgery, there should be a shared decision-making in place, but for that is relevant to receive timely and unbiased information. Eric explained that when we first talked with him, there was no awareness in the Lymphoma Coalition for this lymphoma subtype. Well, that's not exactly the case, because we were aware of this lymphoma subtype. Indeed, the breast implant associated anaplastic large cell lymphoma had a special session on the 2019 International Congress for Malignant Lymphoma that takes place every 2 years in Lugano. And we were there, in that session, talking with clinicians and trying to understand better. But what is true is that having not known anything about this lymphoma subtype 20 years ago, this was not individually and regularly included in our global patient survey, meaning that we were not doing any kind of research to report cases or to understand the patient experience or to understand what we could do. This was considered a very ultra rare lymphoma, and the reported cases may have fallen in the group of other T-cell lymphomas or other indolent or aggressive lymphomas, because we group certain categories when for the patient to report the lymphoma subtype they live with. We have so many unknowns, but as we have learned a wealth of information and we realized we should explore to get to know the patient experience. That's true, and that came after having these first conversations with Eric, after listening to some clinicians that were really worried about this lymphoma subtype. And we wanted to be better equipped to raise awareness among the physicians of the entity and also healthcare professionals in general, including primary care nurses, but also the society in general, the citizens. And of course, the scientific community, regulatory bodies, and policymakers to advance legislation and establish prevention and early detection measurements. The good thing is that we actually know quite a bit about what the cause is and how to treat properly and also how to prevent and diagnose early this lymphoma subtype. When patients are told about their diagnosis, too often they only come away knowing they have non-Hodgkin lymphoma. That was the case in the past. For instance, according to the Lymphoma Coalition 2016 Global Patient Survey, 1 in 4 patients only were not aware of their lymphoma subtype at the time of their initial diagnosis, and nearly half didn't understand the characteristics of their subtype. That means that patients were told that they had non-Hodgkin lymphoma, so they really didn't know what they have, but they know what they don't have. They don't have Hodgkin lymphoma. But this is not enough, of course. And this is even worse when it comes to these breast implant-associated lymphoma subtype. So I just want to illustrate past experiences and the Lymphoma Coalition to drive the change. So from 2016, we did a lot of campaign and we worked a lot with clinicians, with scientific societies to promote patients to be informed about their lymphoma subtype. And I'm happy to tell that by 2018, the Global Patient Survey findings reported that most respondents globally were aware of their subtype at the time of the survey, meaning that we achieved that change. It was a big, big milestone, especially nowadays that we have so many targeted therapies and precision medicine in place. So we are fully convinced that it's time for change, that we need to drive the change on breast implant-associated anaplastic lymphoma. The background information we have so far is the link between texture breast implants and the disease was first reported in 1997. But it's quite shocking to know that the FDA first identified, and with evidence, that possible link between breast implants and this lymphoma subtype in 2011. 10 years have passed since then, and we're stunned to see not much has been done at regulatory or policy level, not to mention the lack of awareness campaigns. Although there have been several studies and announcements from the FDA and from other international bodies, the general public and the medical community alike have never heard of this risk of this disease. So this remains an opaque and obscure diagnosis for many patients and clinicians alike, and raising awareness about this lymphoma is paramount. The incidence, prevalence, and impact could be much larger than currently reported, and this type of lymphoma is serious and can lead to death, and especially if not treated promptly. And the concerns we have is that there are large variation in the ability to correctly diagnose and report. And some countries have quite well established breast implant registries, but it's only for breast implants. But the approach is not designed to target the breast implant associated anaplastic lymphoma. So these registries are scarce. And we know certainly that there could be certain influence of genetic variations, but we need to understand those genetic variations also to offer prevention and also to offer early detection. And of course, the prevalence of high-risk implant cannot be excluded, and we need to know more in order to inform better to the society. So, and knowing that, we also wanted to explore the level of information that women have. Women come across so many barriers before they get adequate answers, even when they receive the diagnosis. Barriers when they are speaking with medical professionals that never heard of this disease, a full roadblock with health insurance because it's not covered, or because many women need a referral to get tested, and at the end it's a roller coaster of emotions and barriers, and we really want to target this and to have an active role in the call to action that is coming. We are convinced that prevention is better than cure, and we think that this is a lymphoma subtype where we can offer prevention by raising what implants are more likely associated with the lymphoma, but also knowing that there are so many mechanisms that some companies are putting in place in order to offer early detection or constant tracking of the state of the breast and the implant. So it's relevant to raise awareness among breast cancer patients and women in general, and we want to work on that, but we want also to ensure that this prevention and early diagnosis are equally offered without disparities at global level in timely manner. And we think that by building partnerships, we can ensure impact at global level, and that's why it's fundamental for us to be here today. As a plan to call to action, we want to include this topic in the European Lymphoma Institute and the International Lymphoma Epidemiology Consortium. This should be one of the agenda issues to be treated with priority. We also want to promote policy making, for instance, a bill requiring breast implant associated anaplastic lymphoma and breast implant illness in general to be included in a checklist presented to patients in advance of their implant surgeries. I want you to know that we recently discovered that there have been at least a first reported case of a glued implant associated lymphoma. So the breast implants are not the only cases. Other implants could be having the same issue, and nobody is talking about this. And we want plastic surgeons to provide patients and women in general, or any person, because this goes beyond women, this can affect transgender people, and we want those to receive detailed and unbiased. It's fundamental that the information should be unbiased of the health risks posed by breast implants and any other implants, and obtain written informed consent prior to performing surgery. And we think we are now well equipped to do that. So as a first step, I want you to know that this lymphoma subtype has been included with a single category in the next global patient survey that is going to be launched in January 2022. So that's tomorrow. And from that, we think we can also gather enough data to get to know better what the patient journey is and how we can help to really move forward with the community of women that are currently living with this lymphoma subtype. I'm open to questions. Thank you very much.
Hi, everyone. I just want to thank Eric and all of the attendees for inviting us to play a part in this conference. My topic is living with the fear of BIA-ALCL. Open up my thing. My name is Jamie Cook. I am co-founder of Breast Implant Victim Advocacy. I am speaking today on behalf of our support group called ALCL in Women with Breast Implants, and also for www.BIA-ALCL.com. This is our global BIA-ALCL admin team. We started this group in 2016 after we met several diagnosed women with Monique Bach in Australia. We realized that they needed a support system. The group was started in February of 2016. We bought the www.BIA-ALCL domain that same year, and the website was officially launched in 2018. We are now the largest social media resource for BIA-ALCL, for women who are diagnosed, for women who are symptomatic or concerned, and just for general education. We also manage a clinician-patient discussion group and a group that is for diagnosed women. Apart from myself, all members of the global admin team are diagnosed. What is BIA-ALCL? I'm not really going to go into this because I believe that all attendees of this conference are aware of BIA-ALCL. We just want to point out that we are grateful that the term emerging is replacing the term rare when we're talking about this lymphoma. Our goal is to continue for public awareness, regulatory body support, physician education, transparency, and manufacturer accountability. The current risk of BIA-ALCL, of course, is widely varies. In some research, it's 1 in 400, and others it can go from 1 in 2,000 to 1 in 84,000. So our biggest fear in regards to statistics is that the number is just, it's all over the place, and we don't really have an accurate statistic to share with women. So part of that, I think, is because we can't determine that based on having no denominator for the number of implanted patients. And we are concerned that proper risk cannot be determined. We're also concerned with this, that the number of cases of BIA-ALCL will start to rise in correlation with peak textured implant use. Fear is a very natural emotion. We all face fear at some point in time or another. I think what we want to point out is that the fear related to this cancer is often accompanied by guilt, especially in patients who have chosen to implant for cosmetic reasons. And what happens when you're faced with a fear that could have been avoided or prevented? When I first started to look at how to put down on paper what the fears of patients were, I really wanted to take patient perspective into account first, and then second approach would be advocate fears. What I realized is that these fears are two, they're all one and the same. So we tried to look at the potential patient situations and how they would be affected. And we realized that as advocates, we have the exact same fears. So we just see them on a larger scale. We broke it down into the table above, from patients considering implants to diagnosed patients. Probably not going to go through this entire table. You can screenshot it, would be just as easy. But basically the left, we have patients who are considering implants. These are going to be the patients that are potentially not warned about this cancer. We have reconstruction patients that are potentially not informed of all of the available options that they have. We have fear that the risk is being minimized and the treatment is being minimized or misleading. We're also concerned that regulatory bodies are not educating the public enough. Our second column is going to be the implanted patient who is unaware of BIA-ALCL. Our concerns with these patients are that these are the patients that are not going to know to monitor for potential signs or symptoms. These are also going to be the patients that are potentially rushed to removal without knowing that there's a cancer risk present. The fear that these patients are going to be cared for by a doctor that is not literate in BIA-ALCL. That we always have the fear that this is a diagnosis that can be hidden. And the fear that a patient who's unaware of BIA-ALCL will possibly mislead other patients. For our next group of patients, we're looking at asymptomatic patients and symptomatic patients. Be aware that some patients do not know what type of surface they have. And some women are told they have one surface type only to find out they have another one on removal. So the asymptomatic patient who has no history of textured device. So these are going to be your smooth implant patients. Our biggest concern is that the doctors are going to not follow these patients as closely clinically, or that they're going to ignore future symptoms due to the history of only having smooth implants or expanders. Asymptomatic with textured device, fear that there's a risk even after explantation, that the implant removal does not reduce that risk. There's a big fear that these patients have an inability to afford removal of their textured devices, and the generalized fear that they have to even make that decision to keep or remove them. We also have a fear that reconstruction patients are unaware that they have a history of a textured expander. So these are going to be your patients with a smooth implant who do not realize that their reconstructive expander was texture surface. Symptomatic patient with either textured or smooth fear that the evaluation is not thorough. That could be the diagnostic side, pathological examination, too little fluid is sent, too little capsule is sent. That could also mean that the entire specimen is discarded completely, which we have seen on more than one occasion. This also relates to patients who are rushed to explant without following protocols. Fear of inability to afford testing or removal or lack of medical coverage to do so. And then we have the diagnosed patient. These patients fear the advanced treatments options. This could include chemo, brentuximab, stem cell transplant, radiation, etc. Fear that this cancer is going to recur or development of a secondary cancer. Fear of financial burden or lack of medical coverage. Fear that they have an indefinite future of tests and monitoring, or even worse, that not enough monitoring is being done. Fear that they're being cared for by a doctor that is not aware of BIA-ALCL protocols. And last but most importantly, these patients are afraid of death. From an advocacy standpoint, I just want to highlight some of our fears on pitfalls in diagnosis. No misdiagnosis or misdiagnosis. No one's obligated to inform these patients about BIA-ALCL. It's usually just a recommendation. Rush to explant mentality by surgeons and patient advocates. This one's a big thing for us because our breast implant social media community is huge. And if a patient is symptomatic, they are often told, just go get your implants out. And they're even told that often by surgeons. And so we really want to stop and talk to those patients. We want to stop them and say, you know, this is not the appropriate path that you should be on. And we want to offer the proper guidance for those patients. Failure to perform screening ultrasounds prior to explant. We really feel like surgeons who are explanting on a routine basis should make this part of their screening process. If you're going to explant frequently, then just do an ultrasound in your office. I think they're fairly cost effective. Just make sure that there's no fluid, because if there is, we can go ahead and follow NCCN guidelines and aspirate those patients before surgery. Removal is a cure anyway, so why test approach? This is frustrating from an advocacy standpoint. We have heard doctors say, I'm doing your en bloc, I'm doing your capsulectomy. That is the treatment of BIA-ALCL, so there's not really any reason to test you. Ego or lack of humility. I know that sounds bad, but I guess I would say that that's the failure to move the patient to a BIA-ALCL literate surgeon when they need to. Lack of BIA-ALCL literate teams globally to address the patients quickly. Pathological concerns, I mentioned that a little bit, too little fluid or tissue, lack of complete testing procedures, a generalized lack of awareness on the lymphoma, no accountability for not following proper diagnostic or treatment protocols. So this is, you may have surgical societies that are really educating their surgeons, and yet we still have surgeons that are not following recommended diagnostic protocols for this cancer. Lack of adequate medical coverage for symptomatic testing or testing an explant. And we really need a global BIA-ALCL team that includes patient advocates. We asked members of our social media groups the following question: what is your biggest fear related to BIA-ALCL? These are some of their responses. I think I'm going to go ahead and just pull all of these up. This top one is significant because a lot of our patients are reconstruction patients. A lot are facing the decision on whether to leave recalled devices in their bodies or textured, not all recalled, but textured devices in their body or take them out. They're concerned that they'll never be in the clear because currently the data does not suggest that removal will reduce the risk. And this patient, I had stage 3 breast cancer and double mastectomies. They didn't choose breast cancer. They were reconstructed with textured implants, 12-hour surgery with DIEP procedure, and the doctor who promised he would test for BIA-ALCL did not test. I had cancer taken out. I would never have knowingly chose to put cancer back in. Are we doing enough? Being an advocate for a rare disease cancer is not easy. Sometimes we find ourselves in the right place, and sometimes we find that we have missed the mark. Just in the past week, we were handling 2 different scenarios with patients in our support group.
And cut Jamie off, but we have a time issue, so I'm happy to respect that. Thanks again for giving us the opportunity. I hope, and we're of course not doing enough, and I hope that this gives you some of our intentions, that we want to move from a traditional medical device manufacturer to that women's health company. And we're going to repeat doing these sessions at all the meetings which are coming up. And thankfully, we are going to see each other face to face again, which helps enormously in creating awareness, because through Zoom, and we heard it already earlier today, Zoom is not a platform for building trust and relationships. So thank you very much, and we'll stay along, so please connect with us once you feel that need. Thank you.
Thanks, everyone. Have a good afternoon.
Okay, thank you very much to be back. I'm pleased to introduce you the welcome remarks from the Dean of the Faculty, Professor Lucidi, and the Chief Medical Officer of Sant'Andrea Hospital, Dr. Paolo Annibaldi. Thank you very much. Please.
Thank you so much, Professor Santanelli, dear colleagues, authorities, distinguished participants to the 7th International Breast Surgery Workshop and to the 3rd World Consensus Conference on Breast Implant-Associated Anaplastic Large Cell Lymphoma. It is a great honor for me and a privilege to welcome you at the Faculty of Medicine and Psychology, and on behalf of the rectress, Professor Antonella Polimeni, to welcome you at Sapienza University of Rome. With over 700 years of history, more than 115,000 students, 3,300 professors, in addition to 1,600 medical doctors employed in its university hospital. Sapienza is the largest university in Europe. Our mission is to contribute to the development of the knowledge society through our research, quality education, and international cooperation. The most influential university rankings worldwide place Sapienza among the first Italian university for its research, educational quality, and international dimension and relationships. In the ranking for subject categories, our university is a reference point for many disciplines, namely in the medical area. This is the case of breast reconstruction, and I want to particularly thank Professor Santanelli for the work he did to identify the breast implant-associated anaplastic large cell lymphoma. This work, together with the research effort of many colleagues involved in this workshop, has entered in the discussion of the Health Committee at the European Parliament in favor of the health of European citizens. Despite the incredible effort by scientists around the world, there is still much we don't know, and more education is required about the breast implant-associated anaplastic large cell lymphoma, and more in general about breast surgery. International cooperation seems to be the best way to reach this goal. It is for this reason that workshops like these are so important, and so great is the privilege to be able to host them, despite the limitation imposed by the pandemic situation. Thus, my biggest thanks are due to the organizers, and my best wishes to all of you are for a successful workshop and a consensus conference. Thank you. Welcome in Rome.
Thank you very much. And now I'm pleased to give the microphone to the Chief Medical Officer of the hospital, Paolo Annibaldi, which is a breast surgeon. It's a conflict of interest, of course. We have to declare, disclose it.
It was a mistake. So, thank you, Professor Santanelli. Can you list me? Thank you. Well, in our hospital, breast surgery is only part of the activity of the Department of Plastic Surgery, which is running the national program for facial allotransplantation, and was the first to perform in Italy. Nevertheless, they are an active part of Sant'Andrea Breast Unit with very outstanding outcomes. Professor Santanelli di Pompeo experience may refer to more than 2,000 breast reconstruction interestingly, 81% immediate with the mastectomy versus a national trend of only 15%. Here was adopted an autologous-based approach, having autologous techniques as first choice reconstruction and counting for 61% of our patients. Among those, Professor Santanelli di Pompeo unit performed the highest number of DIEP flaps in Italy, with an experience more than 700 cases, with a success rate about 99%. Besides that, they must probably are the world leader experience on the cosmetic breast reconstruction with autologous flat transfer after nipple-sparing mastectomy. And finally, we fought a lot with other institutions. By the way, we have scored a great goal. Following literature, data, and the final opinion from SHEAR on the occurrence of BIA-ALCL, we decided to use a smooth surface in our implant-based breast reconstruction and limit the use of textured implant only when strictly necessary. For us, for me and for Professor Santanelli, I think it's a new era. Thank you.
Thank you very much. I'm very honored from your introduction. I'm very pleased. It's a great honor for me to have the faculty and the hospital. Thank you very much. We can start the next session. Thank you. And I invite Paul Harris, Valerio Cervelli, and Francesco Stagno dal Contres, which is the president-elect of SICPRE, will replace Francesco D'Andrea, who couldn't attend. There is a minor change in the session. Riccardo Cipriani couldn't join us because of a storm in Corfu. He couldn't fly over. So we will finish 15 minutes early, and the next session will start 15 minutes earlier. So we include an extra presentation in the following session by Giovanni Botti. Thank you for your attention.
Well, good afternoon and welcome in Rome. And I'm chairing this session in place of Professor D'Andrea, and well, we go on with the session with the first speaker. This is the Dr. Pietro Berrino with a work about from Weiss pattern to periareolar mastopexy.
Thank you, Fabio. Thank you, Mark, for inviting me. I'm really very happy to be here and to share with you my experience with the periareolar mammoplasty. Actually, in my practice, periareolar mammoplasty has really increasingly replaced traditional techniques in several different conditions. Why? Because it is really modern surgery. Minimal invasiveness and scarring, stability of the results, minimal risk of complications, and maximal adaptability, flexibility, and you don't burn any bridge behind you. So it allows to obtain outstanding result through creativity and minimal trauma. Why it is so powerful, although it is minimally invasive? Because it exerts its action on the apex of the breast cone. So it allows to change this shape into this one with really minimal external scarring. So I use this technique in several conditions: ptosis, tuberous breast, asymmetries, secondary breast augmentation, and also breast reduction, which is rather a new topic. So what are the indications in breast ptosis, which is the crucial point of all the concept of periareolar mammoplasty? The indication is the triangular ptotic breast. What does it mean? That in the lower pole you have minimal tissue excess. Of course, the flat ptotic breast with a ptotic lower pole is not an indication to this procedure. So this is the change that we can obtain with this minimal procedure performed on an ambulatory basis and under local anesthesia. It's a triangular shape breast, and you see that it is not true that the breast is flattened. Actually, if you have a good compromise between skin resection and the content of the breast, projection can be maintained, as we can see also in this other patient with a triangular breast. It is a wonderful technique for symmetrization, as in this case. You see the nice symmetry achieved with this minimal operation, while this is a borderline patient. Why? Because the lower pole is a bit ptotic, so the result is not perfect, but still she is a candidate. So how far can we go with nipple areolar elevation? Very far. We can deepithelialize a large portion to obtain upward migration of the nipple and the round shape of the breast. As in this case, we see one side operated and the other side not yet operated, and the nice symmetry, that the nice projection that has been maintained and or better created. And the same can be transferred to tuberous breast, as in this patient. Of course, these are also candidates to breast augmentation, but when they are very young, 17, 16 year old, it's better, in my view, to postpone augmentation later. They are not mature enough. So they gain normality, a normal appearance of the breast by this minimal operation with minimal scarring. And we can achieve symmetry by resecting different amount of skin on the two sides. Of course, we also have to work on the breast base, relaxing it, releasing the fibrous attachment, and modifying the breast base, obtaining this type of results. So what is the technique I use? I use 4 periareolar sutures on different levels. This is the epithelialization. Of course, through this opening in the gland, I can modify the breast base, or I can introduce the implant. Then this is the first suture. It is a deep subdermal suture. You see how deep it goes when you close and you pull the threads and you close the knots. So it's about 2 centimeters deep. And this is the second dermal suture. You see that when you will close the skin, it will be at least 1 centimeter deep. And then the last suture is the interlocking suture, which equalizes the two circumferences. And this is the final appearance at the end of the operation. The rest is changed and with the minimal external scarring. And the same concept applies in this patient with the important asymmetry and tuberous breast. I just did a modification of the shape of the breast on the left side, while I did an important reduction on the right side. And you see normality is restored through with minimal residual scarring, which is the ideal procedure in this very, very young patient. They gain normality through this approach with minimal residual damage. You see that this really abnormal breast is modified into a normal one, and in the future, if she will like, she will have an augmentation. And this is also modern surgery. I did a breast reduction with the periareolar approach on the right side. I corrected the tuberous breast just by fat injection on the left side, and normality is achieved. So let's go to see a periareolar and breast augmentation. Of course, when you have a tissue deficiency in the lower pole, you cannot do a traditional technique. Taking skin out from the lower pole, in this case, is really detrimental. And when you have some asymmetry, like in this case, you can achieve symmetry by placing implant and by modifying the skin tension above it. So you can see on the left side she had a ptotic lower pole, which was reduced by some larger epithelialization below the areola on the left side, achieving this type of symmetry. And in this patient, a patient who was not suitable for breast augmentation alone, of course, was transforming in a good patient thanks to this minimal periareolar approach. So in secondary breast augmentation, this is a really powerful procedure. We can choose either to modify only the tissue above the implant or also to act on the implant by modifying the tension on the capsular tissue around the implant. So in the first group, let's see only the patient in whom I just modified the tissue above the implant without touching the implant. So I restored symmetry by a unilateral small periareolar mammoplasty. I improved the inner upper quadrants by lipofilling, and symmetry was restored, and the final result is acceptable with a minimal ambulatory procedure. And this was a more difficult case, just managed by lipofilling and bilateral periareolar mammoplasty, changing a possible major operation into a small ambulatory local anesthesia procedure. And you see the change on the lateral view. And in this type of patients, which are not rare, where a tuberous breast was disregarded before breast augmentation, you can just modify the tissue above the implant by a circumareolar resection, which should have been done before, without touching the implant, obtaining a normal appearance of the breast, as you can see in the lateral view also. But there are cases which must also be managed by treatment of the capsular tissue, of course. This is a difficult case. It was managed by a periareolar asymmetrical mammoplasty and modification of the capsular tissue around the implant. What does this mean? Capsulotomies and small capsulectomies where you need to have release of the tissue, capsulorrhaphy where you need to make the pocket of the implant tighter. So this, managing the tension on the capsule, you can achieve a symmetrical implant position, and by managing the superficial tissue by periareolar mammoplasty, you have symmetry of the tissue above the implants. And this concept can be repeated in difficult patients like this one with symastia and asymmetry and a lateral right nipple area position. You see the symmetry that one can achieve by modifying the superficial tissue and the capsular tissue around the implant. This is during the operation, at the end of the operation, and the lateral view showing that projection is maintained. And this, I think, is the last important case. This was a really severe capsular contracture. This polyurethane implant were really hard as a stone, and I had to cut the capsule to allow the implant to come out of the incision. So this is at the end of the operation, and this is the change that I obtained by combining the treatment of the deep and of the superficial tissues. So perioral technique makes breast corrective procedure simpler, faster, often ambulatory, reduce the risk of untoward result because you don't have tension at the lower pole. I thank you for your attention.
Thank you, Piero. If there is some question from the auditory, please. In the meantime, I have a question. Piero, what's the role in the reductive perioral approach of liposuction before to do the perioral approach? In your opinion, I know that is your young.
Yeah. It's a good consideration. Anything that can reduce the weight of the breast, the mass of the breast, by itself lift the breast upwards. Is a concept that we learned from Gerardo Peixoto in the 80s. So in these cases, the perioral excision just help us to replace the nipple, but the main work is done by reduction of the breast weight. So I completely agree with you.
Please.
Okay. Thank you very much for this lecture. Do you think that the resection of the skin as a whole is safe? Compared with deepithelialization? I mean, you make two concentric rings and you do deepithelialization. So, what will it be endangered, the nipple area complex, if you remove the whole of the skin?
No, I don't think you have important risk of reducing the vascularity, but you need the dermis to have a strong suture around the areola. So you always have to leave a cuff of dermis in the along the external circumference to have something where your thread can go and be pulled. Otherwise, if it is only fat, it will break.
What kind of thread do you use?
I use Prolene or nylon 3/0 for.
So that's not resorbable?
Not resorbable, no. We learned from Mario Pelle that when patient go to other surgeon and remove the deep sutures, even after a year, the areola can spread. So only permanent sutures.
Okay. Please, introduce yourself before to do the question, please.
So, thanks. Thank you for the great talk.
Thank you.
Just a technical question. How you do the local anesthesia? And do you have an anesthesiologist in the OR or you do it by your own?
Well, anesthesiologists depend on the personality of the patient. If they are patients who are rational and calm, you can do really under local anesthesia. Something like the anesthesia that you use for liposuction or a bit more concentrate. You just have to if you don't have to work on the breast base, of course. So in normal mastopexy, you can do with a small amount of local anesthesia around the areola, which is very easy with amount of anesthetic that are really very, very small. Sedation only if you see that you have patients who are stressed, who are nervous, who are afraid and scared. So in this case, it's better to have a sedation. But actually, you don't need it to reduce the pain.
Thank you very much, Piero.
Thank
Dr.
you.
Harris, you can introduce the next one.
Thank you very much. That's a surprise. I haven't got my list here. Dr. I can't see.
Swanson.
Dr. Swanson, comparing augmentation mastopexy results with measurements. Dr. Swanson, thank you so much.
Thank you. So I'm in private practice in Kansas City. And my disclosures are these two books, Evidence-Based Cosmetic Breast Surgery and Body Contouring Surgery. So what are patients' preferences? Well, patients don't want linear upper poles. They want convexity. And this study by Shaw and Thompson was very interesting because it showed what patients wanted themselves. And of course, they want a correction of sagging. So how do we evaluate and compare different techniques? I developed this two-dimensional system to do just that. I found 1D was too simple, 3D too complicated, and this has worked for me and it's practical. It allows me to evaluate both my own results and also publications. So I initiated this study comparing different augmentation mastopexy methods. I looked at 106 publications since 1979. There were 16 in 2019, so a lot of publications. How do you sort out which works and which doesn't? We have to do measurements. So there were five groups that were commonly used: vertical, periareolar, inverted T, either central mound, superior, or inferior pedicle. Now, it's important that the photographs be standardized, and this is something that plastic surgeons are very weak on. Many studies, we do not see standardized photographs. The photographs on the left look like they're okay, but actually the post-operative photograph is 25% magnified. It's also tilted slightly. So you see that I've corrected it on the right side, right over here. So this is the first group of patients, and this is a representative of this group. In fact, this is my own patient, vertical augmentation mastopexy. I use a medial pedicle, and you can see this measurement system allows us to compare relevant measurements of the breast projection, upper pole projection, the lower pole level, which is the lowest point on the breast, and the breast mound elevation, which is how far the most prominent point on the breast rises. It even allows you to compare area, which is a surrogate for volume. Volume varies as the square of the area. Here's an example of periareolar augmentation mastopexy. This was by Austin and colleagues. And these photographs have been, the Canfield system, I have no interest financially, but I use this in order to facilitate matching the photographs. You can see there's very little difference in the lower pole level. There's a modest increase in upper pole projection and breast projection, despite 330 cc subglandular implants. Let's move on to the third group, which is the central mound group. Inverted T resection, but a central mound for the pedicle. You can see that there is a boost in upper pole projection and in breast projection. The nipple's been over-elevated almost 2 centimeters, which is a common problem associated with a Weiss pattern. Here's a superior-medial pedicle. This is commonly used. Inverted T skin resection. And you can see the hatching. This is also a function on the system that I use to compare area before and after surgery, and it also allows me to compare upper pole area to lower pole area to give an estimation of the breast parenchymal ratio. And you want to see that increase after surgery. Here's the inverted T Weiss pattern resection and inferior pedicle. You can see very little difference in the lower pole level. Some improvement in breast projection and upper pole projection, but not a lot. And then we can look at mammographs. These are not artistic representations. These are actual mean measurements before and after surgery for each group. You can see the vertical group. It gets a good boost in the lower pole level. The upper pole projection is increased, and the breast projection is increased. These are things that we want to see. Periareolar, there is some improvement in the lower pole level, but not as much. Central mound, very little difference in the lower pole level. So now there are some other methods that have been published that don't fall into one of these 5 groups. We heard about this technique, Alexander Munhoz described it earlier, the Crimes technique. Now I found it difficult to really evaluate this technique because it looked like there had been some photoshopping on the pictures. You can see there's an indentation on the lower pole, so it made it a little difficult. Now what concerns me is, and this was the authors that found that there was a decrease in volume, 31% decrease in volume, despite using implants. So I don't think this really gets the job done. What about this other technique published in ASJ in 2020? These are the matched photographs. This is sort of an inframammary fold tuck procedure offered as a minimalist approach, or alternative rather, to augmentation mastopexy. Now these photographs, they're just what you'd expect from implants. There's actually a lowering of the lower pole level. There is an increase in breast projection and upper pole projection, but this procedure does not appear to meet our objectives in terms of providing a lift effect. So what are the results of this study, which were published recently in PRS Go? Well, all methods increase breast projection and upper pole projection, except for the inverted T methods. Now, why is that? Well, that may be because upper pole tissue is removed typically in the Weiss pattern. The vertical augmentation mastopexy was the only method that significantly raised the lower pole level. It also significantly increased the breast parenchymal ratio. So it achieved the surgical objectives. So there's been a renewed interest in periareolar mammoplasty. You just saw it with the last presentation. In fact, this was recently published and promoted as an all-seasons technique. Now, these are 17 Italian authors on this paper. They used visual analog scores and looked at complications, but they only did so in 28% of their patients that they selected. No measurement data, no control group, and again, as usual, the photos were not standardized. Here are some photographs from that study. Now, oftentimes, when you do a periareolar lift in combination with an implant, you wonder how much of an effect the periareolar lift really had. I mean, you could probably get similar results just with the implants. And this is a problem with this with the periareolar technique, especially if you're being more aggressive. For example, if you're using it for a breast reduction, these are pictures from the same study promoting this technique. And the after picture is not dated, but you can see these unattractive pleats around the areolas. And these tend to stay. So this technique was popularized, we all know this, by Benelli in 1990, but it fell out of favor. Spear had a paper in 2004 where the authors themselves rated 4 of the 30 results excellent. I've never seen a paper where the advocates rate their own procedure so poorly. And over half of the women requested revisions. Areola distortion, flattening, the starburst appearance, large caliber permanent sutures that you can palpate, they're a nuisance. And Gorney found in 2004 that this procedure had the highest rate of medical malpractice liability in the U.S. among mastopexy claims. So few surgeons in the U.S. at least use it exclusively, and the lowest rate of surgeon satisfaction in a 2006 survey. So if you compare periareolar and vertical, which is what I use exclusively, I think the vertical technique really is the all-seasons augmentation mammoplasty. But I think most of the different parameters, they fall in favor of the vertical approach. What about the central mound? This has also had some renewed interest in a paper, this paper by DeLong, published in PRS last year. It was the most viewed breast paper in PRS. The problem with the central mound is you're completely sacrificing the superficial vascular and sensory supply. And results reflect this. The authors found that nipple sensation was decreased. They had 2 cases of a nipple fibrosis, which is, is a catastrophe. Now, Spaniol and other authors published this technique, central mound, for cases of secondary mammoplasty. And once you match the photographs, there's really very little difference in this particular study in the measurements before and after surgery. So how does central mound versus vertical compare? You can see the differences in the red boxes. Again, the vertical comes out ahead. My original study was in 2011, where I used the same measurement system to evaluate publications on mastopexy. And I found that auto-augmentation, we've seen all of these claims of auto-augmentation, it's ineffective. Fascial sutures, they're ineffective. And this really should come as no surprise if you look at the geometry of the resections. On top you have the inverted T. Well, there are horizontal ellipses of tissue is being removed from the lower pole and closed. What that does is it trades projection for width. And because you're pulling down on the skin flaps, which is paradoxical, you need to relocate the nipple and areola at a higher level. So this procedure tends to produce square breasts with over-elevated nipples. The vertical technique does the opposite. You're removing a vertical ellipse. You're trading width for projection, which is favorable. We want projection, and we don't mind a more conical lower pole. The measurements reflect that. The lower pole is more conical. And the nipple and areola are pushed up as a result of the procedure. Periareolar, the surgeon is removing the skin and breast tissue from around the areola in order to limit the scar to around the areola. The problem is there's no removal of tissue from the lower pole. So if you believe, as I do, that we need to remove lower pole tissue, 2 minutes, right? Then this procedure is not going to work very well. The inframammary technique, which is the no vertical scar technique, is not very commonly used for the same reasons that the inverted T. It produces a square kind of look, actually even more so because it's not relieved by a keyhole. So if you look at the inverted T breast reduction procedure with inferior pedicle, the nipple position relies completely on transposition, okay? You're not getting an assist from the mastopexy technique itself. Whereas with vertical, 80% of that vertical upwards movement of the nipple and areola is created by the Mastopexy method itself, pushing the nipple and areola up, so you have to swing it. You don't have to swing it very far. So here's an example of vertical augmentation. These are my patients, vertical augmentation mastopexy. It works very well for breast asymmetry, secondary cases, breast reduction plus, a third of my breast reduction patients have implants simultaneously. And it's a safe technique. I investigated this using the SPY system to determine what exactly does the implant do to nipple and areola vascularity when I put it in during surgery, and it doesn't decrease it. Persistent ptosis can be an issue, 8.7% in my series. Patients are pleased. The patient-reported outcomes are very favorable. Long-term measurements really hold up better than I even thought. I looked at my 10-year results. Pretty good maintenance of upper pole projection, and the lower pole does gradually settle with time, as you'd expect. I prefer the medial pedicle because I get better maintenance of nipple sensation because I'm preserving the medial branches. So the most important technical point, adequate resection of lower pole parenchyma. Thank you.
Thank you. Thank you. Any question? It's very interesting. It's a geometric condition.
That's geometric.
We have reason.
Dr. Swanson, I have a question.
Yes.
Thank you for bringing some objectiveness to these studies, which is fantastic
Thank
to
you.
see, really good. I just ask about the nipple position, because are you measuring from the maximum projection of the breast? And I wonder, is that your ideal nipple position, or is your
Yes.
ideal nipple position slightly above? Or because some people would suggest that a slightly upwards inclined nipple position is
Right,
more
Dr.
attractive.
Malucci, you know, in his
Yeah,
ICE
yeah.
principle, 20% inclination. Of
right.
course, if you read my response to that, I don't think it should be inclined. That's an unnatural look. So the nipple should be at the point of greatest breast projection. It should not be inclined upward.
Okay. Any other questions? Mr. Malucci, would you like to comment on the nipple position?
Oh, hi, Patrick. He may respond to that comment.
Okay, now.
Oh, there's one more question over here.
More a consideration than a question, actually.
Oh.
I think the beauty of plastic surgery is to have a custom-made choice to the patient. It means that it's the technique that must be adapted to the patient and not vice versa. So your strict consideration that this is an all-season procedure and that is not, I think is not possible to agree with it. It's clear that when you have a tissue deficiency in the lower pole, you must have not to remove vertical skin there. On the contrary, if you have an excess of skin in the lower pole, you have to remove it vertically. So I think that...
Incidentally, I agree with you. I mean, it's a minus-plus concept, which Regnault originated. In cases of breastosis, by definition, you have excessive tissue in the lower pole, minus, and then you need to add to the upper pole. Implant does that best.
No, there are different type of ptosis. You can have a ptosis of the nipple areola complex without ptosis of the lower pole. So these are different indications to the lifting procedure.
But usually, when you have ptosis, you have problem in the lower pole, in the majority of the case, together with the nipple.
I don't agree, Valerio, because if you look to the classification that Giovanni Botti published about ptosis, you can have a ptosis of the lower pole, which is completely different from the ptosis of the nipple areola. That's the triangular shape that I was mentioning.
But usually you have to work, especially in the lower pole.
We must go on.
Yeah.
Okay.
Okay, next one. There is a question. Dr. Michel Atlan. Is a scarless mastopexy feasible?
Hello everyone, I'm really pleased to be with you. So why we are looking for scarless mastopexy? Because we are speaking about scar. And the patient, for most of them, they are reluctant to get scars. Many devices were developed to avoid them, but if we can avoid them totally and not just try to diminish them, it will be fantastic. So some people tried, and Roger Correa in Miami, he decided to do a separation of the gland over the skin and from the parenchyma. It's quite easy to do, and then he put a pexibra, you're going to see that, just to reposition the skin above the parenchyma. That's the pexibra. So he has very good results to me, and it's interesting with no incision, only a windshield process of through stab incision. Another surgeon from Europe, Marwan Aboud, he's from Belgium, very innovative. He used liposuction, loops, and lipofilling to try to do breast reduction and mastopexy. So it looks quite easy at the beginning, but I'm probably not enough intelligent because it came to be more complex. And to me, I'm not able to master all that, but he has very good results. The in-between period is could be frightened, but he has a good result. So I was looking for an easier solution, and perhaps a solution I better understand, and with the tool and devices I master. So I use Renuvion for my aesthetic practices. It's helium plasma and through radiofrequency. Well, what does that mean? That means that it put the skin at a level of 85 degree treatment for 4 milliseconds. So it retracts the fiber tissue, and it helped the tissue retraction and the skin retraction. So that's my aesthetic cases. So I was quite happy to try on the breast. This is the other results. So there is 2 videos, so you can send it. So the first part is to do undermining using liposuction and DIEP, exactly the same. And then, and then you use the Renuvion. So could you only make in action the second one on the right? So you use this retraction device, DIEP, and you use it superficially. You see, there is like a bubble under the skin. It's the helium, and it doesn't burn, but it's retract. So I tried that with it's very mild results. It's not fantastic result, but only with this kind of device, energy device, I was able to uplift the neck, and we can objectively. I hope Rick Swanson will see that. And I did periareolar, not because it was not good, because the aspect of the areola was a bit strange after. So I tried again and again. There is a slight elevation, not too bad for without any scar. I did a bit of liposuction and skin retraction through the Renuvion. The same thing, and I did an MRI, and I didn't find any differences. My urologists were very happy with that. So on the right side, we were quite happy, and we will see 6 months after. And with the help of tattoos, we are able to say that there is elevation. So I think it's something we could understand. The same thing. It was on a breast cancer on the other side. There was she was irradiated, and 6 months after, we can see a nice symmetry, probably through the fat grafting on the left side. So I tried on breast implant. She was not happy with this breast implant. I couldn't totally understand, but she doesn't want to change. I use fat grafting and this kind of the Renuvion under the skin only. I don't want to make any problem with the implant. So I was not the only one who think about that with Renuvion. So there is the third Duncan. And she has some of the same technique. You can run the video. Thank you. Yes. So exactly the same technique, and but she used more puncture to make it higher. so on the upper part, on the lower part, but it's almost the same. And first, we would like to do it deeply to make above the fascia, just a lower part of the gland, to attach to the pectoral, and superficially to retract the skin. So she has quite good result, but as a radio courier, she used tape to maintain the result, and she has quite good results. I have the authorization to use her images, and she has. I think it's quite interesting to think about. So I think it's not a technique that could replace mastopexy. It's probably I will need to use pexibra or something like that to maintain the results. Probably not with too large breast and not a bariatric case. I think it's a new tool for plastic surgery and a good alternative for breast asymmetry. And this is there will be a clinical trial that will start soon in France for this subject. Thank you very much.
Dr. Atlan, have you observed perhaps is allium?
Yes.
Did you observe something like subcutaneous emphysema?
Yes, absolutely.
In the first days after the procedure?
you have to do massage, and sometimes you need to do more stab to let the gas evacuated.
Yeah, because this is the same tools that was used for liver surgery.
Exactly. At the beginning, it was a G plasma.
Yeah.
It was adapted to plastic surgery, and now it's called a Renuvion. It's exactly the same. Not exactly with the same type of radio frequency, but it's the same.
The problem was the gas in the subcutaneous, and it sometimes could be very important.
No, because it's the volume is very low, and it burns really, so it's consumed.
Yeah.
So.
Okay. There is any question? Please. Short question and short answer, so that we have time for everyone.
Congratulations.
Thank you.
I have a question about the safety of the Renuvio. Of course, you mentioned that you use only subcutaneously, but I remember 2 weeks ago, Konstantin presented the argoplasma, so it's almost similar, and he announced that he used everywhere, in the glandule tissue as well, and I hesitated to safe, so that's why I'm asking you, did you have any data about the safety of the use, oncological safety, of course?
For Renuvion, the intensity of the energy is not enough to make a burn. There is other devices, I don't remember now, with, it's between the two, and you have, it could make a burn. But I won't go within the gland. I will go, because the gland is not the problem, in fact, to be really honest. It's usually it's more the skin or the position on the pectoral lymph major. So I won't go within the gland, and I didn't have any cases in my aesthetic cases and in these cases with burn.
Next one.
Dr. Can I ask, have you tried this with gynecomastia? It seems a good indication for gynecomastia.
With because it was not, but yes, I did try, and it has really, really good results, and especially if with weight loss, associated with the weight loss here on the lateral part, it's perfect. It works really well. I think we have to push this device a little.
Even in post-bariatric patients?
I didn't say that. I just say, no, we have to be careful. I don't a lawsuit. So no, it could help a lot on gynecomastia or adipomastia, when they are a little bit overweight.
And because you're not going into the gland, it's not going to interfere with mammography afterwards?
No, but I did MRI after. I didn't go through the gland, but I'm sure I a bit in the gland. And no problem for only the 3 MRI I did. But this is the reason why I want to do that on breast asymmetry only, and to make a comparison.
Thank you very much.
Thank you.
Well, okay, thank you. The next speaker is Dr. Malucci. Welcome. Achieving long-term stable results with the mesh in mastopexy.
Thank you very much to Fabio and Mark for the invitation. So I'm going to talk about my experience with mesh in mastopexy. These are my disclosures which aren't relevant. So Yeah, I've been using Galaflex mesh now for about 5 or 6 years. What is Galaflex? It's a synthetic material called P4HB, polyphenylhydroxybutyrate, and it has these attractive properties. It's biologically derived, it's monofilament, it's strong, and it's bioresorbable, which is nice because you don't feel you're putting a foreign body into somebody. I pretty much only use mesh now. I don't really have a role for ADM in aesthetic breast surgery any longer. These are the various indications in both primary and secondary surgery, but today we're concentrating on mastopexy. Just as a matter of curiosity, this is the first case outside of the US in 2016 on a Swiss lady who actually had an augmentation mastopexy. And as I've been using it ever since then. So the concept, it's fairly simple. It's this idea of taking on poor soft tissues and not relying on those poor soft tissues. So using something to help strengthen internal suspension, all those terms that we're familiar with. We all do our mastopexy slightly differently. I think we all use Galaflex slightly differently. I know Paul has a vast experience as well. And I'm sure we all do it slightly differently. I modified my mastopexy technique very much as a cut as you go in order to accommodate the Galaflex, and I use a superiorly based pedicle. This is just a diagrammatic representation, which we'll see in little video clips in a minute. I undermine the whole of the lower pole as a sort of a mastectomy type thickness. To expose the lower pole, I remove the excess skin, and I insert my Galaflex as a hammock into the lower pole as the support mechanism. So this is just sort of talking you through, this is an example, typical case of ptosis. This is the patient on table. And here, before I do any cutting, I'm going to do some tailor tacking just to try and understand my exact excision before I commit to those lines. Here I am just doing my tailor tacking. I can't speed these videos up, unfortunately, so we're just going to skip through them. But yeah, this is the procedure that you're looking at there. Once I've confidently marked my skin, I can remove, de-epithelialize it. I effectively park my nipple out of the way, and then I concentrate onto the rest of the procedure, which is going to be to undermine the lower pole. So this is the undermining from medial, inferiorly, all the way to lateral. These are thick skin flaps. As I said, I'm not really even cutting with my scissors. I'm just pushing to expose the lower pole of the breast all the way around. That's the bit that I'm doing diagrammatically, and that's what I want to seek to expose. I want to be able to hold that lower pole in my hand and to elevate it off the chest wall, which is what you'll see me doing here. I always elevate the lower pole, and then you can do a number of things. You can tuck the pole underneath to create medial and lateral pillars. You can do glanduloplasty sutures to get more projection, to narrow the base, according to what you feel is going to be beneficial to the patient. Once I've done that, I close my skin, my vertical, and then I seek to remove my horizontal element. The vertical incision is normally somewhere between 5 and 6 centimeters, depending on the size of the breast. This is variable, so I'll draw my marks, and then once I'm happy, I'll, according to the contour of the breast, I will excise the horizontal portion. As you can see here. So the Galaflex goes in at the very, very end when I've done all my excising, all of my skin removal, and when I'm happy with my breast shape. So there it is, pre-Galaflex, and you can see it already just checking my measurements, checking that I'm happy. This is what Galaflex looks like. It does come in different shapes. This is just very plain, the non-shaped form. It's a 10 by 20 sheet, which I cut in half and use 1/2 per breast, and then I just shape it accordingly to the breast. I taper it, and once I've done that, I start to insert it along the deep fascia along the inframammary fold. And rather than using this as something to elevate the breast, my concept is it's a prevention of it slipping down. So I think if you try and force it too much, you can distort the curvature of the lower pole, you can square it off a bit, but I suture it into the lower pole almost as I said, a prevention of descent rather than an attempt to push up. So there I am, just from medial to lateral, series of stitches all the way across, as you can see in that diagram. And here she is on table with the two sides completed. So what it does, it gives a real sense of stability. It's quite rigid, the Galaflex. And as I said, it really, it certainly gives a sensation of adding solidity to that rather fluid, floppy structure of a ptotic breast. And this is her on this is her beforehand, and this is just at the end of the procedure. So here we are. This is an early post-op at 3 months post-op, and this is at 1 year post-operative, and you can see a very stable result in terms of recurrent ptosis or descent of the lower pole, which is something that we're going on to analyse at the moment. This is just another view of her. And the Galaflex we can use also in secondary mastopexy. So more and more of us are having to remove implants, carry out mastopexies, and it's exactly the same thing where you're, as I said, doing an explant, capsulectomy, whatever else it is you need to do, and then you're doing your mastopexy. And again, there are a number of ways of doing this. It's the tail attacking, exactly the same. The idea is that you're making good the tissue that you have left. There's just the same procedure of deepithelialization. You can see the undermined tissue. And again, here you can either push the gland up and suture it, or I quite often do a crossover flap where I split the gland and then I cross it one over the other, as you can see here, in order to give projection to the procedure. And then exactly the same, skin excision, cut it as you go, exactly the same way, and then put the Galaflex just as we described before. So no different, just using the Galaflex exactly the same way, but in this more secondary situation. This is her before, and we'll see some images after. So these are just a few examples of sort of typical mastopexies. This is her before, this is her after, this is 9 months after. And again, really just pointing to that very stable lower pole, that lack of descent or recurrent laxity. This is again at 6 months, exactly the same. I love the lower pole, unlike Eric. And so what I look at is that lower pole curvature in terms of reconstituting my attractive breast. And again, stable results. One of the things that we did, just a whole load of examples here. This is 1 year post-op. Again, no movement in that lower pole. And again, 1 year post-op, exactly the same thing. And what we've gone to do is to try and measure change over time, which is not easy in terms of photo adaptation and adjustment. But what we'll be looking at is the percentage stretch over time, which we'll be looking at 3 month time intervals and 1 year time intervals, with an average stretch of around 5%, which compares favourably with the little literature that there is on this subject. Again, very challenging cases here. This is a massive weight loss. She didn't want an implant. This is 3 months and 1 year with, again, extreme stability. And again, we've chosen some difficult cases, very poor soft tissues. What I want you to see is this 3/4 view. This is at 3 months and 18 months. And again, real stability here. And then we have a 3 year post-op. And again, when we look at the percentage stretch over time, it's minimal and stable even in these soft tissue conditions. These are just some of those implant removal cases. Again, as you can see, just applying the Galaflex in exactly the same situation, making good of what's left of that residual tissue. This lady with very large implants. before and after, and again, before, this is 3 months and 1 year, looking at the change in lower pole stretch over time, which is very favorable, very consistent. Also now doing it with small breast reductions in exactly the same way, same principle. And again, this is almost 2 years after surgery. And again, I look at that lower pole recurrent laxity or lack of with this technique. And again, challenging, poor soft tissues. This is 18 months post-op. So it's become routine use for mastopexy and small reductions in our practice. It's completely eclipsed the use of ADMs. It's easy to use, it's versatile, and as I said, it's something that I've enjoyed using. Thank you very much.
Thank you. Thank you very much, Dr. Mallucci. I have a question. In your opinion, how much is important the remaining width of the the skin adipose remaining tissue for the long-term result and the immediate result? In other words, did you have any problem in the cross point of the inverted T due to the presence of a foreign body just subcutaneous?
So we've just submitted a 100 case series looking at complication rates. We haven't had a single case of tissue necrosis or delayed T-junction. These are thick mastectomy flaps with very safe vascularity.
Very interesting. Thank you very much. Is there any question from the auditory?
Is there any relative contraindications that you think, such as a smoker, diabetic, anything that would make you pause to put in this foreign body?
Well, I mean, to be quite honest, I probably wouldn't do a mastopexy in a smoker anyway. So it's not really that. Would I not use it in a diabetic? No, I don't think so. I think one of the things with Galaflex, unlike ADMs, and I'm sure Paul will confirm this, is its rapid integration into the tissues. It really integrates super fast. So you don't really have this worry of this dangling foreign body which is prone to infection.
Yeah, it doesn't go away though fast. I mean, I think it takes around 18 months to 2 years before it goes away. It just integrates quite quickly.
And there is any experience about the use of Galaflex in reconstructive breast surgery?
There is. The guy who has a lot of experience is Steve Sigalov from Chicago. He talks a lot about it. So I know that he uses it a lot in his direct-to-implant reconstructions now.
Even in direct contact with prosthesis?
Yeah.
Very interesting.
Yeah.
Okay.
Hey, Michael.
Just the level of the Galaflex. How do you decide? Because it could be quite easy to put it too high or too low.
At the level of the inframammary fold. Period. You know, and as I said, I think the mistake at the beginning, maybe I was putting it too high, and I was trying to think, I'm going to push the gland up, but it's not to. It's to stop it falling. That's the mentality you have to have. So I put it at the fold.
And there is no suture on the upper level?
There is onto the gland.
Onto the
gland? Yes, onto the gland.
Thank you.
Yeah.
Can I ask Patrick just one question? If you're just about the technical aspects of it, because there's some lovely cases, and it's you do a lot less than I do. I put a lot more Galaflex in around the breast. Do you get a transition where the Galaflex stops, so that if you've still got some of the lower pole above the Galaflex, do you ever have that coming forward and the Galaflex kind of holding below that?
Do you know? I don't, but I think that's one of my rationales for not using it on big breast reductions, because I'm sort of slightly worried about that. So I think because they're only mastopexies or small reductions, I don't feel that you're getting that spillover. But I think that's my rationale for not using it for big, and maybe I should use more. Yeah.
Yeah. I mean, I go all the way, but maybe I don't need to go all the way to the nipple. You know. Nice results.
Just a moment.
So I've had one case of, micro extrusion. A lady came back 2 years with like a little non-healing, like a non-healing hole on the vertical scar. and literally under local anaesthetic, just took a tiny little trim, and then that was gone.
I can just add to that. I've had a case of galactorrhea, so a patient who started secreting milk out of her breast and had wind breakdown, and I treated it conservatively. The mesh was visible in the lower pole, and I left it to heal by itself, and it was fine.
Yeah.
Because it integrates so quickly.
Yeah.
And I have nothing to do with Golflex. Good, thank you, Patrick.
No drains, no drains. So unlike ADMs, don't use antibiotics, don't use drainage, don't get red breast syndrome, don't get seromas. So, as I said, I have no use for ADMs in my practice, yeah.
Okay.
Good. Thank you, Patrick.
Okay, Dr. Botti. What to do if the patients ask for smaller implants or permanent explantation?
Okay. Short. Okay, so I'm going to speak about those patients that reaching their 60s, they wish to get rid of their implants. Actually, for many years, our patients have been asking for ever bigger implants, while only recently we have noted the shifting toward smaller sizes. This is certainly due to a new fashion trend, but perhaps also to a better perception of body proportions and harmony. With smaller breasts, the whole body looks slenderer, more elegant, and much easier to dress. Large implants can cause stretching and thinning of breast soft tissues with formation of folding and wrinkling, and this means also breast ptosis, which brings about breast aging acceleration. We also have altered body proportions and difficulties in regular workout with consequent weight gain, and this brings about body distortions. In synthesis, implants bigger than suitable can be responsible for many problems like ptosis, ptosis also of the implant itself due to the force of gravity, soft tissue atrophy, palpability and visibility due to this thinning of the covered tissues, and even postural problems. Along with this trend, implant explantation is becoming an ever more popular procedure. Why? Until a few years ago, the main impetus for patients having breast implant removal was capsular contracture, or leakage and the rupture of the implant. Some women simply wanted to change the size and the shape of the implants. Then in July 2019, Allergan's biosol texture silicone implants were recalled by invitation of the FDA due to the risk of ALCL. It was categorized as a class first recall, the most serious type of recall. According to the FDA, use of these devices may cause serious injuries or death. Of course, this is scaring our patients. Both ALCL and the notorious breast implant illness, the name for a constellation of symptoms that thousands of women have come to attribute to their breast implants, may have contributed to the increased request for breast implant removal. Whereas some women may have health concerns, others may have simply outgrown their implants. What they might have found fitting and enjoyable at 30 may not make them feel at ease at 50. But what are the main issues they raise? Breasts may increase in size with menopause, thus becoming too big. With aging, the weight of the implants may cause back pain. With gravity, heavy breasts may become ptotic. More and more women become sporty at a later stage of their lives, and having a big breast gets cumbersome. Lately, much attention has been brought on a healthier and more natural lifestyle. Therefore, alloplastic materials are no longer trendy. As they mature, women want to be able to feel freer with their bodies, wear what they wish, and avoid too much attention on their breasts. As they age, patients realize in the future they may be too old to undergo any further surgery.
like an implant change. Most of the patients who decide for implant explantation are very happy with their choice. Implant removal represents a relief from having a ticking bomb because sooner or later the implants could deteriorate or cause new problems, as we know. From a surgeon's point of view, there are several issues to take into account when removing breast implants. A few points should always be addressed. Are the soft tissues, and mainly the skin, sufficiently elastic to readapt to the smaller size? Is it necessary to remove some skin with a periareolar vertical L or inverted T scar? Should we remove or just tailor the capsule? Should we consider fat grafting as well? To answer all these questions, we should mainly take two things into consideration: the amount of reduction and soft tissue quality and skin elasticity. On the basis of these factors, we can decide what technique to carry out. About skin removal, yes, of course, in most of these cases, some kind of mastopexy, removal of the skin, excess and lift of the breast, should be performed. We can have three different scenarios. The first is more rare, where you can remove the implants without touching the skin at all because of a very good skin elasticity. The skin redraped in this case without any resection. This is 8 months after the operation. Then the second is just a periareolar mastopexy, and here I totally disagree with Dr. Swanson. There are very good indications for this operation. This lady had an abdominoplasty with implant removal and periareolar pexy 20 years after breast augmentation. As Dr. Berino shows earlier, we can perform this operation with quite good indications when indicated, of course. And then we have an inverted T mastopexy. In this case, for example, she had several complications, and when she came to see us, I just suggested to remove the implants, and she got rid of all these problems. When indicated, we need also an inverted T. Total capsulectomy after implant explantation. A capsulectomy should always be performed if the implants are retroglandular. But even in case of retromuscular implants, it would be preferable to remove the entire capsule. Of course, in this last case, if the capsule is tightly stuck to the ribs and the intercostal muscle ballooning with fluid could be quite helpful, because after ballooning you can really detach the capsule from the ribs with much less risk and much easier. Nevertheless, if it isn't strictly indicated, for example, when there is a suspect of ALCL, one could carry out just a partial capsulectomy on the two sides of the pocket in order to promote adherence and prevent breast drooping. You can even leave a part of the capsule and use it, just tailoring it if a total capsulectomy is not mandatory. Because in this case, the parenchyma sometimes is mainly adipose, and the capsule can be used as a firmer structure to grasp and gather the surrounding tissue and make a mount. About fat grafting, I do believe that this is good help when you remove some volume from inside in order to partially reintegrate this loss of volume. I think really fat can be considered a good choice, but it's very important to inject moderate amounts of fat to avoid compromising blood supply by excessive compression, because this is a common mistake. Unfortunately, there is no one flap-fits-all technique, but we have to figure out the best flaps to recruit the largest possible amount of vascularized tissue and give the breast enough shape, volume, and projection. I wish to show you a case operated by my daughter. This lady was an Arabic princess, actually, had these implants by 20 years. They were retroglandular, and this is the technique we use. This is one side almost at the end of the operation, and this is the flap is a supromedial flap, was already designed, and then she is going to pass through the parenchyma in order to reach the capsule and the implant. And here is where is the implant. She just go and remove it. That's not at all difficult, of course. So you remove the implant. In this case was pretty big, was probably something like 400 milliliters. And of course now the most difficult part is to reconstruct a nice breast. So what she did was to use a technique very similar to the flap I described about 30 years ago, which is the so-called autoprothesis technique, but in this case she used something more similar to the technique by Lycée Ribeiro, leaving the bridge, the dermal bridge along the inframural fold intact, because like this, in these particular cases, you get better blood supply, because of course the Wuringer plexus was already altered by the presence of the implant, so we have to count only on the lower intercostal arteries. This is just sculpturing the autoprosthesis, but as I mentioned, she will leave the dermal bridge intact in order to count on this kind of blood supply. As you know, this technique means that we will use the ptotic soft tissue and we'll bring it upwards, fixing it to the pectoralis muscle. So this is the design of the autoprosthesis. Then she used the popcorn technique in order to get a better adhesion, which means just to touch with the cautery the capsule. In these cases, you can avoid to completely remove the capsule because it will help to get a better fixation, but it's better to do this in order to get a better adhesion of the autoprosthesis. And that done, she will go and lift this autoprosthesis like that, and position a bit medialwards in order to give a good cleavage, and to fix it to the pectoralis, and then to bring the two lateral flaps downwards. Sorry, Professor Santanelli gave me a few minutes more. So
few.
This yes, it is at the end. So this is the fixation of the flap to the pectoralis. I go a little bit faster, and the sculpturing, because you need more projection in the center. And at the end, she also injected some fat in order to give the breast the best shape. Anyway, I cannot show you the photographs of this lady because the Arab Muslim people, they don't want to be photographed after the operation. But this is another interesting case. I removed both the implants. I redid the inverted T mastopexy, and you see that you can get a good outcome anyway, even removing the implants. This is another case by my daughter. Again, 10 years old implants, removal and mastopexy. This is 6 months later. I'm at the end. And this is another case I operated about 25 years ago, because it's not a new problem, of course, and we can still do a good job. Another case of my daughter, and you see that, of course, according to the problem, you use the proper technique. The blood supply was, in this last case, probably reduced by the total capsulectomy, which we now almost always perform in case of macrotexture implants removal for fear of the ALCL. And I thank you for listening. Thanks.
Thank you, Giovanni. Question?
Dr. Botti, I have a question just about your auto-augmentation technique. Are you worried if there's been a previous inframammary crease incision for the breast augmentation? So often the breast augmentation has been put in through, half of that has been incised. Are you worried by that?
No, you know, the incision for breast augmentation, even if it was an inframammary incision, is a very short one. So we have at least the third, the four intercostal arteries which provide enough supply for this flap.
Okay. Questions from the floor?
Giovanni, I have a question. What's the role, in your opinion, of the remaining capsular flap to enhance the volume of the breast with fat grafting? And if there is a role, in your opinion, how much this fat can help you to reach the best symmetry of the two breasts?
Okay, the role of the capsule is not, of course, to give volume, but it's just to keep the fat in the right position in case. But about the fat, as you know, I like very much fat grafting in the breast, but we should just try to avoid to put too much fat, because this will end up with a bad result, with no taking.
Okay, thank you very much. And now, my friend Professor Perrotta, supermedial pedicle in gigantomastia, long-term outcomes.
Okay. Good morning, President, moderators. Thank you to Fabio for the invitation to present, to be here in this very interesting meeting. I'm going to present the experience of my group in large breast reduction with the supermedial pedicle technique. Okay. I'm going to talk about gigantomastia, and I talk about all the cases in which the mammary volume is particularly large, and how important is the recovery as well as morphological and as functional. We all know the cause that can produce a significant increase in breast size. There are many, and sometimes these are also hereditary and even local factors. Many problems arise from particularly bulky breasts, weight on the back, upper limb neuropathies on paresthesia, muscle fatigue, postural problems, dermatitis and skin ulcers. Certainly this condition involves an important discomfort to the patients who suffer from it. In our presentation we included all the patients who presented a pure gigantomastia. That means over 1.5 kilo per breast, and who needed the removal of at least 1.2 kilo of breast tissue. We therefore wanted to consider not only the obtaining of the proportionate size and shape, but also the maintenance of the function of the nipple areolar complex. More, we considered several factors. The risk of loss of the nipple areolar complex due to the excessive length of the pedicle, and its compression after positioning in the superior pedicle technique. The loss of sensitivity of the nipple areolar complex in the thorax technique, and the need itself to preserve this very important function. Many techniques are used to treat gigantomastia, but when the pedicle is too much long, the technique usually used in breast, in large breast reduction is thorax. Technique apparently simpler and faster, but it involves the definitive loss of sensitivity of the nipple areolar complex, which is removed after grafted. So this problem is very, very difficult to the patient to retain. However, we note how important this particular disabling aspect was for the patients, and how it could be necessary to utilize another technique that did not present serious complications, such as necrosis of the neck. I want to stress this aspect because the major part of our patients with this problem, with this large, very large breast, are in a young age. And we also note that, in fact, in younger subjects, or those who had a lively sexual activity, that despite the great advantage of reducing breast volume, the loss of functionality of the nipple areolar complex involved significant discomfort. For this reason, whenever breast size has led us to consider the thorax technique, we have decided to use another technique, the superior medial pedicle technique. We leave totally the technique, the thorax technique. With this technique, with the technique of superior medial pedicle technique, this pedicle carries the neck because then the pedicle rotates in 118 degrees. In this manner, the nipple areal complex do not suffer by the compression of the folding during the reposition of the neck. And in this way, we reduce the complication of the risk of the necrosis, and we preserve the sensibility of the nipple. We use normally this technique in case where the distance between sternal notch and the nipple areal complex was less than 40 centimeters. Now the patient is prepared for the surgery, all is marked, and I show you now some clinical case. As you note, different shape, different skin condition, different nipple areolar complex dimension, but the same problem, risk to lose sensibility of the neck. First case, a 40-year-old patient with 38 centimeter distance from sternal notch and neck, and a reduction over 1.1 kilo per breast. Good size, good long distance shape, a good projection. Another case, 67-year-old patient with 38 centimeters distance from sternal notch and neck, and reduction of 1.2 kilo per breast. Same thing, good size, long distance, good results at long distance, and good projection. Another patient, 67 years old, with 38 centimeters distance from notch to neck, 52 years old, 40 centimeters distance from sternal notch to neck, and a very young patient, 22 years old, with 38 centimeter distance from sternal notch to neck and reduction of 1.2 kilo per breast after scar revision of the neck. Good size, good long distance shape, good projection. Another case, 40-year-old patient with 38 centimeters of pedicle. At the end, a 43-year patient with 38 centimeters distance from sternal notch to neck, good size, good long distance shape, good projection, and lateral aspect. You can note the versatility of this technique in order to the age, size, shape, and consistency of tissue. Post-op. The management of the patient is the same as the others. We remove the compression bandage after 1 week, and we replace a contentive corset. We remove the dressing and stitch after 2 weeks. After follow-up at 1, 2, 3, 6 months, and after 1 year. The same things for the pharmacology post-op, for the same protocol of the other patients. At this point, we made an examination of the results, and we note that the classic complication of hematoma, hypertrophic scars, and seroma remained in percentage the same as in the other techniques. But the most interesting aspect was the absence of necrosis of the neck, and consequently, the sensitivity conservation. This was the point that the reason why, because decided to change the technique, we decided to utilize only this technique. The absence of this type of complication. Anyway, the other complications are the same of the other technique, but with supromedial pedicle technique, we had not the very discomforted complications, the necrosis of the nipple complex. In conclusion, however, the choice of the supromedial pedicle technique had the advantage of preserving the functional integrity of the neck, the stability of the shape and the projection, the maintaining of the sensibility of the neck. All the patients had a significant benefit and improvement in their social and sexual life following mammoplasty reduction in gigantomastia. I know that some techniques are good and depending by the experience of the surgeon. But in my opinion, in any case we think to operate a patient with thorax technique, this is the case to try to change and propose a supermedial technique like first choice technique. This is the reason why I definitively changed my philosophy approach. More, any patient that has complications need to more access to the hospital, more access for medication, for the control post-op, and maybe other operation. So in this way, I think that if we can reduce the complication with only a little change of technique, we can arrive to obtain good results and to allow the cost of the healthcare sanity, public sanity. Thank you very much.
Is there any question? I have a question.
Easy.
What's your experience, the request of the patient for secondary reduction after the use of this technique? And obviously, if you have to do a secondary reduction, you have to know very well what it was done in the first time. And what's your experience in this?
Do you want to say if
how many patients request other operation after the first one?
First step operation, because we do this type of technique in all the patients that has a pedicle overdone 35, 36 centimeters, and it's only one step. If we have the necessity to do another operation, it's only to adjust the scale.
Okay.
Yes.
So
but we had no complications in about the vitality of the neck.
Okay.
Do you use liposuction?
But only in secondary, sometimes only to adjust the superolateral pole of the breast.
Can I ask, why was your cutoff at 40 centimeters? What did you beyond that?
More 40?
Well, I'm just asking how you came up with 40. Why, is that you had a problem beyond that, or you didn't have any problems at all, or?
No, because I stopped. I had not patient with 41, 42, or 43. Maybe that's time.
Okay, so everyone who came, you did superior medial.
Our patient stopped to 40 centimeters, not more.
So no free nipples.
No.
There is some other question. Professor Santanelli wants the audience give more question, please. Another one. Okay.
Hi, I'm Berisha from Kosovo. I wanted to ask you, did you have any case pre-pubertal gigantomastia and do the mastectomy with implant?
With this operation?
Yeah.
With this type of technique?
Yeah.
But not for gigantomastia. No. This is only a point of interest about only gigantomastia. What you want to know, if you utilize this technique in
When you have also the mastectomy, actually, when the pre-pubertal, when you have.
I don't understand, sorry.
When you have the case pre-pubertal, actually, gigantomastia, when the age is very young. And do you do also with implant, actually, or no?
No. No.
Okay. Thank you.
Professor Rubino, here.
Thank you. Excellent.
Ciao.
I share your opinion because I also use supremedial pedicle for all length. I just want to ask you the pattern of skin incision, because I have shifted to the L, JL, and so I wonder whether you use the same or just the T inverted
T.
Okay.
Always, because they are very, very large breasts, and sometimes these breasts are very large implant.
Okay, thank you very much.
Thank
now,
you.
Dr. Harris, you have to change position, and Professor Rubino introduce in some way your speech that is making the wise pattern fit.
Thank you so much, and thank you for the invitation. I'm going to continue with the theme, actually, about just trying to improve things slightly each time for your operation with some small changes. So I think we're all familiar with the WISE pattern, but it's not the best technique in the world, and it's still preferred by many, and I wanted to sort of maybe come back to the differences between pedicle and skin incision. But the WISE pattern is still very useful. It's just sometimes it produces quite a boxy look, and sometimes that lacks projection, and can also not address that axillary fullness. So for many, many patients, the WISE pattern is a sort of ugly result, really, and that's why we've looked for alternatives over time. And I thought I'd put this up for Patrick here because my discussion earlier about the nipple position, because we're appreciating what is a beautiful breast. And, that kind of, we've learned from many different types of patients, but that sort of axillary fullness is really hated by them, and we've addressed it quite a lot in the weight loss patient. They really like that reducing. And in breast reduction patients, we don't seem to address it quite so much. So I've been working hard at trying to sort of look at that, looking at why I'm disappointed with the WISE pattern, and aimed at more projection and reducing lateral fullness. So I've accepted well-placed scars, and I still do some reduced scar techniques, but this is really about looking at the ideal breast, and for me, the nipple does, it's not 45-55, but the nipple does incline slightly upwards on a coned projected breast, and a very clear separation from the chest wall. If you take that pattern and you compare it to the WISE pattern, it's slightly more flared, and that's the F of my fit. So it's a more flared pattern. Like the previous talker, I always do a superomedial pedicle with inferior reduction of technique, and a very thin pedicle, so it's thick at the base and thin, and then that's moved upwards. And then the breasts are closed from lateral to central and from medial to central. So very different to what I used to do as a trainee, and that provides much more projection to the WISE pattern, leaving a significant dog ear, which I then take upwards along the breast. And so it's positioned in that sort of crease, that natural crease, and I accept for scars in that area with some additional liposuction. So here's an operative series of a relatively young patient, and there's the marking. It's essentially a standard WISE, but that flaring lengthens it from 5.5 in my practice to about 6.5. The technique, I've sped some of these up so that we can sit into time. There's the inferior straightforward reduction. It's actually quite quick, and you don't isolate the pedicle, you just take away that inferior tissue. And then you isolate the pedicle by taking away some central kind of tissue. And there's that thinned pedicle on the superomedial aspect. And then this is one of the key elements of it, is this inverted lateral apex. So rather than closing the apex, what I do is I pull that forward into the lower incision, and about 4 or 5 centimeters along. It creates a lateral dog ear, but it's a temporary lateral dog ear. And it pulls in the breast and really defines that lateral border of the breast. And so you don't get that wide breast going around the flank. And these are small changes, but they make a big difference. And I then start to close, as I said, medial to central and lateral to central, meaning that you're taking tension off the T-junction. So by putting the T-junction down first, you're actually closing it under tension. You're doing this last of all, and there's no tension whatsoever at that point, because you've coned your breast. I then address that dog ear, as I mentioned before. There's the lateral dog ear, which is, rather than taken out around the flank, you take almost vertically up the crease of the breast as it intersects with the chest wall. And it does lead to some puckering, because that lower incision is much longer than the upper incision, but that can be cheated in back to your normal scar. And then lateral liposuction, which I'm not showing here. So I said that's the sort of concertina cheated in lateral lower incision. And here she is on the table. And it's a young patient, but that's a 3-month result showing good projection, I think, with well-placed scars. That's perhaps a more typical case of a 55-year-old, again with well-placed scars. And again, showing or trying to maintain good projection, which you don't often get with the WISE pattern. And so just by trying to cone the breast much more and addressing those lateral areas, you can maintain projection as much as possible, I believe. Even with very ptotic breasts and still coning, you can get that projected look to the breasts. The scars, as I said, even in a pigmented skin, the scars don't go out lateral, they go up along the side of the breast. Occasionally in this series, you might need to take one out laterally, but it's very rare to need to do that, and that's when there's an extra fold in that area. And I really work hard on liposuction and resection of that lateral tissue because that's what patients really dislike in the postoperative result. And so this is the kind of, again, just explaining the technique a little more. This is the inferior resection, which is very simple and straightforward. And then that leaves the supromedial pedicle when you remove that lateral central portion there. And it's supposed to be matched with the animation on the top. And it's that sort of very thin pedicle towards the end, but thick at the base. And this is the difference. This is what I used to do, is I used to close the breast like this, which is under tension, and pushes the tissue to the medial and to the lateral aspects of the breast. And so now I bring in that lateral aspect, I create that lateral border of the breast, which cones and projects, leaving that tension-free closure at the T-junction. So you don't run into problems in the same way that we did with the standard WISE pattern. And here what I've done is I've stapled the standard WISE closure on the patient's right. And you can see it's quite boxy and flat and doesn't project, as opposed to just these small changes of addressing the lateral aspect and the type of dog ear, the way you've addressed that, to show a significant difference in the shape of that breast on the table. This is a series of 200 patients intersected with COVID, and I'm doing many more now. Actually, I don't know why COVID has meant that I'm doing many more breast reductions than I used to, but I certainly am. And had no nipple necroses. This is all supromedial, like the previous speaker. Some minor wound problems, but much fewer than I had before because the T-junction is not such a big issue. Remember, this is 202 patients, with very few dog ears for revision afterwards. And these are the examples, low BMI patient, and I've used it for low BMI, for a modest BMI patients, and going through the ranges, modest patients with good projection afterwards, well-placed scars, I believe. I think that we work quite hard on scars. We talk a lot about scars, but if they are well-placed, then they're hidden, and they don't bother patients so much. Even with the larger breast reduction now, higher BMI. Again, the elements are the flared pattern, so I flare the bottom of that vertical incision, that's the F. I invert the lateral apex, that's the I, and then tension relieving sutures, so you close from outside inwards for the breast. To give a reliable reduction in this group. And of course, we do a lot of breast reductions, and it needs to be reliable so that we don't have so many revisions in practice. And even through the higher BMI patients, it's a reliable technique. Even up to this patient with symastia, and that's an 18-month result, 18-month post-op result showing that the scars do settle very well. I don't have a cutoff for BMIs. I caution patients, of course, above 32, but if it's realistic for them, then I'm happy if they take the risks of the increased wound healing problems. And in this series, I've not used a free nipple graft either, which was why the question in the last talk, and I've not lost the nipple in any of these, and certainly it's been up to in the high 30s. I've done it in young patients and old patients, and it's been very reliable in producing a projected result. So these are just, kind of small gains in several areas for the WISE pattern, which I think we can employ in lots of parts of our practices. As Patrick Minucci showed before, I've used it with dissolvable mesh. I like dissolvable mesh in the small breast reduction. That's a 12-month result with the same Galaflex mesh, and that's an almost 3-year result with the Galaflex, showing good projection and maintenance. I've done it in secondary breast reduction, significant breast reduction for this patient who's also had some weight loss, and also with some lateral fullness. Again, this is a patient who had a previous breast reduction and the lateral fullness was not addressed. And I've even done it in secondary breast reductions with additional mesh in this Ehlers-Danlos patient who's got significant laxity. So I've been able to elevate this reduced breast in this case. So for me, I've just called it the fit pattern, but it's really helped my practice significantly. It's become the reliable workhorse in my practice for breast reduction. I found the traditional breast reduction techniques produced pretty ugly results. Maybe it was just me who was doing it, but I think it was a combination of an inferior pedicle and the way that the WISE pattern was closed and designed. And I think with these small tweaks, you can make some significant improvements. It's the flared pattern of coming outwards to give more coning, inverted lateral apex to really define that lateral border of the breast and reduce the fullness in that area, and then detensioning towards the T junction with closing that very last of all. I think I haven't been able to prove it, of course. as in plastic surgery, it's also a lot retrospective and looking at our own series, but it's better shape at the expense of longer scars, and I acknowledge that, and I still do some short scar techniques, but I think in the WISE pattern this is the best way that I can achieve. And I've got a relatively low revision rate, and I think it can be used in secondary cases and also with some mesh. Thank you so much.
Congratulations. Beautiful cases. Any question?
First one.
Okay.
And I've got the questions to Zlatko from Zagreb. Dr. Harris, I would like to comment, if I may. Supermedial technical WISE pattern. We evaluated from the technique like that. You cut the lower apoptotic part of the breast, and you close the breast tissue, glandular tissue, and anyway, and you've got a flat and wide breast always. And supermedial pedicle means no sensation of the nipple. That's the, let's say, first generation of the breast reduction, according to only skin, suspension. And we evaluated to the second generation after the Claude Lassus and Marlène Lejour. Of course, if you resect the central part of the breast, you can get the projection of the breast. And after that, the problem was how to derotate the breast. And we came to the third generation, like lateral septum-based Hamdi technique. It means how to derotate the lower lateral quadrant of the breast into the upper medial quadrant of the breast to derotate and to do the vertical resection. And what's your opinion about that, to use still the first generation of the breast reduction technique?
Well, I think, I don't think it's the first generation. I think it's an adjusted generation, with all respect. I think that, as Eric Swanson showed before, with the anything inferior really comes back down again. And I have tried lots and lots of different techniques based on inferior tissue. And in my books, no matter how many stitches you use, no matter how many types of pedicles, even with the mesh, I'm not able to keep it up longer term. And I think you must preserve the upper pole tissue, and therefore you've got the upper pole tissue there. Why disrupt it? Why move it? Many patients like their upper pole. You're just simply coning the breast a little bit more, and it doesn't have a tendency to come down. So in my practice, honestly, I tried the shorter scar techniques, I tried inferior pedicle techniques, and I ended up doing lots of revisions. And in private practice, you've got to reduce your revision rate. And this clearly, in my hands, reduces my revision rates as essentially zero, apart from a few dog ears, which are really very, very few and more medial than lateral, to be honest. So I think in terms of consistency of results, I think this provides for me. Now, I know that there are other techniques out there which you can, in certain patient groups, get much better results, and I completely acknowledge that. But in terms of consistency for the majority of breast reductions, I think this provides the answer for me.
And you don't use hearing septum at all?
No.
Dr. Harris, I think you may have answered my question, but your technique is starting to look like a vertical. I mean, you use a superior medial pedicle, and then you cinch those pillars together. I wonder, have you considered doing a vertical ellipse and then just simply doing away with the dog ear at the bottom, thereby limiting your inferior scar so it doesn't appear on the sides?
Well, you can get where I started from, okay?
Yes.
That's exactly where I started from in all of this. I used to work with a Swedish surgeon in London, and that was his technique. And I took that on from when I first became a consultant, and that was my starting point. But going back here, my revision rate for that vertical scar was very high. So in order to eliminate the revision rate of that vertical scar, I then introduced those short horizontal. And so actually it's evolved to this from starting from that position. But you're absolutely right about the pattern for the vertical and the glandular pattern, because I think it's the glandular pattern which helps this shape, actually. You're right.
Saçak, Istanbul, thank you. Very good results. When you suture the horizontal line, do you take a bite from the thoracic wall? Do you think it can improve the stability of the lower pole? Thank you.
I don't, to be honest. No, I don't. But I do use, in patients that I'm concerned about in the smaller breast reduction, that I want to really maintain that position, I will use some dissolving mesh, as I mentioned. So I will stabilize that in some patients. But I tend to not use anything to the thoracic chest wall.
Paolini from Rome, congratulations for your technique.
In my hand, I would be concerned about the length of the vertical scar, because it looks to me quite long. If we think that regularly it's 4.5 centimeters, the Weiss pattern. So I'm asking you, when do you put the mesh to keep the lower pole from bulging over time?
Well, I think you get less bottoming out because it's not an inferior pedicle, so you get less stretch of the lower pole post-operatively, because I think this is actually, all of these questions are linked in that the technique comes together in that way. Because it's superior tissue, you don't get the bottoming out in the same way. I think that, I'm taking others, who's already spoken, that slightly elevated nipple position, looking inclined upwards, is actually the modern aesthetic. That's what patients really want at the moment. They don't want it low down. And whenever we discuss photographs of patients in the office, none of them like that lower nipple, even though we don't want to go too high. And of course, I don't want to go too high. But I think when I first started, it was 5, 6. Now it's down to 6.5, and it's getting close to 7. And patients like that look.
Do you use the cautery to sculpt and to model the nipple areola bearing?
Actually, no, I don't. I use the knife. I think that it's quite a quick technique, and also, in order to get the sort of spatial awareness of the whole thing, you need to be able to do it quite quickly. And if you're doing the cautery, it's a little bit slow, and you lose your orientation, your three-dimensional orientation. So you need to keep moving the tissues around.
It could be also problematic, especially in very long pedicle bearing
take some time.
The nipple complex.
Do you give any importance to the quality of the breast glandular or fat breasts in the skill of the technique?
That's a very good question, because I think that the short supromedial pedicle in the glandular breast is a real tough one, and I've been caught out by that because it really won't turn. And the fatty breast, the supromedial will turn very, very easily, whereas in the glandular breast it's stiff and it doesn't move in the same way.
Very rigid.
Very rigid. And in those patients, I cut my talk short to make it for the 11 minutes, but in a series, a younger patient group with glandular breasts, I use mostly a superior stroke glandular pedicle for those patients.
And is important for you the base of the breast in the skill of the technique?
The narrowing of the base is what's important, what is key to this, because what patients hate is that really broad, fat breast which sticks out to the side. And that's key to all of this. So I'm really working hard to change the footprint so that it narrows as much as possible. I'm glad my talk has stimulated a lot of questions. This is really good. As being chair of this session.
Okay. Thank you very much, everyone. Professor Santanelli.
Thank you very much. And now we have a coffee break, half an hour, and then we get back in half an hour sharp. So it's something like 10 minutes to 4. Past 25.
Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company.
Oh, okay. It's fine with me.
Gliel'hanno detto che c'è adesso prima dottor Botti. Allora lo dice a lei, magari che sa tutto.
Not here,
lo dice
right?
lei
Okay,
perché...
okay, okay. Dr. Diamond, instead of Faradi.
Okay.
And then Piassi and Munhoz and Lennox, they are all video. They're not here.
Oh.
They are disconnected.
Passo, Munhoz, I know he's not. And Harris is not here either. No,
Sì.
Yeah, yes, Dr. Strado.
Conoscenski. Ok. No, cervelli no. Ah, ok. Vabbè, tanto io sto qua a fare da guardiano. Fanno tutto loro.
not going there.
So we can start. I give the microphone to the moderators.
Okay, thank you, Dr. Berino, and hello everybody, and welcome back after the coffee break. And we are going to start with Dr. Botti. Please come. He will show us a video, and then we will go on with the regular program. Thank you, Dr. Botti.
You're welcome. Professor Santanelli asked me to show you something different, new, but it's hard in this field to find something really new. So I thought that you could have a look to this video. I recorded it about 3 months ago during our meeting at Lei Garda, and it is related to the use of a new device, which is the Ergonomics 2. It's a totally new implant. Very interesting. So I wish to show you this video. Can you go with the video, please? Thank you. So this is the case. She was pretty skinny with a lot of stretch marks. A good indication for a transaxillary breast augmentation because the breast was height on the chest wall. So this is my favorite approach anyway, and this was the choice with this new device. So first I mark the midline, then the inframammary fold. In this case, the inferior pole of the breast was pretty short, so I decided to lower it a bit because she wanted to have a 275 milliliters implant, which means about 11 centimeters diameter, and so we need at least 5.5, but better 6 centimeters from the inferior lower border. And so this is how I am going to lower the inframammary fold. They were a bit asymmetric, so I will lower it a little bit more on the left side, as you see here, 1 centimeter on the right and 1.5 on the left. And then how to find where to position the axillary incision is easy. The anterior and the posterior axillary line. In between there is space, but you should leave at least 1 centimeter per side. But with these particular devices, we need just a 3.5 centimeters incision, and this means that we can go just deep into the armpit and have a totally hidden scar after that. So this is where I will make my incision, and this is how I will reach the new inframammary fold with the appropriate instrument. I first mark one side, and then, of course, the other with the same circumstances. I mean, I go in between the two anterior and the posterior axillary line. So this is the marking in a fold, in a wrinkle, let's say. And this is the operation. So start with some local anesthesia. In this case, there was also a pectus excavatum, so I put some fat in order just to not to correct it, because you can correct it only with an implant, but just to improve the situation. So we are injecting fat in exactly on the sternum where there is the concavity. And we used 3 different approaches in order to crisscross and better distribute the fat in this particular area. Then, after this first part of the operation has been concluded, I will start with the breast augmentation. So first of all, the incision, exactly where I mark the skin. Then I insert a scissor. I don't use the endoscope. I try it for a couple of years, but to me it's really not necessary to use it. So I start my dissection with my finger. Then I take a dissector and I go deep, and I release the pectoralis from the ribs, and I try to reach the new inframural fold. As you see, there is a special movement, but it's so easy to do that everybody can do this operation. And I suggest to young surgeons to learn to do this operation, because it's something different. Not everybody does this, and the patients, they like very much to have a breast without any scar at all, because in this case the scar is totally invisible. So you first try to prepare an appropriate pocket for your implant. As you see, I totally release the insertions of the pectoralis from the ribs and a bit in the lower part of the sternum. And then, when I feel that the pocket is not bad, I take an expander. This is a new expander. Also, this is a new device from Motiva. And with this kind of pump, you just fill it with air, and you start to see the effect, because yes, we have chosen with the patient the 275 milliliter implant, but then we have to see if the effect is right. Then I see that here I didn't release enough the pectoralis, so I go back, I remove the expander, and with this Dingman underminer dissector, I complete the dissection where it was not enough. So I go, and with just this kind of elevation of the flap, I try to get the best and the most regular pocket. At this point, I inject some long-acting local anesthesia. Is Chirocaine, is bupivacaine, Levogir, and it lasts for something like 10 hours, so the patient will not feel pain in the first period after the operation. I block the intercostal nerves, like that is very easy to do, and I suggest also this can be included in your surgery, because it's very important the patient has a good experience with this operation. Then I reinsert my expander, and I check if the pocket is right, and in case I go again with the dissector if it is not correct, but in this case it was okay. All this takes no more than half an hour, I mean the complete operation. At this point, when you are sure that the pocket is correct, you take a color funnel, you remove the paper inside, you cut the extremity, and you insert the implant without even touching it, and then you put the tip of the funnel inside the incision, and you push the implant inside. Then with your finger you push it a bit more, but just a bit, and from outside you just place the implant in the right position. And then you do the same on the other side. So again, the implant in the color funnel, and then you just put it inside your pocket. And the operation is done with the suture, obviously. So I repeat, it's a very straightforward approach. I stopped using the endoscope because it takes more time to me without any reason, because I get exactly the same outcomes with or without the endoscope. This is the movement of the dissector I need to do in order to lower the inflammatory fold. Of course, you have to choose the right case for this kind of operation. You can do that in 90% of the cases, but it's hard when you have a tuberous breast or a very, very short inferior pole, or if you have a secondary case where you need a capsulectomy. This can be done with the endoscope, but it's a lot of work, and I prefer probably a periareolar incision in order to remove the capsule. But anyway, in the other 90% of the cases, this can be done with very good results, exactly the same as with any other approach. This is 1 month after the operation, because this was done in July. I repeat in July this year at our course. Professor Pietro Berino was with us, and probably some of you. And this is the outcome 1 month later. And you see these implants are really very good, because they have the right consistency, but they can shift through a very small incision. That's all. Thank you very much.
Do we have any questions for Dr. Botti? Yes.
Never need to put drainage, never need to do hemostasis?
No, because this approach is really magic for that. Probably when you go with the dissector, the vessels shrink and they don't bleed. I have been using that for almost 40 years now. Never drainage, never hematoma. So far, that's good.
I have a question. I think you may have answered it. If you have to reoperate, did you say you use a periareolar approach, or do you sometimes reuse your transaxillary incision?
Okay, if it's just to change the implant without any capsular contracture, I go transaxillary. But if I have to remove a complete capsule, it's too hard to me. I cannot.
Another question there. Dr. Harris.
Thank you, Dr. Botti. I think if you look at breast augmentation over the last maybe 20 or 30 years, the biggest advance has been in surgical technique, I think we'd agree. And some of that has been brought up in the 14-point plan. Are we just abandoning the 14-point plan now?
Okay, my friend Bill Adams pretend that only the inflammatory approach is the magic one who doesn't give any particular problem. It's not true, at least in my experience. In my clinic, we do, let's say, transaxillary approach about 10-15% of the cases, but for one reason, because when patients come and ask for breast augmentation and I propose to pass through the axilla, they say, no, I don't want, because I know it is much more painful, much more risky, which is not at all. This is because many surgeons, they cannot do that, even if it is so easy, and so they say on the internet, on the television, oh, don't do that because it's risky, you get capsular contracture. It's not true. To tell the truth, I never had any capsular contracture with this approach, but I had, as everybody, many through the inflammatory approach. So it depends by experience. Bill did a good work, but to me was a bit influenced by somebody to arrive to those conclusions. I have a huge experience, many thousands of implants, and to tell the truth, I don't see any difference, any real concrete difference between the three approaches. That is my opinion.
May I ask you also a question?
Sure.
Do you think this is the best approach also for anatomical implants?
Yes, you can use anatomical implants. I have been using for at least 20 years, since from 1992 till 2012-13, and there is some more difficulties because you have to put them straight, and sometimes it's hard, even if you can palpate the implant, because the markings generally are in the lower pole. To put the anatomical implants, it's better to use the endoscope, to tell the truth.
Okay. I'm sorry, I think. Okay, one more question very quickly, because we have to move forward.
notice some stria at the end. Its stria can be a problem after you expand the skin too much?
No, this patient was full of stretch marks before the operation. This was one of the reasons she wanted to feel the breast.
Okay, thank you, Dr. Botti. And we can go on with the next presentation. Dr. Kolasinski, I'm sorry. Relevance of chest wall asymmetries for selection of best implant. Thank you.
Good afternoon. First of all, I would like to thank Professor Santanelli and Professor Clemens for inviting me for the interesting conference. Nothing to disclose. We know that the breast surgery is very popular, and now more than 3 million procedures done in the world. So when we look on this patient, we say, okay, it's an ordinary patient. But when we look carefully, we find the depression of the sternal notch, protrusion of the upper pole of the chest, protrusion of the costal margin. So I think there is not a really simple patient, and we cannot solve his problem with very easy technique and different width. So I think the surgeon should respect the rules of geometry as well, because chest asymmetry have a significant influence on the effect of breast correction surgery. Although much is written concerning breast augmentation, only few authors focus on the shape of the chest and how it affects the final result of corrective surgery. So far, no, I don't find any comprehensive classification in the literature of the shape of the chest wall. So the aim of our study is to present our own classification of the chest shape based on the 3 basic plates and how it affects the implant selection. The material, 1,000 patients, evaluated from 2013 and 2019, and we use 2 tools, a Vectra and Mirror, Canfield, but I have no interest, financial interest, and relationships between measured parameters were calculated using the chi-square person test. The coronal plane allows to assess the proportion of the chest width and shoulder height. Therefore, this classification we divide into 2 sub-classifications, CC and CS. And in the first CC, we measure the width of the chest wall, and we compare the left to the right side. And we calculate the CC0 if it's almost equal. If the right side is bigger than a left, it's CC1, and if the left is bigger than right, it's CC2. CS classification, again, the horizontal line on the level of the axilla and 2 vertical lines. And if they are almost equal, so it is CS0. If the right side is higher than the left side, it's CS1. And if the left is higher than right, it's CS2. The sagittal plane is more complicated. And we draw the several lines, and line horizontal A and B, and line C. And 3 measurements were calculated: A distance between the most convex point of the chest and oblique line, B distance between the oblique line and vertical line, and C, the distance between the most convex point of the costal arch and the vertical line. And the proportion are measured. So we classify this as like 0 if the A is 33% and B is 67%, or A plus B is equal half of C. So if the A is bigger than 33%, in this case it's 55%, is S1. If C is much bigger than A plus B, we classify it like C2. And the horizontal, quickly, is maybe easy, but there are several lines. Maybe I don't explain exactly because there's no time, but finally we calculate the projection of the right side and the left side of the chest. And if they are equal, we call it H0. If the right side is the more than left, it means that the right side is more than left, we call it H1, and in the opposite result, we call it H2. So what results are of our study? So they were classified 923 patients in coronal plate, 920 in sagittal plane, and 627 in horizontal plane. Other patients were excluded from the study due to the insufficient quality of the images. And when we measure in CC classification, what is important, as many as 34% of women have chest width asymmetry. In shoulder height, we find that almost 43% of women have shoulder higher asymmetry, more on the left side, less on the right side. And we find that there was a relationship between the asymmetry of the shoulder height and chest width conferred by chi-square person test. So it means that if the shoulder is higher, greater chest width on the same side is expected. Chest asymmetry according to the projection, we found that more than 84% as S1. So they have more projected our pole. Upper pole. 28% has more projected the sternal arch. So, and if we look at the projection and we compare in the scale, we found that 84% of the patient has asymmetry in chest projection. So it is a lot. And what is the final practice advice coming from this study? That, for example, if we have the patient with different chest width, and we use I have the pointer here, this is the pointer. If we use the same width of the implant, finally, we have the biggest projection of the side where the chest was more narrow, and the patient will see it. So we put the two equal width of the implants, and they find that the breast is more projected. So we have to use, if we want to have the same projection, and this is very, very often patients look down and see the projections of the breast. We have to choose the different width of the implants, and finally we have the same or similar projection. If we look at the height of the shoulders, again, if we use the equal or round implants, round base implants, we can have a asymmetry of the cleavage. So we can use a different height of the implant, or for example, it's a safe method to use the implant, anatomical implants with oval base. So the asymmetry of cleavage will be not visible. Please consider it. And the most often the projection of the upper chest. Again, if we use the round implant, sometimes we have over-projected upper pole, and even we change the direction of the nipple down. So it's much better to use a low height implant. I think, of course, anatomical, because we have no round implant with oval base. So I think it is better solution and avoid this problem, finally. And if we look at, of course, it is obvious if we have different projection of the chest in horizontal plane, yes, and if we use the implants on the same projection, we have finally the different projection of the breast. So we have to use the implants of different projection to correct this problem. So there are some examples. Oh, I'm sorry, I can go back. Okay, so the patient with different width, and we use the implants to correct this patient, the implants with different width. So finally, it looks quite good. Of course, I have chosen the difficult cases, not easy, which we publish every day on the Facebook. Yeah. The same, if we have a different height of the shoulders, yes, it is better corrected, but anatomical implant with different height. And finally, it looks quite good. And if we have the protrusion or more projection of our upper chest, again, it's better to use the implant with low, high, and with, okay, I am coming to conclusion, and we don't have over-projected the upper pole. And this is when we look horizontally to the different projection of the chest. In simulation, I use the same implants, and we see the different projection in final results. So it's much better to use the different projection. So of course, on the left side, the implant of the high projection, and finally, it looks quite good. And this is sometimes we have the patient with pectus excavatum, and there are a lot of problems, and we have to solve them with the implants, and I suggest anatomical implants in different width, with a projection, with a different height. So in conclusion, the vast majority of women had natural asymmetry of the chest wall. And for sure, everybody of us told the patient during the first consultation that asymmetry is close connected to the human nature. 34% of women have chest with asymmetry. 43% of women have shoulder height asymmetry. 84% of women have excessive projection of the upper chest. 28% of women had excessive projection of the lower chest. And 84% of women have a chest projection asymmetry. So there's a significantly confirmed relationships between the asymmetry of the shoulder height and chest width. So I think this classification allows to systematize the chest shape assessment, and the chest shape has a huge impact of the individual selection of breast implant. Thank you very much for your attention.
Do we have any questions for Dr. Kolaczynski? Well, I've got a question. I applaud your use of measurements. It's great. Your coronal view, I wondered if a few of the patients were just standing with one shoulder higher than the other. How do you rule that out? Or a patient maybe with scoliosis that might be, tilted a little bit, but it's not from the chest, from a chest wall deformity.
Of course, it looks like she stayed like this, but I asked her stay when I start the photo session, and this is her natural position, and of course, always there's the spine, there's asymmetry, and for sure there's not specially done by only for this study.
I thought you might have been using the Canfield system.
Yeah.
Do you match the photographs so that would help deal with that problem, so that they're in the same position, with regard to any skin markings or anything, to make sure that the chest position is similar?
Of course, it's a good idea. I don't do it, yes, but of course, the distance, even I don't have the line on the floor, but I have the same movement. Put the patient and go back and use the camera. So probably is one step, yes. But of course, it's a good suggestion to mark them. Fortunately, later, when I make the measurement, it doesn't matter if on the one side is 3, in Canfield there are different numbers. There's not exactly centimeters, there are no inches. There's some, I don't understand sometimes the measurements exactly. But I always compare one side to the other side, so that's why.
Okay. Any other questions?
No more questions. Thank you, Dr. Kolaczynski. And now we have, unfortunately, speakers are not here, and I'm afraid they're not going to be connected with us, but they send the videos, so perhaps we can see the video, and then if there are any questions, we can discuss at the end of the 2 presentations, otherwise we can.
Hello everybody, ciao ragazzi. My name is James McDermott. I'm a plastic surgeon based in the southwest UK. I've been invited to speak by GC Aesthetics, for whom I am a key opinion leader. I'd like to talk to you about the evolution of my breast implant practice over the last 21 years. So I'm a KOL for GC Aesthetics. I'm the owner of Wood Medispa, a private hospital in Oakhampton in Devon, and I also own 2 wood clinics in Plymouth, Cheltenham. My practice started back in 2000, and I set up an independent consulting room and minor ops clinic in the Tamar Science Park in Plymouth, because none of the private hospitals seemed to be tuned in to the big changes that were happening in non-surgical aesthetics, and I wanted to be able to exploit the Botox and filler boom. 2005 I opened a second clinic in Cheltenham in one of the Regency Squares there, and I kept this clinic till 2019. 2008 I got this crazy idea that restoring a derelict country house in the beautiful Dartmoor countryside would be a good idea, and I thought to myself, how hard can it be to put a state-of-the-art private hospital into a gorgeous listed building? And it took a long time, so the answer is quite hard. But we opened this practice earlier this year, and I want to talk to you about some of the decisions that I've made along the way and what's influenced me. This is our operating theatre at Wood, where I spend 3 days of every week now, and it really is my dream that's come true. So what I'm doing in terms of the of preventing implant infection and capsular contracture, we're using the hydrocone, we're using antibiotic prep on the implants, vancomycin, gentamicin, povidone iodine, no-touch technique, and then closing the wound immediately after implant insertion. We're also doing quite a lot of fat transfer, and this is something that I'm doing at the same time as breast augmentation and also separately. So my training was in Canisburn Hospital in Glasgow with some really great names: Martin Webster, Eva Weiler-Mithoff, great breast reconstruction surgeons. We were doing DIEP flaps there in the 1990s. Mustafa Hamdi was a colleague of mine as a trainee, and I also worked in Louisville, Kentucky with Harold Kleinert. My background is reconstructive microsurgery. As a trainee in Glasgow, the Cumbernauld GC Aesthetics factory was literally down the road, and I visited the factory on a couple of occasions, and the implant of choice then in aesthetic practice for my consultants, my bosses, was the Nagor GFX implant, which was kind of an underfilled, floppy, soft bag of silicone. In breast reconstruction, we were using quite a few Mentor Becker expander prostheses, which also had their own problems. Most of what I saw was subglandular augmentation. Most of the Beckers were being put in submuscularly through a muscle split. In 2000, I was appointed a new consultant at Derriford Hospital in Plymouth. I took over an existing private practice, and the person whose practice I took over had booked lots of patients for Perthes round microtextured implants, which actually turned out to be a pretty good choice. I saw very few problems, very few encapsulations with these. In the health service, we were buying Mentor implants, both round and contour profile gel anatomical implants with a Siltex coating, but I saw a lot of rotations with these. In 2004, the Tebbets and Maxwell McGann style 410 Inamed, Allergan, whatever you want to call it, roadshow was in full swing, and I was indoctrinated into or introduced to the biodimensional matrix at a meeting at the Academic Clinic in Stockholm, Per Hayden's clinic. The BioCell seemed a very luxurious texturing for the implant surface. The matrix was fantastic in terms of choice of anatomical implant, and I still, to this day, I don't think it's been superseded. The other thing that was being pushed at that time was the dual plane, and when I came back from Sweden, I think I was overusing this approach, and I produced some contour problems because it's definitely not the pocket of choice for primary augmentation, in my opinion. It has a role in patients who don't have much soft tissue coverage, but it's the pocket of necessity, in my opinion, not the pocket of choice. The bullets I dodged through this time were the PIP implant crisis. I arrived as a surgeon after this had finished. Hydrocolloid implants and also triglyceride had all finished. Through working with a company called MyBreast in the UK, I initially was using Allergan implants, but they switched to Nagor, much to my annoyance, because I was very familiar with the Allergan implants. It's like learning a new language. But eventually I switched to the Impleo and Kojo range and really started to like these implants. In 2009, the polyurethane implants were reintroduced to the UK, And quite a few colleagues started to use these regularly, thinking that they would never see a capsular contracture again. However, everybody who started using these for 100% of cases, all the primary cases, only did this for a while because there was a very high early reoperation rate because of implant malposition. They sit very high, there's a very steep learning curve. And in my practice, I still use these, but they're special use only for symastias, for over-dissected pockets, for patients with recalcitrant repeated capsular contractures, but they're not the primary implant of choice. In 2011, panic stations hit with ALCL. And what we know about ALCL, it has an unclear etiology, most often associated with textured implant surfaces, most of which were Allergan biocell surfaces. But wouldn't it be a disaster if textured implants were banned, as has unfortunately happened in France? We'd see a massively increased capsular contracture rate and a huge increased reoperation rate and all of the associated risks. So this work by Stefan Danila breaks down the risk-benefit analysis of a ban on textured implants into pretty straightforward terms. And he looks at the sort of macroscopic Freakonomics big number picture of the consequences of a ban. So for 100,000 breast augmentations undertaken with smooth implants, you would prevent 7.9 cases of ALCL. You would cause 23,152 reoperations and cause 0.12 additional deaths. You wouldn't be saving lives, you'd actually be putting people at risk if you factor in a mortality of 1 in 50,000 per general anesthetic. You would basically see 1 extra death per 50 cases of ALCL prevented, an $18.5 million cost for every case of ALCL prevented. So I don't think this is a good idea. I think removing textured implants removes choice, removes anatomical implants, and it would be an absolute disaster. So micro or nanotextured implants, you know, if you classify this by pore size, things like the Nagel Pearl, I think are okay for smaller implants, but I prefer macrotextured implants for larger devices. Microtextured implants or smooth implants stretch the pocket, cause malposition, bottoming out, and rotation. And this is a rotating. That was a rotating Belite implant. My current practice is mostly GCA products, Nagel Impleo, Cogel. I use some pearls for smaller implants, and I use urosilicone because they have a wider size range. Very low profile urosilicone implants enter my practice. I like Belite implants for people that want very large devices, and I also use Polytech for the reasons I said earlier. I really like the Canfield system. I use a Vectra H2. It's great for communication and planning surgery. It allows detailed analysis with the patient sitting next to you. You can discuss their existing breast volume, chest shape. You can add implants, and you can show them the difference of round versus anatomical. I really like inflatable sizes as well for making the final decision on implant size during surgery. I think it's essential for asymmetries and also for simultaneous mastopexy aug. We CO test. We do breath carbon monoxide testing on all breast reduction and mastopexy cases because patients don't always tell us the truth. And there's nothing worse than having to fix a complication that is not your fault. And this just removes these patients from the equation. If in doubt, cancel. We're doing a lot of fat transfer, as I said. We use the lipofilter system from MicroAir and inject with a 2.1 millimeter Caraway fat harvesting cannula. Ultrasound, I think, has arrived, and as plastic surgeons we can measure the thickness of the upper pole breast coverage with ultrasound very precisely. We can also look at the integrity of the implant shell. On the left is an intact implant shell, on the right we have the stair-step sign of a ruptured implant. Also, in the case of ALCL, you can analyze the pocket, you can aspirate fluid and send it off for CD30 analysis. I'm not saying that we should stand in the place of a radiologist. However, we can get an earlier diagnosis or at least reassure our patients with these. GC Aesthetics have been making breast implants for almost 50 years, 3 million breast implants, lots and lots of clinical data. They're the only UK-based implant manufacturer. And they have a very wide range of implants with different surfaces, different shapes and sizes, as well as tissue expanders. The Impleo is, I think, the softest implant on the market. It has an extremely soft gel, extremely cohesive. I'd recommend that you go and sample some of these implants at the GC Aesthetics booth. They also have a fantastic warranty, so any implant affected by capsular contracture or rupture will be replaced. There's also an ALCL warranty in there as well. Cohesivity is great.
Smooth implants were causing more capsular contractures, more reoperations, even more deaths. But I wrote a letter with Dr. Hall Finley on this point in ASJ. They got the math wrong. They duplicated some data from one study that was included in another study. They mixed up number of breasts with number of patients. So the basis for the calculations, which were very difficult to understand, but the very basis was flawed. And I think to say that we should move, that it's been unfortunate to move from from texture to smooth is just wrong. I've used smooth exclusively for 20 years, and a lot of surgeons in the United States have used smooth for a long time. We haven't seen a massive increase in capsular contracture. So I just have to take issue with that comment.
Well, I believe the issue is I don't want to start a discussion on this topic because otherwise it will be very long. The problem is to understand what we mean by smooth, because Motiva and Pearl are described as smooth. They are not. They are very similar to smooth surface, but probably Fabio will tell us something much more precise tomorrow. So I think it's better to go on with the program. Yeah.
And so we have a next presentation, another video, and this is from Dr. Piassi, I think. Augmentation, mastoplasty, what has changed?
I'd like to thank you for this invitation. I talk about today about algorithm for best performance in augmentation mastoplasty. Last year, from the ESPS statistics, the top 5 cosmetic plastic surgery procedure. Who is the first one? The first one is breast augmentation. 300,000 surgeries per year in the United States. We need to have the concern and care with thought-related procedures. We have to be careful about this. 4 steps to success in breast augmentation. Education, preoperative consultation, preoperative planning, surgical technique, and post-operative care. Education preoperative, I think that it's time you have to discuss about BIA-ALCL, BII, the size of the implants, a lot of things about implants. You have to avoid, in this time, about avoiding large implants. It's very important, this. Large implants, a lot of problems. Preoperative plans. We know today, every patient has the implants they need. Every patient have the implants they need. Surgical techniques and post-operative care. We know that a follow-up, a long-term follow-up give for us a less work. I'm sure that. What about access? We have three: axillary, inframammary, and areolar. Just this. The other ones is folk. Let's see the algorithm. Defined fold, poor defined fold, and high fold. PEC. Papillary areolar complex. PEC less 3 centimeters. We go to inframammary fold. PEC more than 3 centimeters. With Pexy, Peri-PEC. Without PECs, Peri-PEC or inframammary fold. Poor defined fold, tuberous breast, Peri-PEC. PEC less 3 centimeters, axillary. PEC more than 3 centimeters, Peri-PEC again. The high fold, PEC more than 3 centimeters, I use Peri-PEC. PEC less than 3 centimeters, I go to inframammary fold, it's not so easy, or axillary. I don't like axillary here, but axillary is a good. Let's see this patient. This patient that are defined fold and PEC less 3 centimeters. Let's see the algorithm here. Defined fold, PEC less than 2 centimeters, and we go to inframammary fold. Okay, let's see. This is the pre and post. Here you can see the results in front of you and see the profile view. This is another patient. Let's see the PEC. The PEC more than 3 centimeters. There is a defined fold. And let's see here in our algorithm, defined folds, PEC more than 3, without and no Pexy, you can choose Peri-PEC or inframammary folds. We choose Peri-PEC. We talk about our patients, about this, what do you prefer. Let's see here, this is the results. Here is in oblique view and the profile view. Poor defined fold, PEC less than 3 centimeters, X-ray. It's the only formal indication for me of X-ray access in our algorithm. I like axillary access, but sometimes I prefer inframammary folds or Peri-PEC. Let's see here, it's very important. We do this 3.5 incision in the axillary side. It's very important. This start this. Here, the section undermined here is superficially undermined until the border of the pectoral muscle and start the section of the store to preserve, to avoid the damage of lymph nodes here. This is the end of the surgery. You can see, for Nahai, there is an important authors say that for me, the best access for our patients is inframammary fold. I agree with them. I like inframammary fold when I can do this. Position of implants. More use to less use. Subglandular, subfacial. I just use subglandular and subfacial. Just this. Submuscular and duoplane sometimes, but I say for you what I think about these stores. Subglandular is the section, more predictable results, very counter and great naturalist. Subfacial, the section more difficult, more laborious than the subglandular plane, the thicker coverage of the upper pole. The lower pole, sometimes I never see this facial. I never see this facial, but in the upper pole, yes, it's a thicker than the lower pole. But it's okay. I don't like subfacial, but a lot of people that I know use this store. Submuscular, a long time ago, I never used this. VSP stores and oncological indication. Duoplane, type 1, type 2, and type 3. Type 1 is the classical submuscular, okay? Type 2 and type 3, I don't like. We see the Spears paper telling us about 62% there is a problem when you contract the muscle. Sorry, but I stopped use this store. If I can say for thing you today, I say stop. You never, this is a place that I never use again. Never, because there is a lot of problems when you have a contract of the muscle. Choose implants, profile, projection, size, surfaces, filling, and manufacture. Anatomical profile. I just use anatomical implants in breast reconstruction and tuberous breast. How the profile? There is a lot of kinds of high profile. There are a lot of kinds of projection. The portfolio is very good, is very high. More restricted use. Patients with good projection and a real breast base, Mastopexy, and others. Round height projection is most frequent use, implant of choice of most plastic surgeons in Brazil and the world, and patients with a good breast counter. It's new one, 5 years, 10 years ago. High, super high. Less use, patients with good breast counter, increased projection without an exaggerate increase in breast diameter. Simastine, O, anterior axillary line. It's important to maintain the diameter of the breast. Implant size. First one is more important, I think so, the patient design. Anthropometric measure, normal side, the external sizer, use of molds, internal sizer, use of expansion mode is like an internal sizer in digital simulator. Virtual simulator like if is greatly facilitates the choice of implant. It's captured for virtual reality, impress our patients. I like to use if in my patients. How do I do if I don't have digital simulator? Start here, I trace the midline to 1 centimeter or 2 centimeters, depending on the patients, start the base of the real base for this breast. And stop here in the anterior axillary line. Here is the real base. The implant diameter is measure base, the real base, and pinch test in the upper paw, 2, 3, 4, 5 centimeters. Let's see here, 10. The base, the real base from my breast is 10 centimeters. The pinch test is 2. I choose the 8. The diameter from my implant will be 8. The surface, I just test through. And I love the adherence of my implants. I need this adherence for my results. And feeling, 100% feel to avoid hippling. I rate hippling, and I think the feeling, the 100% of feel is very important to avoid hippling. What about the manufacturer? I know that you know about this. The product quality is very important. Not the cells say for us, but what the scientific studies say for us is very important. For me, I will choose this implant, this device, just what I say, what I see in the papers, in the scientific studies, approved by the regulatory agency and delivery logistics. It is very important. Who is this company? Who is this company? Take home message, please. Breast implants and their service have been established for over 60 years. We cannot let this with very low levels of evidence. Almost on speculation, maculate this product. In aesthetic or reconstructive surgery, in 2021, it is the best and safest option. Thank you again. See you early.
Okay, I'm afraid we can go on because the speaker is not connected. So, maybe we can see if Dr. Munhoz, Alexander, is with us or not. We can see after the video, and so is going to present defining and calculating the zones of fat grafting to achieve predictable results in breast augmentation.
Hello everyone, thank you very much for the invitation. I will talk about hybrid breast augmentation, defining and calculating the zones of fat grafting. This is my disclosure with Establishment Labs Motiva. In hybrid surgery, we have different materials that confer different properties. Thus, fat allows you to change the surface, make it smoother and still protecting the implant more naturally. And the silicone implant is located in segmentation, defining and calculating the zones of fat grafting. This is my disclosure with Establishment Labs Motiva. In hybrid surgery, we have different materials that confer different properties. Thus, fat allows you to change the surface, make it smoother and still protecting the implant more naturally. And the silicone implant is located in the central region to promote projection, thus working with smaller volumes of implant. This is the concept of hybrid breast augmentation. And what is our standardization in the preoperative markings and distribution of the fat in the breast? Basically, we have 4 objectives of hybrid breast augmentation. Objective number 1, to create an homogeneous transition at the upper pole. Number 2, no step between the region with and without implant. Objective number 3, to promote a greater distance between the implant and the skin. And finally, the reduction of the intermammary distance and working with smaller implants. And the distribution of fat into the breast is predictable. We have on the upper pole the zone of fat only. We have in the middle pole a mix between the fat and silicone. And in the lower third, the inferior pole, it's the silicone only zone. And the same pattern that we have on the upper pole, we can achieve into the medial aspect of the breast. We have in the parasternal area the fat-only zone, where we create a transition between the implant and the midline. We have a mix of fat and silicone located on the medial quadrants, but lateral to the fat-only zone. And on the lateral aspect of the breast, the silicone-only zone, where we can put some fat, but only in the upper lateral area. And here you can see our standard planification, and it's not different from normal breast augmentation. The most important is to define the implant pocket limit, and especially the superior breast limit. So once you define the superior breast line, we can classify the zone 1. Zone 1 is a crescent shape located in contact with the implant pocket. And then the zone 2 located superior to the zone 1 in contact with the infraclavicular area. It's a transition zone. And finally, the zone 3 located on the medial aspect of the breast in order to create a better transition of the implant in this area and reduce the intermammary distance. Here you can see a simulation of the implant position and fat grafting distribution. And here is an example, 32 years old, primary breast hug, symmetrical breast, very low pinch test with visible ribs. And as we mentioned before, this is our standard planning. You have to define the implant pocket dimension based on the medial and lateral limits, and then create the superior breast line. And so the zone 1 and 2 and the zone 3 on the parasternal area. Here you can see a simulation of the implant position and fat grafting distribution. And here is an intraoperative view. On the upper video you can see zone 1 and 2 fat grafting, and on the lower video the zone 3. We usually use 1 millimeter incision on the upper lateral aspect of the breast, and we like to use a 1.9 at maximum 2.1 millimeter cannula. And then we try to distribute 3 cc of fat into 8 to 10 centimeter length in order to create a very thin ribbons. Here you can see the distribution. We insert the cannula, find the place, and pull slowly in order to avoid fat leaks. On the lower video, you can see after demarcation of the zone 3, the transition on the medial quadrants, the same procedure. Here you use 1 incision for each breast, but you can do with only 1 incision at the midline. And with the IFP insert, find the plane, and pull slowly. We distribute 3 cc of fat into 8 to 10 centimeter length from the upper medial quadrant to the inferior lateral quadrant, creating a crescent shape fat distribution. And here you can see the outcome. This is the pre-op, the post-op after 255 cc ergonomics full projection implant associated with 135 cc of fat grafting into zone 1 and 2, 100, and zone 3, 35 cc. And the control with MRI performed 1 year after breast. Here you can see an adequate distance between the implant and the skin, with an average of 1.8 centimeters until 2 centimeters, with a very good coverage, as you can see here in static and dynamic MRI images. And we can associate the hybrid surgery with other procedures with better results. It's what I define SIA, subfacial ergonomics, axillary and hybrid surgery. Subfacial pocket, less invasive, less pain, and no breast animation deformities. Ergonomics, softness, and naturally respond to gravity with a round base and a shaped format. An axillary approach with no breast scar and a natural camouflage. And hybrid surgery, softness, natural touch, less rippling, and a possibility to work with smaller implants associated with fat. And how to predict the fat volume required before the surgery according to the implant volume and projection. And for this objective, we have a new tool in hybrid surgery. This is the Max Munhoz formula. It's a simple way to calculate the fat volume, and especially the distribution into zone 1, 2, and 3. This formula was published recently in a Aesthetic Surgery Journal. And to create this formula, we have the support of an interesting software. It's called SketchUp system. And basically, the SketchUp software is a 3D modeling computer program with a wide range of applications: interior design, landscape, mechanical engineer. It's available as a web-based app, and you can simulate different areas and also permits volume calculations. And with SketchUp system, we simulate the 3D distribution of fat grafting into the upper and medial poles. And for this objective, we create 2 lines, one from the top of the implant and one from the implant base in an angle of 60 degrees, just to create a cone shape. And our formula is very simple. Here you can see with 100% of fat intake, which in the real world is impossible. So we use a 75% of fat intake. So it's pi multiplied to the radius of the implant, multiplied to the projection, and divided by 4.8. And in our study, we compared the volume calculated by the formula and that done in real cases, and we observed a higher correlation. Furthermore, the greater the projection of the implant, the greater the need for fat to obtain an anatomical and natural result. And what are the most critical areas that need the most volume of fat grafting? And based in our clinical experience, almost 66% of the volume calculated by the formula, we graft into zone 1, and 1/3 into zone 2. And zone 3, it depends of the intermammary distance. You can fill with 0 until 125%. It depends of the distance between the two breasts. In this way, you can classify the intermammary distance into zone 3A, B, and C. And based on the fat volume that we calculate through the formula, if you want to fill 1 centimeter in this area, you need 25% of the volume previously calculated. If you want to fill 3 centimeters, 75%. And if you want 5 centimeters, you need 125%. This is a large intermammary distance. And here is a tertiary case of breast augmentation. Capco on the right breast, and the patient wants increase of the volume and reduce the intermammary distance. She complains about palpability and implant tips. And here again our standard planification. When you define the implant pocket dimension, you calculate the superior breast line, and then the zone 1, the zone 2, and then the zone 3 in contact with the parasternal area. And here is after subfacial breast augmentation axillary approach, and the zone 3 fat grafting doing simultaneously, where you can see fat grafting into the medial and inferior medial and superior medial quadrants, creating a crescent shape in this area. And a view from the bottom, where you can see in the pre-op with 5 centimeters of intermammary distance, and immediate post-op with almost 1.5 centimeters, the distance between the two breasts. And this is the outcome: the pre-op with a submuscular implant with cap cone and asymmetry, and the post-op in a short term and the long-term follow-up at 1 year after 235 cc full projection ergonomics associated with 145 cc of fat grafting. And here you can see the outcome from the top, where you can note some implant tips and some contour alterations. And then the follow-up and the long-term analysis at 1 year. Submuscular pocket in the pre-op and subfacial pocket plus fat grafting in the post-op. And with 3D scanner, we can have a more precise evaluation. Here you can note intermammary distance in the pre-op of 3.4, and then after in 1 year with 1.7, and a less than 1 cc difference in terms of volume between the right and left breast. And also you can note very clear the benefits of fat grafting into the zone 3. Here you can perceive the distance between the two breasts in the pre-op and the post-op, just using small volume implants associated with fat grafting. In conclusion, in hybrid breast augmentation, we have different materials with different targets, especially when you take a look to the touch, to the coverage, and the core projection. I advise to stay modest. More seeds on the same ground do not mean better harvest. Overfilling, you can have necrosis. Overgrafting, you can lose your fat. Thank you again for the invitation, and I appreciate your attention.
Thank you, Dr. Munhoz. Do we have any questions for Dr. Munhoz? Okay, I'll start off the questions. I read your article with interest, and the equation included the radius of the implant and the projection of the implant. So it seemed to me that any patient treated with that implant would get the same amount of fat because there's no patient parameter such as subcutaneous fat thickness in your equation, but I may misunderstand your equation. Do you individualize? Of course you individualize.
Hello everyone, thank you again for the invitation. It's a great pleasure to be here, and thank you Fabio and Mark to participate in this meeting. This is a very interesting issue, and the formula we have been doing in the last 3 years, and it works very well. And if you change your projection, you need more fat. This is a fact. Because when you calculate and you put the variables in the formula, one of the main points is the base, the diameter of the implant, and the projection of the implant. It's totally different, the amount of fat that you have to fill the space between the upper pole and the infraclavicular area when you have a low projection implant, and if you compare to a high or extra high projection implant, because you have two lines, one from the base and one from the domos, the top of the implant. In an extra high projection implant, the distance between these two lines are totally different. And consequently, the amount, the volume of fat that we have in this space between the top of the implant, the upper part, and the infraclavicular area will be different. So in our experience and doing this in the last 3 years, extra high projected implants, you need more fat in order to simulate a homogeneous transition between the infraclavicular area and the domos of the implant. However, if you compare to a low projection, the curve, the lines are more close. So the amount of fat that you need will be smaller. So this is the main points when you put the variables in the formula, projection and the base of the implant.
Do we have any other questions?
No, I think.
Hi, Alexander.
I think we have to go on because we have used all the time, a lot.
Thanks, Alex, and invite him to go back to his ENT patient waiting for him on the table. Thank you very much for your professionality. Thank you.
So we move on to Professor Cervelli. He will speak about fat graft again, I think, and is fat grafting in hybrid breast augmentation. Changer, I'm sorry, I can't read very well.
Or just supporting cast.
Thank you.
Thank you very much. I'm not a video clip. I'm bone and
You're
meat.
Here. You're not virtual.
Fat. In fact, I'm going to speak about fat. Thank you, Fabio and Mark Clemens, for the kind invitation. Thank you, moderator and Mr. President. I'll go on. Okay. We are not sure if the game changer can have a real role in this match, or is more important the cast supporting. But obviously, breast augmentation is the most performant surgical procedure in plastic surgery, even in Italy, with about 52,600 operations in 2016. And the use of autologous fat grafting is a pivotal tool in breast surgery, and the combined use of breast surgery and the autologous fat give us a promising result. Because of a lot of problem, obviously we have to discuss about the number of procedures, as you saw before in the previous speaker. We have not a predictable graft survival, but which one is the real advantage to use the fat? And the trends of autologous fat grafting and aesthetic breast surgery, obviously, this is a casuistic of 2013. Only more or less 30% of the surgeons use currently this technique. Now we are trying to do something similar. We are now doing a sort of questionnaire for all the Italian plastic surgeons. And the main indication, which one is obviously breast augmentation adjunct with prosthesis. The hybrid solution is the most experienced situation in which we are going to use this fat grafting. Let's go to our experience that especially take advantage in spotty patients, in patients who want to have a major degree of cleavage of the breast and to reach upper pole fullness, especially together with round implants in which we can reach the result. We had the risk of implant visibility so that we can go to the hybrid solution. As you saw before from the previous lecturer, we can transform the round implant in an anatomical solution to correct the step-off deformity even in the upper pole, then in the medial part of the breast, and to increase the fullness of upper and medial pole in both situations, even in sovrapectoral situation, putting fat in the prepectoralis fascia and in the prepectoral subcutaneous station, and even in the submuscular situation, the same procedure, you can give more fullness even in the upper and in the lower pole. In our experience, we used to do the breast pinch test, and our cutoff is set at 2 centimeters. If more than 2 centimeters, we try to do, speaking obviously with the patient, a subglandular implant. In less than 2 centimeters, we go to submuscular pocket. And in this pinch test, if the subglandular implant need more fullness in the superior medial poles, we go to the composite breast augmentation with fat. And if the pinch test is inferior to 2 centimeters, but the patient doesn't want a subglandular implant, we go to the dual plane with more fullness in the superior and medial pole together again. We go to the composite breast augmentation, as we do if the patient wants the subglandular implant. However, the surgical technique was described more than one time, even my previous lecturer. We think that it is quite independent if we take the fat from the lateral thigh or from the abdomen. We take advantage from the position of the patient in the operatory theater, and after having tried a lot of technique of lipotransfer enriched with stem cell, we went back in the last year to the classic Coleman technique with the centrifugation in the centrifuge to obtain this fat that we put in the medial pole and in the upper pole more and more, but even in the lateral one to correct the step of deformity of the patient. And our classic goal is to reach this kind of result to correct the abnormalities of the round profile of the breast. These are all cases in a dual plane situation that you can see in the preoperative and postoperative after 1 year control. And various kind of patients obviously need different quantity of fat. I fully agree with the concept that it is useless to put too much fat because it's going to be resorbed. And if we think that we need more than one operation, we say to the patient that it's necessary to do this more than one time, especially in secondary cases like in this one, in which you have a double bubble deformity and a quite clear visibility of the implant of the patient. It's necessary to do more than one time. But from the patient point of view, these are the characteristics of our study, 55 patients of a mean age of 39 with a follow-up more than 1 year, and 55 cc for each one operation to correct the contour of the breast. Quite a little number of complications of local swelling and bruising. The fat was arrested, as I told before, from the abdomen and the latter part of the thigh. This was the test that we used to give to the patient, in which we went to see the satisfaction and the sexual well-being and the outcome of the patient, that is going to increase even in the post-operative, immediate post-operative, then after 1 year. This hybrid breast augmentation gives, obviously, in our opinion, a high level of patient satisfaction, because, as I told before, conveys a more natural shape of the round implant, giving them the camouflaging and giving the impression a more natural result, and also because extend the possibility of the use of round implant. One of the questions, very important, is reduce the capsular contractor rate, really, even because increase the coverage of the subcutaneous and the peri-prosthetic width, and even if because it reduces the risk of capsular contraction, we have to ask if this is the correct way and to potentiate the antifibrotic effect, because this possibly is the real reason that this fat contains obviously stem cell, even adipose-derived stem cell that are contained in the stromal vascular fraction, with a pro-adipogenic and pro-angiogenic involvement, but more and more with an antifibrotic effect on the peri-prosthetic tissue, so that it's possible that this antifibrotic effect gives us a lower capsular contractor rate with really there is not a prospective study that can assure this. We have a little number of patients, and there is a high risk of bias, so that is impossible to do to give definitive conclusion about this. But the satisfaction of the patient is of paramount importance in the decision of the type of procedure to be used, and this composite breast augmentation may be a valid alternative to the implant-only technique, even if we need more and more study to demonstrate the real tendency. The use of an algorithm that is based on the pinch test result and the patient preference may help the surgeon in the decision-making process and can improve the outcome of for the patient, for the satisfaction of the patient. But as I told before, we have a short follow-up and we have absence of a prospective study, so that the hybrid augmentation at the end share the same limitation of the autologous fat grafting, including the non-predictable fat resorption and the possible need for multiple procedures. So that maybe not the game changer, but if it comes into play at the right time, together with the cast, can help to win the match. Thank you very much.
Thank you, Dr. Cervelli. Do we have any questions for Dr. Cervelli? Yes.
Dr. Kolasinski.
Congratulations. The idea of hybrid augmentation is fantastic. Only my suggestion that instead of putting
Mike Jordan.
if instead of put the implants under the glandule, much better is subfascial, because you have much better vascularity, so you reduce the risk of capsule formation, you better protect the lower pole when you sew the fascia, and you have a little bit more safer space for fat grafting. So I think subfascial is much better.
Thank you
and
very much
safer.
for your suggestion, but sometimes it's not so simple to isolate the pre-pectoral fascia.
Dr. Cervelli, what % of patients get fat injection, and what volume do you typically use?
In the last year, because I know that I had to come here to give this lecture for Fabio Santanelli, I put a lot of...
Valerio, can you address a bit the topic of the donor side? Because I believe the abdomen is a rather risky site, especially in the long-term view, because you can have irregularities. The ideal site will be the flanks, but very often augmentation patients have not so much fat there.
There is a fantastic study about this of Professor Sbarbati from Merona, that you know very well, that gave us at electron microscopy a complete study about different places for harvesting fat. And at the end of the story, I think that is quite the same, really. Even from the abdomen and the flank and the lateral thigh, so that what is important is to gain time during the operatory, in the operatory theater, not to have too long time during the operation. The only different fat that Sbarbati demonstrated was the one of the foot, that is completely different from all the other sites because it has a more fibrotic net.
I have also a question. As you say, the percentage of intake, the survival of the fat is unpredictable. So my question is, in cosmetic patients that we all know the expectation is very high, what is the percentage in your experience of touch-up and asymmetries between the two breasts?
I used not to put too much fat, really. I used to do much less than 100 cc, more or less between 50 and 70 cc of fat each breast, no more.
Okay.
I prefer to do this more than one time, especially in breast. We published a study some years ago in plastic surgery about that, probably next time I will put the study about the percentage of survival of the fat in the breast, that it is obviously much less than in the face.
Thank you.
Thank you very much.
Any other questions? I think we can move forward to next presentation. Dr. Chacon, welcome. And you're going to speak about hybrid breast augmentation from concept to everyday. Thank you.
Thank you very much. Thank you, Dr. Clemens and Dr. Santanelli, for the invitation. And I think everything had been said before, so I'm going to round up because wonderful presentations. Let's see how it works. So I have all the conflicts of interest. I'm Motiva, a medical educator. I'm a shareholder also from the company. So we're going to talk about the objectives. I think everything has to have an objective, and I think in breast augmentation we should know what the goals are. So we tell the patients always that the objective of a breast augmentation is to do upper pole fullness, to put the nipple in point of maximum projection, and the third one is to give medial cleavage. So this is the main cause of why we use fat. Then with this, at the end of the procedure, we tell the patient we achieved the goals, check, check, check. I want more, I want less. No, the goals were achieved. So the implant surface, now with the new generation of implants, these implants behave differently, and so we have to adapt to the new implants. And these implants will not adhere, so we will move more like a natural breast, and we have to learn to use them differently. So what's the trends in breast aesthetics? Now we have more trend to use smaller implants, and this is what happened in my normal practice. They have to be exercise friendly. So now let's see if it moves. Okay, this is a 140 cc breast augmentation. And very important, at least in Costa Rica, 90% of women exercise and the other 10% wants to exercise. So you have to think in the future of these patients. And the other part is have a breast that will be easy to dress. So you have to think that there's a lot of money put in the how to dress a breast. The indications. So to motivate to have a hybrid breast augmentation, we divide the indications in three areas: thoracic shape, that it was addressed just before; breast hypertelorism, too much space between the breast; and increase of the pinch, or increase of the tissue coverage. So the thoracic shape. What we did is we measure using AutoCAD the shape of the thorax, and frequently we knew that then, and it was presented just before me, and we divide it in right divergency, bilateral divergency, left divergency, and most of the patients had a right divergency shape of the thorax. Why? Because the only hard organ in the thorax is the heart, is in the left side. So most of us have the same thing. So if the patient doesn't know that from the beginning, they will say after the surgery, look, my right breast is looking to the other side. No, it was like that from the beginning. So we measure every patient that and this was one of the indications to use fat. This is using AutoCAD and seeing the degrees of divergencies. And this is another group. And during a whole year of breast augmentations, we had 84% had right divergency. Only 1% have a left divergency. These are the most prominent angles, the less prominent angles, the less different angles, and the most different angles. Then the breast hypotelorism. So we find that a lot of patients had an important separation between the breast. The mean separation that we had in the patient that we use fat, it was 4.1 centimeter. The largest was 5.5. The shortest was 3. But the medium post-op, it went down to 2 centimeters. For the amount of fat that we use in these cases, almost 75% were very, very small amount of fat, only between 11 to 30 cc's per side. So we use very small amount of fat. So the increase of the pinch. Now with the fact of women doing a lot more exercise, we have to avoid, at least in my practice, the use of using under the muscle. So we go a lot pre-packed, and sometimes we need to increase the pinch. So, and you see how the less was the pinch, the more fat we had to use. And this frequently we see women that do a lot of exercise, and then we cannot use the subpectoral position. Then the surgical technique is very straightforward. We will use the donor side, mostly the flanks. It takes a medium of 9 minutes to do it. Then we do the breast and our breast dissection. It takes about 22 minutes to do it. Then we harvest the fat with a syringe with a toner cannula of 2.4. It takes about 12 minutes. And then we do a no-touch insertion. We use a very small scar. We use a medium of 2.6 centimeter scar, mostly by the IMF. And at the same time, the nurse is preparing. We use the pure graft system. I think it's simple. The only problem is expensive, but the fact of it's simple to use, and you can irrigate it and wash and everything, and then you have the amount that you need. And then in the same time we're doing start the breast closing. We sit the patient to close, and I follow the technique that was developed by Dr. Hammond to secure the IMF, and we close in 3 levels. And then at the end, we start using, with the patient seated, we put the fat. And we follow Alexander technique, but we do less amount of fat. And we use a cannula of 1.6. So the way I think is and sometimes they think they can puncture the implant. We can use an ultrasound to guide it lipofilling, but it's really not necessary. You're going to see your cannula under the skin. If you want to show mostly for education, you can show by the ultrasound, but it's really not needed. So the way we do it is that we put the implants, then we put one line of 3 cc's in the higher part, then one even higher, and then the medial one. We do the same in the other side. So with this, we need not that much fat to do the fat grafting. The same we do in the frontal view. We do the first a little higher, then higher, and then the medial one. We have to avoid the put too much in the medial part because you create almost astigmatia. And then in the upper pole, it's different because you have to fade the shape of the breast. So going back, we put the first syringe, the second syringe, the third that will lift it. And with this, we need a very small amount of fat to give the cleavage that we want. So some results. This is a patient pre-op. This is exactly immediately post-op. And this is 3 months to 6 months. This is doing mostly the pandemic, so the patients have not more than 1 year follow-up. This is another case with an important separation between the breast. You can see my fingers in between and just after the fat injection. And you can see the result 3 months and 6 months after. Another case, you see my hand in between and just after the fat grafting. And 3 months, I think 6 months after the fat grafting. In another case, I include this, even though it was a breast augmentation, but now we're trending to use more in mastopexy. And this is just after the mastopexy, and we put the fat at the end, and this is the result 1 month and 5 months post-op. So now, in the 45% of my breast augmentation is done with fat. And it has increased only about 25 minutes of surgical time. So this is I think fat grafting is like drinking whiskey. It's like an acquired taste. When you start using it, you like it, and the only problem is the cost. Thank you very much.
Very nice presentation and great graphics. Do we have any questions? So Manuel, what percentage of your patients get hybrid procedures?
45%.
45%.
Of breast augmentations.
So you are not doing any submuscular augmentation?
No, sometimes I have to. And even because if Dr. Kolasinski talked about the shape of the thorax, and sometimes you have a very thin pinch, and you have to go under the muscle, and sometimes the muscle is inserted too laterally, so you have to put fat to give that cleavage. So I still have to do sometimes under the muscle, but I have reduced the size of my implant, and I put a small amount of fat.
Any other question? Dr. Kolasinski?
Only one short question about your recommendation after the surgery. How long do you recommend to use bra? Because if there is a stable, I think the survival of the fat is better. What is your recommendation?
I try to make things the more simple possible. This morning was amazing to me to see back again the big surgeries that you guys do, and I do very simple surgery. So very simple post-op. I put a small amount of fat, so you hardly need. I put that surgical bra only because it's in the books that you have to put it, but they can go normal life almost 3 days after, only not exercise, no sexual activity. Apart that, almost normal activity. Thank you.
Okay, thank you. Dr. Harris, safety and effectiveness of silicone breast implants in breast augmentation.
Thank you very much. Yes, safety and effectiveness. There we go. I think I'm not ashamed to say that this is a sponsored talk. Sponsors support these meetings. It's because of sponsors that we're here and we're able to get together and talk in this way. So this is a sponsored talk, although actually I'm completely independent and Mentor have not seen or vetted this talk in any way. I do receive a payment per hour as part of Mentor's educational output, but I'm not a shareholder or don't earn any money from Mentor in that regard. So I want to be very upfront about that. But they've asked me to present this. It's not my work, in fact. And there's the written disclaimer. So it's really about a very recent paper published in the Aesthetic Journal, Safety and Effectiveness of Silicone Gel-Filled Breast Implants in Primary Augmentation Patients. And I'm going to share with you this recent publication and go through it and see what it does for our practice and how it helps us or doesn't. The issue is that the core studies are now quite aged. And they are scientific studies. They are scientific studies that the FDA set up. And they don't necessarily represent practice so much because they were dictated to in terms of what the follow-up must be. The data is specific to each of the core studies, and whilst there might be some crossover between the core studies, you can't really compare those core studies to some of the publications that are delivered currently from other companies who haven't been through that FDA. So it's a little bit of a sort of, you're comparing apples and pears, as it were. So it's difficult to know about all this data, and what we're not getting is real-world experience, and that's not discussed. And I think that can add, not replace, but it can add to our understanding of implant performance. If you look at the core study for Mentor, that's the 10-year core study as a prospective, started in 2000 and has just been published this year. The 3 and 6 year data has already been published and demonstrated safety and effectiveness in Mentor implants. And as I said, the 10-year study has just been updated. It is the most comprehensive and detailed study. It's 1,008 patients and 48 sites with 62% follow-up. And at 10 years, 98% of patients said that they would take the same decision to undergo breast augmentation. Again, I think we've seen a lot of that data. However, this last data has shown some sort of issues, and the estimated, I stress that estimated rupture rates are concerning. And this is from MRI suspected ruptures. It's not all confirmed, it's subset analysis, but they seem to be quite high, and the MRI estimated figure is something around 24%, with a mean rate of rupture of 8.3 years. The confirmed rupture rate is very different. That's actually 9.8%, so we've got a bit of an anomaly here. And the symptomatic rupture rate is 0.6%. So we have a real problem in terms of what patients are recording and what some of these detailed MRI studies are recording. So the thing is, we've got this knowledge paradox. The more you think you know, the less you know, really, because it's just asking more and more questions. And the more you know, actually, the more you know what you don't know. So, as I say, I don't think these real-world studies change or replace the core studies, but they add to our understanding. So what they set out to do was measure real-world long-term outcomes associated with memory gel implants in a single center, primary breast augmentation, smooth implants, and perhaps more representative of clinical data. And there is a move in the literature, not just in plastic surgery, to look at real-world data. It's complementary as opposed to replacing clinical trials. And yes, there's an inability to control for lots of potential biases, and there's not all the data there. But it is patient-reported outcomes, and that can help you in your day-to-day practices in terms of informing patients about what they can experience with respect to risks and benefits. So this study is primary augmentation, 22 years old patients implanted with memory gel breast implants at one plastic surgery center in the US with a minimum of 2 years follow-up. Mean follow-up is 6 years. And it was basically a telephone and email questionnaire following up performed on all patients meeting the criteria. And it was a very short period, a couple of months of follow-up, with questions like, have you experienced any problems, complications, bleeding, pulmonary embolism, cellulitis, infection, have you been reoperated on anywhere else, or your own hospital, mastopexy, breast uplifts, anything really, and what was your overall satisfaction? And if there was a problem with satisfaction, if they scored less than 8, they were brought in for some more detailed discussion of what their experience of these implants were. So it's a big study. It's 1,500, almost 1,600 patients eligible for the study, of which there's almost a 50% response rate. And there's a 6.4% reported complication rate, with an average time to complication of 4 years, all the way out to 12 years. So the complications really, as you might expect, to be honest, capsular contracture, grade 2 was the most common at 2%, capsular contracture grade 3, and then ruptured implants, grade 4, seromas, implant exchange outside the office, so one had mastopexy, one case had developed breast cancer, one had been reoperated for asymmetry, a double bubble, sinusitis. So a mixed bag, but relatively small numbers. They looked at sort of root cause and see whether there were any links to any of this, multivariate Cox regression model analysis, and they showed that larger average implant size increased the likelihood of a complication. And I think, although some studies have not shown that, I think we would all agree with that, to be honest. And I like to see this new era of hybrid augmentation where we're going to smaller implants and patients accepting smaller implants. I think we're in for a better wave, if you like, of those patient experiences. Almost all of these patients had subpectoral, so there were fewer complications, but that's a bit biased, I think, because there's very few subglandular here. And of course, these are smooth implants, so the capsular contracture rate subpectoral is lower than the subglandular rate. And patients undergoing concurrent body procedures had a higher complication rate. So this was the results. The Kaplan-Meier estimation 10-year incidence of capsular contracture was 4.7%, Baker 3.4, which is what I tell my patients. I say it's about 5 to 10% 10 years. The estimated 10-year incidence of infection was, of course, very, very low. That's all our experiences. And here's the interesting one, is that the estimated 10-year cumulative incidence of rupture was 1.6%. So that's certainly nowhere near the 24% of MRIs in the core study. So the question I want to hopefully pose to the audience, and my last talk about breast reduction stimulated some good questions, so I'd quite like to stimulate some good questions here in discussion really, which is this real-world data relevant, or should we simply just quote the core studies? I think real-world data can supplement clinical trials by providing information of outcomes observed in, yes, less structured settings, but it's real-world, and it's what we're experiencing, of course. There are changes in standard care, as I mentioned before. Surgical technique has changed over the last 10, 20 years, and that's improved outcomes, and so some of the older studies are out of date now. And such studies do add to our understanding of implant performance and also our interpretation of the published data, because what we need to do is understand that some implant series are publishing real world and some implant series are publishing clinical data, and they can't be compared, as I said, apples and pears. The other question it raises is, should patients be screened with MRI? Due to a lack of MRI screening in this study, this is the real-world study, there's only 1.6%, which probably represents the symptomatic ruptures. You remember in the core studies, that was 0.6%, I think, was symptomatic. So, and if you look at that, 65 of the 68 confirmed ruptures were considered silent. So silent rupture rate is quite high. And the FDA recommend MRI screening at 3 years postoperatively and then every 2 years thereafter. And yet, it's interesting to observe from this side of the pond that over half of the ASPS members report that they follow these recommendations. So perhaps MRI is overcalling it a little bit. And as we move into this new era of greater implant surveillance, I guess we must expect this more frequent diagnosis of a suspected rupture in our practices, and we need to develop strategies for dealing with them. And further to this, should patients with suspected rupture on MRI undergo explantation if no additional symptoms exist? Now, this is a controversial question because these data, if you compare the core studies to this study, it suggests that the silent rupture rate is certainly much more frequent than the symptomatic rupture rate. But it's not all there, and it's not all true, So, and 41 of the suspected 122 implant ruptures were not removed in the core study. So, patients come to me with an implant rupture, I suggest they have their implants removed. and it's perhaps controversial to say you shouldn't have your implant removed, but it's just this week, and I'm not telling a lie, I took an implant out on Tuesday and put it for a suspected rupture and put a DIEP flap in, a breast reconstruction patient, and I got to it and the implant was not ruptured. So, she had a DIEP flap and the implant wasn't ruptured. There were other reasons why she moved over, but we need to know if the implant is ruptured or not. And if it's ruptured, is it causing any other problems? Because in the core study, there were no cases of ALCL, there were no cases of memory gel implants causing connective tissue disorders, autoimmune disease, rheumatoid disease, or breast cancer on the questionnaires that were provided. So, I'm not sure. I think it's controversial to suggest we don't remove suspected implant ruptures, and I think all of my patients, if I tell them they've got a suspected implant rupture and an MRI, they will all want their implants out. But there are surgeons and authors out there who are suggesting that we perhaps could just maybe hold fire a little bit and watch and wait for some of these patients, and obviously have an informed discussion with them about the chances of the true implant rupture. Thank you. I hope that does stimulate some questions and discussion.
Thank you, Dr. Harris. Any questions? Yes, Manuel.
Thank you. Thank you very much. What was the percentage of patients with subpectoral placement? The percentage of patients who had submuscular, and any data about pre-pectoral percentage?
Yeah, so I think that it was, I can't give you the figures off the top of my head, but because it wasn't my study and I didn't write that, I'm reporting it, but it was predominantly submuscular, and so I think it was sort of like 80-85%. There was a trend to the submuscular doing better with fewer complications, but because the groups were not even, they couldn't make that conclusion. So they said, although there was a trend to submuscular doing better, subglandular having increased complications, they were not able to say that accurately because of the groups were not even.
Manuel.
Dr. Harris, sorry. That was a fascinating presentation. However, I do have some concerns about what you mentioned regarding the fact that core studies don't necessarily represent real-world data, and I have some right here at hand. Just to put one from Mentor core studies, how would you say that 59.7% of reoperation rates at 10 years are not representative of real-world data? Maybe core studies do represent a high standard that we should use to assess safety of breast implants. So could you please comment on that?
Yeah, I mean, those patients are in a study. I mean, they're being called back regularly to be examined and imaged. And so that leads to a higher suspicion of problems and a higher or lower threshold for reoperation, I'm sure. And I can't, I'm just saying that study is not it's not a real world study. That's patients being called back. I don't call my patients back after a year. I discharge my patients. Now, they may be going elsewhere. I completely accept that. But I suspect if I did call them back every 6 months or more frequently in the core studies, then I would pick up problems and I would be heightening their attention to some of the deficiencies that they see. And, I mean, how many patients do we see in clinic who come back and say, yeah, I've had this problem for 5 years, but I just haven't got round to having a reoperation just yet. Now, if you're in a close follow-up research study, as soon as you see that problem, you're going to say, would you be able to fix that up for me, doctor? And you probably would do that. So I'm not saying it's not there. It is there. But these are different studies, and they represent different data. And I think that one does not replace the other. Absolutely, completely get that. But they are perhaps part of our experience of practice. It more mirrors that rather than what's going on in some of the detailed studies.
Okay.
It certainly doesn't replace them.
We'll need to wrap up the questions and go ahead with the next study.
It's more a comment. And now I think technology can help us, and high-resolution ultrasound has become something that you can have in your office. It's very easy to use. It's very easy to see a rupture, a malposition, the rotation, flipping. So I encourage younger surgeons that I'm sure they have done this in general surgery to use it. It's very simple. Now they're $2,000, or the butterfly is very cheap. And then we're also giving courses in ultrasound if you guys want to join us. But it's a great tool, great accuracy. And since you know the implants, you know better than the radiologist if it's only if it ruptured or not, if you have extra liquid, if you need to puncture. So I will encourage that.
I couldn't agree more, actually. I think I'm definitely moving in that direction with high-resolution ultrasound. It's changing this quite a lot. And I think the MRIs actually are not as good because they're overcalling situations.
Thank you, Dr. Harris. I'm sorry to interrupt the discussion, and we have to go on with the last presentation, Dr. Lennox, hybrid revision breast augmentation.
Good afternoon. It's my pleasure to have the opportunity to present to you, and I'd like to thank Dr. Clemens and Dr. Santanelli di Pompeo for the invitation. I'm truly sorry that I'm not able to be there with you in Rome. I know many of you, and I would have loved to have had the opportunity to see you and to be in Rome, and I hope that next year I'll be able to see you all in person. I'm going to be talking about hybrid revision breast augmentation. These are my disclosures. So first, I think one has to define what hybrid breast augmentation is, and it probably is the same as composite breast augmentation. So hybrid refers to something heterogeneous in origin or composition, and the synonym is composite, and composite means made up of distinct parts or elements. And the definition for this talk is I'll be referring to revision breast augmentation that involves components other than an implant alone. And specifically, I'll talk a bit about autologous fat grafting, which has been well covered so far, as well as implant support, including mesh and acellular dermal matrices. I think that one can further classify hybrid revision breast augmentation into simple, involving one of these elements, or complex, involving greater than one additional element. In revisional breast augmentation, there can obviously be issues with soft tissue coverage, soft tissue quality, implant pocket, and implant support. These can exist in isolation or most commonly in combination, and having an analytical approach to patient assessment will determine which tools we use for which patients. So starting with fat, and I won't spend much time on this because there have been excellent talks already to address this, but fat clearly can improve implant soft tissue coverage. We'll talk about some of the evidence that it may improve soft tissue quality, and that clearly can improve breast shape. And an example would be moving from shaped to round implants, and certainly implants in a pre-pectoral position. There have been multiple studies on fat harvesting and processing, and I think that in summary, there's not really good evidence that different harvesting techniques, so hand harvesting, suction-assisted lipectomy, power-assisted liposuction, use of ultrasound, water jet, none of these have a huge significant impact on graft take. There's not very good evidence that different processing techniques have a significant impact. There may be some evidence that modification of the lipoaspirate, either with stem cells, adipocyte-derived stem cells, or PRP, may improve engraftment. So this is a simple case of fat grafting alone. This is a 44-year-old woman with multiple previous breast augmentation revisions, including up to 800 cc implants in the past. She now, at this point, has pre-pectoral 445 gram moderate projection textured implants in a pre-pectoral position. On the right side, she has Baker grade 3 capsular contracture and asymmetry with medial rippling and flattening of her lower poles bilaterally. And the plan for her was revision to smooth implants and revising her right pocket as well as bilateral fat grafting. So she had a right partial capsulectomy and new implants, fat grafting from her medial and lateral thighs with 130 cc's of pure fat injected into the right side and 110 on the left side. And she's had a subtle improvement. She has better coverage of the upper poles, better contour, and less flattening in the infraareolar area in the lower poles. This is a more complicated patient who has a very complex history when she presented. Of note, she has a BMI of 17.4. She originally had subpectoral saline implants placed through an infrarelar incision. She then underwent revision for symastia with no significant improvement. She underwent repeat revision with an attempt that was unsuccessful to repair her medial right pectoralis major muscle. She then had bilateral bottoming out and had acellular dermal matrix placed in the lower poles through IMF incisions on both sides by another surgeon. So when I met her, the problems that we identified were symastia with pectus excavatum, lateralization of her breast tissue, right Baker grade 3 and left Baker grade 2 capsular contraction, avulsion of her medial right pectoralis major muscle, and I didn't know where her ADM was in the pocket. So a great trick with saline implants that many of you know is to be able to deflate them and get a sense of what the soft tissue envelope is. And so we did this with a plan for autologous fat grafting alone in her. And she had 1.1 liters of tumescence, 1.3 liter total aspirate, which resulted in 210 cc's of fat after processing. And so she had 130 cc's placed in the right breast and 80 in the left breast and bilateral periareolar mastopexies, and a result that I thought was acceptable given where she started, and that I thought with a little bit more fat, if we could find it, and potentially some further skin envelope modification, she could get a good result. However, she ultimately decided she wanted to go on to have augmentation again. And this is her after placement of textured Siltex textured implants in a neo-subpectoral pocket, which shows the power of the fat grafting, I think, in terms of improving the soft tissue envelope. So fat grafting alone can be used for revision breast augmentation, obviously in many ways. As I said, I think that the technique will depend on the goals and user preference. And the technique I presented here is of much more moderate volumes and allows improvement in implant contour and decreased implant visibility, and essentially a supporting cast, as has been alluded to previously. Moving on to mesh and ADM. Situations where ADM and mesh have been useful in revision surgery include soft tissue deficiency, so medially for symastia, bottoming out, infralateral displacement, and then potentially for gland support. There's some evidence that certainly ADM may be beneficial in capsular contracture. Both can affect or positively affect rippling and implant show, and ADMs may have a role in the setting of radiation. Prior to having ADMs and mesh, we used neopockets, capsulorrhaphy, capsular flaps, and capsulectomies. And all of these remain very powerful tools that we can use in conjunction with ADM. Just to review some of the general techniques, most of you are familiar with this being the reconstructive technique, which basically uses a large piece of either mesh or ADM to cover the entire lower pole of a device from the inferior border of the pectoralis major muscle or the anterior aspect of the gland or capsule all the way back to the chest wall. You can use a much smaller piece and use it just to buttress your repair of a capsulorrhaphy, for example. And then you can also use a French seam approach. Poly-4-hydroxybutyrate or PRHB mesh is something that I've been using a lot lately. It is available widely in the United States. Where I'm from in Canada, it is not widely available yet, and I don't know if it's available in Europe. It is an off-label use in Canada of this product, and it requires Health Canada approval under special access for each patient. This is just an example of one of the manufacturers. In fact, it's the only manufacturer I'm aware of, but they come in prefabricated contoured pieces, which are amenable for breast surgery. It's a monofilament open pore woven mesh. It resorbs by hydrolysis. It has 70% strength still at 12 weeks and lasts 18 to 24 months total, and is replaced by native collagen as it resorbs, and it is significantly less expensive than ADM. The uses are similar to ADM in terms of soft tissue support. It provides support of the lower pole with implant malposition, correction of symastia, pocket control, support of the gland with mastopexy, and also correction of double bubble. And this is simply a case of supporting inferior descent or bottoming out with the mesh in place and then wrapped around the implant enclosure and a 1-year stable result. This is a patient of mine. This is one of those I should have known better cases. This is a patient who had previous transaxillary subpectoral saline augmentation and wanted her breast larger and her areola smaller, which are contradictory goals. And she underwent bilateral periareolar mastopexy and revision augmentation with extra projection 650-gram implants, which looked great at 1 month and looked predictable at 6 months with large areola and the inferior descent of her implants. And she also had one of her devices flip over. This just shows her significant pectus deformity, which I did not appreciate preoperatively without implants in. And so she underwent bilateral mastopexies using mesh with a smaller, less projecting implant. And this is her at 2 weeks, and this has been maintained with stable position. There's a similar patient, 450 cc saline implants filled to 500 in 2010. She had infralateral displacement and wanted to have her breast position improved as well as her breast shape while maintaining similar size. And so she had bilateral lateral popcorn capsulorrhaphies with mesh in the gutters laterally and inferiorly to support the lower pole. And this is her at 14 months with a stable result. Complex hybrid revision augmentation, as I mentioned, that's where I think we need to use mesh and fat to optimize revisional breast surgery. These are often the most complex cases that require all the tools that we have, and they draw on many techniques used in breast reconstruction. And many of these patients are referred to as breast cripples. So this is a patient who had pre-pectoral saline augmentation 20 years ago, multiple revisions with subpectoral silicone up to 500 cc's on a small frame, mostly through periareolar incisions, as well as inframammary fold incisions. She underwent explantation and total capsulectomies in 2018 and is bothered by the tethering scars and volume and shape. And you can see her IMS scars are way down on her upper abdomen. She underwent extensive fat grafting from her posterior trunk, medial, and lateral thighs, which resulted in only 150 cc's of pure fat, so 75 cc's per side. I released her scars to use a small piece of ADM in the lower pole on the right side to further support the soft tissue. And she had periareolar mastopexies to try and tighten up the skin envelope. And that's where she got to, which again, I think with a bit more fat, if possible, may have been an acceptable result, but not one that she was comfortable with. And so we then proceeded to do revision breast augmentation using acellular dermal matrix with a full reconstructive lower pole sling. And this is her at 6 months with significant improvement. Her left pocket is slightly less expanded, but it's not really bothersome to her. And finally, this is a 55-year-old woman who had bilateral augmentation in the past with a revision in 2018 in Thailand. She divided a seroma 1 year postoperatively and saw her original surgeon, who did not do any kind of investigation and made the incorrect assumption that she had ALCL. And he then went on to do what were essentially partial nipple-sparing mastectomies and replaced her implants with high-profile 400-gram smooth silicone implants. Her subsequent pathology was normal with no evidence of ALCL. And when I first met her, this is what she looked like at the beginning of February 2018. She had extremely thin soft tissue in both lower poles, worse on the medial left. And then within 2 weeks, as we were coming up with a plan, her implant became exposed, requiring removal. And this is what she looked like. And that soft tissue on the left side is extremely thin and tethered to her chest wall. So as you all know, fat can not only add volume and soft tissue coverage, but there's good evidence that it improves the quality of soft tissue. And this in original work was done by Dr. Rigotti, who demonstrated that adipocyte-derived stem cells could heal radiation-damaged tissue. So she underwent extensive fat grafting, not so much for soft tissue, but to try and improve the quality of the tissue on the left side, and then had a tissue expander and a cellular dermal matrix placed and fully expanded. And this is her after the tissue expander is expanded. And then she went exchange to a smooth silicone implant with revision on the right side with ADM and an implant as well. And she has, this is stable and soft. So in summary, hybrid breast augmentation involves the use of materials in addition to an implant. Simple hybrid breast augmentation may involve the use of fat alone for shaping, contour, implant coverage, improvement in soft tissue, or ADM and mesh for implant support. Complex hybrid augmentation involves use of both of these tools, often in complicated salvage augmentation that can be similar to breast reconstruction. And use of these tools allows us to achieve stable results in revisional and complicated cases. Thank you. This is skiing in British Columbia where I live. So if any of you ever find yourselves in my part of the world, please let me know.
We're just finishing up here in Rome. You're the last presentation, but we've got time for some questions. Any questions from the audience?
Great talk, thank you so much. I just wonder about the Galaflex experience around implants. I've had some amazing results with Mastopexy only, but I've had some very poor results around implants, and I now no longer use it around an implant. I wonder if you use it direct on the implant, because we don't really understand that interface, or whether you close the capsule and put it to support the capsule outside of the pocket.
I generally use it directly against the implant inside the capsule if I can keep the capsule as a further support. I haven't had, knock on wood, any negative experiences yet with Galaflex adjacent to implants. And the big advantage compared to using ADM is the lack of seroma formation, not needing to use drains. So I haven't had any negative experiences yet. It is more difficult to handle intraoperatively than certainly ADM is.
Other questions? Peter, how often do you do fat injection at the time of a primary breast augmentation?
I'm starting to do it more and more. I think the experience of, I've been following the talks this morning for me, this evening for you, and I'm using it more and more. I think the move to smaller implants and certainly the subfascial plane, Vancouver's got a very athletic environment as well, and so the subpectoral or dual plane for a lot of people is problematic, and so it's an area that I think I'm doing more, and I'm happy with the results so far.
Hello, Dr. Lennox. Thank you. May I ask you, do you switch and change pocket when you do revision breast augmentation? Change from submuscular to prepectoral, or the way around?
Do sometimes. I don't, I was taught in the era of if you have, for example, capsular contracture in one pocket, then you should try switching to the other one. I don't think that's necessarily true anymore. The use of ADM and the other adjuncts, fat things that we've talked about have helped improve that. So I generally will go with the pocket that I think is going to give the best result based on the patient's anatomy and how they're presenting. And if it means staying in the same pocket, I'll do that. I don't hesitate to switch pockets if I think that would work better.
Okay, good. I think we're done. Thank you.
Thank you. Thank you, Peter, to join us. So now I must apologize to ruin your day in Rome with such a long working day. If you expected to come on a nice city and a holiday and good time, I'm very sorry for you. But I'm very happy because thanks to the faculty and thanks to the excellent moderation and presentation of the papers, today we had more than 1,300 followers on the meeting. So I'm very happy, and thanks very much to the faculty. I give the microphone to my co-president, Mark.
Thank you very much. I know this is the last time to make any kind of speech when we're standing between you and dinner. So we hope to see you first thing in the morning for another fully packed day. Thank you for your interest today. Have a good night.